Morning, Joe. Good morning, Rita.
Morning.
Good morning, Joe. Can you hear me?
Morning. Yep.
Okay, I just wanted to check and make sure you saw my email about screen sharing for Pastor George.
Yes, you should be able to share your screen now.
Okay. Good morning, everyone else.
Morning, Kelly.
Morning, Kelly.
Morning. Morning, Rita.
Hi, Rita. It's Avella from still remember ECMC and working together.
Good morning, Arvella. Good morning, Dr. Lesse.
Morning, Alan.
Oh, good morning. Sorry, I had my mic on mute. Good morning, Rita.
Good morning, Pastor George.
Good morning.
Good morning.
It'll be a great day.
Yeah.
How's everybody this morning? Pastor George, Rita.
Well, good morning, everyone.
Good
All is well.
Morning.
But Tim, you put a tie on this morning, huh?
Well, special occasion.
Old habits die hard with us.
Yeah.
Yeah.
It looks very nice.
Yeah, you do.
And read it. Well, your whole setting looks like you're on TV. You know, those beautiful backgrounds.
I did my best. I'm in my dining room. Cleared off the serving table.
Yeah, it spun a few things around on our table as well.
Good morning, Dr. Tripathi.
Good morning. Good morning.
Thanks for joining us this morning. Really appreciate that.
Thank you. Thank you.
You're all in.
We are all in.
Yeah, all right, great.
Hi, Tim. How are you?
Morning. Real good, thank you. How are you?
Good morning, Henry.
Good morning. How are you this morning?
Good, good.
Good morning, President. I'm reminded of the side of the table that you sat on. Good morning.
I know. You know, the table on the screen is kind of weird. It's you don't know where one is sitting here. Everyone has a different view.
Yeah.
We're all on the same side today. That's a beautiful thing.
That's great. Yeah.
We all opted in.
Yeah. It's a beautiful morning. Sun is out.
Oh, I know.
Yes, indeed.
Good morning, everyone. Welcome to the 2020 Igniting Hope Conference. As you all are logging in, we just want you to be comfortable today. You are more than welcome to put your video on or leave it off. We will be recording this larger group session. So if you don't want your face on the video, keep your video off. If you are having streaming problems, if you've been on other Zoom calls or other video conferencing calls and you get some choppy internet sometimes, you'll generally receive better service if you turn your video off. We want you to be fully engaged as much as you want to be, but we also want to make sure that you're able to hear everything clearly, receive all of the information that will be coming forth from our presenters today. We encourage you to use the chat function. As you do that, if you are not familiar with Zoom, chat is going to be at the bottom of your Zoom window. If you click the button that says chat, you can chat to everyone. You can chat to any of our presenters or anyone else that is in the room. My suggestion would be to send your questions or comments either to everyone or to myself. I am Kelly Marie Wolford. That way we can make sure that they're addressed. And if you have something for one of the presenters, I can make sure that that question gets to them. We will be starting shortly. Welcome to Igniting Hope Conference 2020. Good morning, everyone. Welcome to Igniting Hope Conference 2020. I am Kelly Marie Wolford, Director of Community Relations at Erie County Medical Center. We are going to be getting started in just 2 minutes. I want to do some quick housekeeping. Our schedule is jam-packed, so we will be keeping in accordance to our agenda. If you have any questions for our presenters, please put them in the chat box. We ask that everyone remain on mute. Even if you think your background is quiet, if you could just make sure that your mute button stays on throughout the course of the day, unless we've opened up the time for direct communication. We are recording, so if you would not like to be in the recording, please turn your video off. It is not likely that your face will be shown. However, we want to make sure that you are most comfortable. We also want you to, self-regulate. If you need to grab a cup of tea or coffee, this is breakfast time. If you have cereal for breakfast, grab your cereal and join us for the conference today. We welcome you. We look forward to working with you, not just today, but for the rest of the year. For the rest of the movement, which is going to be much more than the year. Welcome to Igniting Hope 2020. We will be starting the conference in just a few moments. Good morning, everyone. Welcome to Igniting Hope Conference 2020. Just a few quick housekeeping points before we start our day. We are recording the conference today, this larger room session. So please, if you are uncomfortable, please turn your video off. That is an option that you have available to you. Also, if you generally experience choppy internet service or unstable connection, if you turn your video off, you will generally have a better internet connection to receive the information that's being presented today. We encourage you to use the chat box, not just to chat with each other, but to send questions over to our presenters, not only in this Zoom meeting, but in our breakout sessions. All of the links for the breakout sessions will be in the chat box. We don't want you to have to dig for any information. So we'll make sure everything is available for you in the chat feature. If you have any questions, again, place them in the chat. If you have a question you would ask privately, feel free to send them directly to me. Again, my name is Kelly Marie Wolford. If you go into the chat feature, at the bottom of the chat, there is a 2 option. If you click on that down arrow that says everyone right now and scroll down to Kelly Marie Wolford, you can send a private message directly to me. Thank you all for joining us. We will be starting right now. Tim, I turn it over to you.
Thank you so much, Kelly. Good morning, everyone. It is a great pleasure to welcome you to the 3rd annual Igniting Hope Conference. Our conference this year is entitled Mobilizing Community Resources to Achieve Health Equity During a Global Pandemic. My name is Timothy Murphy, and I'm SUNY Distinguished Professor in the Jacobs School of Medicine and Biomedical Sciences, and I'm Director of the Clinical and Translational Science Institute and also the Community Health Equity Research Institute. You may notice if you've been to our previous conferences, there is a little bit of difference this year. One is we're in the middle of a global pandemic, and another is that we're holding our meeting remotely instead of in person, where we held it in the Jacobs School for the last 2 years. But I would argue that there are more similarities to this meeting than differences from previous years. One, we have a room full of people from the community and from the university willing to commit a Saturday in the summer to learning about and working together to find solutions to the health disparities that exist in people of color in Buffalo. We have a room full of people who bring innovative solutions and big ideas to this problem. And we have a room full of people who are passionate about achieving health equity in our community. And that's what we're here to talk about today and to learn about today and to brainstorm about today. To start our meeting, it is my great pleasure to introduce the 15th president of the University at Buffalo, President Satish Tripathi.
Thank you, Tim, and good morning, everyone. I'm so pleased to be with all of you today as you engage in this important and timely discussion. We at UB are proud to be co-hosting today's conference with our community partners, and we're grateful for your long-standing commitment to create a real and measurable progress towards health equity in Buffalo. The subject could not be more pressing in our present moment. Although health inequities have been embedded in our countries for centuries, the COVID-19 pandemic has brought them into sharp relief. Earlier this week, the New York Times article cited a survey from 2011 that found only 55% of white Americans knew about inequities in Black and white health, compared with 89% of Black Americans. Today, it would be very hard for any American not to recognize this unsettling reality. Every day, new statistics and stories underscored COVID-19's disproportionate impact on communities of color. Each one tells us that our Black, Hispanic, and Native American neighbors are more likely to contract the coronavirus, be hospitalized as a result, and die from it. This public health crisis has created a moment of reckoning for our country as we grapple with social injustice and structural racism. At the same time, it is creating an opportunity for genuine societal transformation, as your work today illustrates. At UB, the pandemic has amplified our call to dismantle health inequities so that all of our neighbors have the right to a bright, healthy future. Alongside our community partners, we have been working to realize this ideal since well before COVID-19 entered the conversation. Last year, we formalized this partnership when we launched UB's Community Health Equity Research Institute. This institute leverages UB's research, scholarship, and community engagement for the greater good, which is a cornerstone of our mission as a public research university. Today, many of our faculty, researchers, and clinicians are playing key roles in the response to COVID-19, particularly as it relates to healthcare disparities. During these uncertain and turbulent times, it is so inspiring to see our UB faculty working alongside our community partners to address injustice and build a healthier, stronger, more vibrant region. Many thanks to all of today's speakers and our community partners for your critical work in this regard. All my best for a most productive conference. Thank you.
Thank you so much, President Tripathi, for joining us and for your support. Now I'd like to show a short video about the institute that President Tripathi just talked about, the Community Health Equity Research Institute, and our important partnership with the Buffalo Center for Health Equity.
Joe, we don't have any sound. Can you restart with volume?
For far too long, African Americans across our nation, our state, our region, and right here in Buffalo have suffered from the devastating impacts of racially based health disparities.
African Americans who live in the inner city of Buffalo, they're going to live about 12 years less than whites who live in other communities. All the medical science is showing us, and the data is showing us, that it's the social determinants of health. It's the living environment. It's the economic situation. It's the access to quality education. It's the access to fresh fruits and vegetables. And all these things are a real problem in our community.
There is diabetes in my family. There is heart disease in my family. This is my history.
The east side of Buffalo has been unfortunately overlooked for decades, but the University of Buffalo embraced the obstacle at hand and said it is time to engage and to fix these disparities once and for all.
It's a great pleasure to introduce a UB Institute that we anticipate will have an enormous impact in our city and for our neighbors, the Community Health Equity Research Institute. The mission of the UB Community Health Equity Research Institute is to perform research to understand the root causes of health disparities and also to develop and test innovative solutions to address these pressing problems in our community.
We challenge UB to use the brilliance contained within their schools of medicine, nursing, education, urban studies, business, social work, and other disciplines to do something that some may believe cannot be done.
By advancing a culture of equity across our region, Buffalo will be known not only as the city of good neighbors, but a city where each of our neighbors, regardless of skin color or socioeconomic status, can achieve optimal health.
You've already done the huge step. You've acknowledged what the problem is. Now you're going to come to us soon and tell us what the solution is and how it's going to get implemented in Buffalo.
We have some unique approaches in Buffalo, and we have talent and expertise in Buffalo where we have an opportunity to become national leaders in this area.
So today we find ourselves at the start of a new journey that will lead us to having a generational impact on the health of all those who live in our region.
All right, I'll say one more thing before we get right into our program today, and that is that the NIH has now supported this conference for the next 3 years. And I think that a very important part of our being able to compete and win that award is the partnership that we have between the community and the university. And that's a model that we are building on and intend to build on. I'd also like to give a special welcome to Dr. Erica Roseman, who's on the meeting. She is at NIH and she was instrumental for us in getting this grant and has been tremendously supportive for all of our efforts. So welcome, Dr. Roseman. It's now my pleasure to introduce Rita Hubbard Robinson. Rita is chair of the conference of this planning committee, and Rita and Kelly, who you've heard from, have been absolutely passionate and instrumental behind the scenes in making this meeting happen. Rita earned her Doctor of Jurisprudence from the University of Buffalo. Not only does Rita work behind the scenes, she is a visionary community leader who's committed to the improvement of health and social determinants of health for over 30 years. She's won many awards for her work. She's founder and CEO of New Water Associates, LLC, and host of the very popular weekly Millennium Health Matters radio show. Rita.
Oh, hello, everyone. Good morning. So glad to be with you here today. We're just, you know, it's very nice when your vision becomes real. And there are just so many people. I was swiping to the right, and there are just so many people on this meeting this morning. I just want to welcome you all. On behalf of the Center for Health Equity and the African American Health Equity Task Force, I just want to welcome all of you. I want to thank out loud the WUFO Power 96.5 for being our media sponsor, the Racial and Ethnic Approaches to Community Health project funded by the CDC at Chickatelli and Associates for their community support throughout the year and also at this conference. I'd like to also recognize the funding from the National Institute of Health. Our dear Timothy just mentioned them, but I wanted to also express the center and the task force's a deep appreciation for recognizing this important relationship between the university and the community, and how this will really help us to move forward with the movement. I'd like to also thank our partners, the Center for Translational Sciences Institute and the UB Community Health Equity Research Institute. I want to recognize also the deep volunteerism that this conference represents in the various UB departments, our dear President Tripathi, his leadership, and the leadership of all of the department heads and all of the schools that are part of the University at Buffalo. I want to give a strong shout out to what I've called the student resource teams that will be leading the breakout sessions, for their time and commitment during the week to pull up Zooms, to meet with me, to meet with our IT team, to work with one another offline with sharing information, cell numbers, so that they can do the backdrop work necessary so that we can have a smooth and successful day. I also wanted to just raise this thought to all of you. Some say that science should not be personal, but we're asking you today to bring your personal to this space. Certainly the pandemic is giving us a new perspective on science, and how science has really been distorted in some ways, but risen to a new and high level in the way that we conduct ourselves on a daily basis. We're just so glad that you've decided to be here today. There's so many things that you could be doing with your time, but you've decided to be with us and to spend time with us on these important issues, issues that directly impact the lives of persons of color and all of us, because really we are all in this together. With the backdrop of the impact of social determinants of health on our community, on our life, even with the loss of George Floyd, all of these things coming together at this time, I don't see as a mistake. They are really, this is our learning time. We're all sort of dormed in our houses now, and really focused on ourselves and our community. So I'm so glad that we have great leadership in this city. We've been able to do some miraculous things over the last year, including the standing up of our institute and our Center for Health Equity. And we're just elated for the leadership of our own Reverend George F. Nicholas. He doesn't even like to be called Reverend. He's a servant leader. He doesn't feel he should be revered, but we want to acknowledge him today and introduce you to him at this time. He's the convener of the African American Health Equity Task Force. He's the chair of the Buffalo Center for Health Equity. He's the pastor of Lincoln Memorial United Methodist Church in Buffalo. He's also a member of the Racial Equity Task Force and the Concerned Clergy Coalition. He's also a friend. He's also a friend to our city. I'd like to, at this time, introduce our esteemed leader, none other than George F. Nicholas. Thank you.
Good morning, Rita. Thank you so much for that just very, very kind introduction. Thank you, all of you who have, again, taken your time this morning to join us as we continue to work towards our goal of eliminating race-based health inequity in this region. Kelly, if you could go to our slides, and we'll get right to work. We have, I'll be speaking on behalf of the Buffalo Center for Health Equity, which we have stood up as an independent 501c3 and 501c4 organization that will be focusing specifically, as we talked about, our goal of eliminating race-based health disparities. We don't believe that your race should be a determining factor upon your health. Next slide, Kelly. And one of the things that people must always understand is, you know, I guess have been chosen in some ways to lead this work from the community side. And when I say lead, just convene, just the one to kind of send out the call. And it's not an addendum to my work or my call as a minister or as a pastor. And so our work is very much grounded in science, as Rita says, but but through working together with our team, there's been a mighty coming together of ourselves as people. I like this symbol here. It's a West African Adinkra symbol that means it's a symbol of hope. And it says that God is in the heavens. And this is a reminder that God's dwelling place is in the heavens, where he's listening to our prayers. And a lot of things that we have been able to achieve over the last 5 or 6 years that has been done by a lot of hard work, but there has been some things that have helped us in the celestial places, and mainly through the relationship building. And so this is a movement. We're not really just starting an organization per se in the traditional sense, but it's very much something that's deeply rooted in not only our intellect, but also into our hearts and our minds. Next slide, Kelly, please. And so we declared last year that we are moving from health disparities to health equity. We felt it was very important for us to begin to start talking aspirationally about where do we see our community going. And so our goal is having that sense of health equity. I'd like to send out a shout out to Idris, who one of the great artists here in not only just Western New York, but one of the great artists I've ever known, to be honest with you. And he has developed this wonderful symbol, logo for us that you see here for the Center for Health Equity. And you see it's a tree. And the roots there are, dealing with the root causes, but the strength of a tree. And when trees are so important in terms of a life-giving source for communities. And what the top there, us coming together, intersecting, bringing all the things, all the factors, the social determinants of health to begin to start bringing a healthy community. Kelly, please. What is health equity? It's very important that we understand what we're talking about. One of the things that, Dr. King, one of his great challenges during the tail end of his journey was working with liberals, be honest with you, who were so excited about celebrating progress. And I think we should celebrate progress, but understand progress is not there should not be such a huge disparity from those are white friends and neighbors who live outside of our community. And we know from our study, our data, if you go onto our website, COVID-19 revealed these health inequities. So we want to make sure that we all understand what health equity is and that we're all working for the same goal. And health equity is achieved when every person has the opportunity to attain his or her full health potential. And no one is disadvantaged from achieving this potential because of a social position or other social determined circumstances. Health inequities are reflected in differences in length of life, quality of life, rates of disease, disability, and death, severity of disease, and access to treatment. And one of the primary goals of the CDC, the National Center for Chronic Disease Prevention and Health Promotion, is to achieve health equity by eliminating health disparities and achieving optimal health for all Americans. So there are organizations, nationally, right? Everyone is really saying health equity is something that is important for our nation. And certainly as we talk about Western New York and what we want to do in Western New York, if we want to be in that place where we have true revival and true resurgence, it's not only reflected in the expansion of downtown, waterfront, even the wonderful medical school that we have at the University of Buffalo now, but the real measurement is the quality of health of all citizens, especially those who have been suffering from poor health for many generations. Next slide, Kelly, please. When we gathered, we have a great team called the African American Health Equity Task Force, and where many people from like Dr. Murphy, Dr. Grinsley, and others are part of our team, Dr. Taylor, and I don't know if I start naming people, I'll forget people. And so we have folks that have come together. We've been meeting with great consistency, even through this pandemic, right? That, you know, we're grateful for Zoom. And so we've been able to, even throughout this pandemic, we have been able to continue doing our work. And we had, before COVID-19, we had a tremendous, I don't like to use the word retreat, because retreat speaks to moving forward, moving backwards, excuse me, and we're moving forward. And so we had a day apart where many of us spent an entire day just talking about planning, developing strategies to how do we move this work forward. And as you see there, these are some of the words that came up. And what I really want you to focus on, and you see one of the larger words there is community. Community. It is essential. It is essential that in order for us to be successful in achieving health equity in this region and in this nation, there has to be true collaborative partnerships. We have to obliterate these lines of division between institutions like the University of Buffalo, like ECMC, like Kaleida Health, like Blue Cross and Blue Shield, and community-based organizations, and block clubs, and community artists, and community musicians, and just everyday citizens, right? There has to be a table that is created. And as you look at these words, you see these words, and this came from conversation with community members and institutional leaders as we figured out how do we focus, how do we develop a plan moving forward to achieve health equity. Next slide, please. And so one of the things that we're going to do through this Buffalo Center for Health Equity is we focused on 5 pillars. So these 5 pillars will give us focus and clarity on how we want to advance our work. And so you see in the center there, the strategy and operations, right? But the 5 pillars that will drive our work, one will be research. Now research, well, certainly a lot of research will be done by the Institute at the University of Buffalo, but this Buffalo Center will engage in different levels of research. Research it can be, operates at many different levels. I mean, getting a block club to go out and go door to door and just have conversations with people about the conditions of their neighborhoods, that's research, right? And so research does not always have to be big, elaborate processes. Those are good, and we support those, but there's all kinds of research, and we want to focus on kind of really a lot of grassroots and neighborhood research. But that pillar, that's going to be a great place of intersection with the Institute at the University of Buffalo. Then we'll talk about neighborhood development. This is something that Dr. Taylor continues to put in front of us, that we cannot change the lives of people unless we change the communities or their lived environments. Right. So part of the approach to bringing health equity in the Black community is to increase or to enhance the livable spaces within those communities, the housing stock, the safety of these communities, the economic condition of these communities. So it's not just when we talk about health equity, and you guys know this, it's not just what goes on inside the patient room between a doctor and a patient, but it's that community and where that patient lives. And we know that in the African-American community, there are some severe problems as it relates to air and water quality, right? We have on the east side of Buffalo what they call a cancer zone or what have you. And so the neighborhood development is critical. Now, underneath there, community engagement. One of the guiding principles of our work is that we believe people at the neighborhood level know what they need, and they know how institutions can help them, right? And so there has to be real community engagement. One of the problems that we've had historically is that when institutions or other entities, municipalities, when they engage in conversations with people at the neighborhood level, and then when neighborhood people tell them they need X, and then here comes government, here comes institution giving them Y. And then they say, well, wait a second. No, we said these are the things that we need to change to improve the quality of life in our neighborhoods. And yet you ignored what we told you because you had your preconceived notions of what you wanted to do. So we want to have real, authentic community engagement. The next one is advocacy and communication. One of the worst things you can do for a community is ask them, how can we help you? And they tell you, and then you don't do anything to help them. Right? And so we have to use, many of us have spheres, all of us have some sphere of influence, right? And so what we want to do is an institution like a university, a hospital, a healthcare concern, government, they have to begin to take the information that comes from community and not just let it sit dormant, but to advocate and keep the dialogue and the conversation going. And so advocacy is going to be a very important part of our work as the Buffalo Center to say that, you know, in order to do neighborhood development, these laws need to change or certain things need to happen. We're going to advocate for that. And then the final pillar is policy. We believe this, that research will give you data. And then from the data, then policy is developed. And then once the policy is developed, then resources are released, right? And so we want to do the research, right? Get the data from the research, take the information that we're getting through our community engagement, right? And then work with policymakers to create policy and then invest resources into changing the conditions of the community in which we are serving. So these are the pillars. The next ones are core values. We operate in not a hierarchical model. And when I talk about we, I'm talking about the task force and the Health Equity Center. And these are some of our guiding principles. We embrace all humanity, right? When we think about those pillars, we're trying to create spaces to have real conversation, but we want to embrace and honor everyone at the table and to honor their desires. Everyone has a desire to live healthy and whole, right? And so we want to honor that too. Health equity is a right, right? This is the World Health Organization determined that the access to quality health is a human right, right? And in order to have these rights to be operating at its highest level, there has to be the elimination of social and economic disparities. 3, social and cultural awareness, centering on race. One of the things that we're very clear on with our Buffalo Center for Health Equity, that our focus is around African-American health. Does that mean that we don't care about other people's health? No, but because of the unique story of African people in America brought under circumstances of being kidnapped, enslaved, and always have to this day continuing just to achieve our basic human rights, there has to be a very narrow focus and targeted work around that. So we're unapologetic about talking about race. Number 4, inclusivity. We want to be inclusive of everyone that is in our community and around our community, and accountability. You know, I've told people, I've spoken to many places publicly, hold me accountable. If I'm going to be, you know, people are going to put my name on the marquee, then hold me accountable. Hold our organizations accountable for bringing change. You know, one of the biggest problems we have at 1600 Pennsylvania Avenue right now is the lack of accountability. You can't be a leader and not be accountable, right? And so accountability is key, and then humility. We're all come at a model of being servant leaders. You know, we cannot just continue just to tell folks what to do. We got to be willing to serve them. The next slide, Kelly. Here are areas in which we have been working. Many of you participated in workshops last year at our last Igniting Hope conference. And these are the areas that we have been working on around our Health Equity Center. This year, here's what we've gotten done. We participated, and Dr. Murphy and I participated in a testimony with the New York State, and we helped spur that, you know, through conversations with Senator Kennedy and Senator Rivera, who's the chair of the Health Committee for the Senate. We have helped kind of spur a statewide conversation around health equity. And certainly Dr. Murphy and I, and to be real honest with you, I'll pat ourselves on the back. Our testimonies were one of the best because we focused on the issue. A lot of people came in just grousing about the conditions, but we had a vision on moving forward. One of our groups that we've been working with is the fines and fees, the disproportionate numbers of African Americans who have been getting ticketed on the east side of Buffalo for tinted windows and stuff like that. Well, the mayor just recently announced that he's going to push to eliminate 14 of those fines and fees because they were creating an economic hardship in that very same community where you had some of the highest numbers of health disparities. The COVID-19 project, and let me just spend about 30 seconds on that. I know my time is running over a little bit. And Dr. Vazquez will give you this information in great detail. But through our leadership, and specifically Reverend Kinzer Pointer, working with the ECMC and the DISRIP, we were able to stand up a project called the COVID response team. And this team, we have called probably over 100,000 people within our community. We have connected people with access to testing and treatment and what have you. And it's a model that the rest of the nation is taking note of. And I want to show you a chart on that real quickly. And then we just completed as Dr. Murphy spoke of, we have a 3-year NIH grant to continue our conferencing. And then we just completed a very important and I think transformative application to do a project in collaboration with the university to really do a robust work around COVID-19. Kelly, why don't you go to, because we're running a little late time, go to the chart, please. When we, and I'm going to close with this story real quickly. When COVID-19 began to emerge in our country, we knew, because of our prior work around the social determinants of health and the pre-existing conditions of so many people in the African American community, that when it hit, it would hit Black Buffalo harder than anywhere else. But then we also saw some of the first places that were standing up testing sites were not in the inner city. So that was problematic. We reached out to the county executive and the health commissioner and others and said, listen, we need to have some very intentional actions around COVID-19 in the inner city. No, not a criticism of them, but there was so much going on. They weren't really kind of prepared for that in their thinking. So we said, well, we'll give you a project, we'll give you a vision, we'll give you a path forward, and we'll bring other collaborative partners in, and we'll work on this together. If you look at the chart there, if you think about nationally, the national numbers today show that African Americans are dying, the fatality rates in communities at about 2.5 to 3 times over their population rate within a community. So, for example, in Erie County, where the African American population is 14.6%, the early trends, as you see, April 8th, we were trending right at that spot, 33.3%. So 33% of the deaths, fatalities of COVID-19 were attributed to the Black community, where there were only 14.6% of the population. That is a trend that's pretty consistent all across this nation. But look at the chart. Look at that chart. You see that those numbers have been steadily going down, and the latest data that we have recorded on here, but we have other data from this slide, is we're right at the population rate. We're one of the few cities or regions in America that can say that, and that's 100% due to the collaborative work that we have been doing in this community. It's 100% due to the leadership of people like Dr. Vazquez and our other partners. Look at all of our partners that we have there. And if we can come together around COVID-19, a crisis, and get something done, then imagine if we stay at the table and begin to start looking at the root causes or the things that are driving those numbers. That's our goal. That is our goal. We are community driven. We're committed to structural change. We're going to address root causes. We're committed to changing the narrative, cultivating inclusivity, and raising consciousness, right? By bringing everybody around the table, not ignoring the issues of race, but talking about those things, but beginning to bring forth a systemic change for this community. So at that, I'm going to stop because we have so many great people that you need to hear from, and you can hear from me anytime because I'm not going anywhere. But I appreciate all of you, and thank you, and have a great day. And thank you for being with us this morning.
Thank you so much, Pastor Nicholas, for those inspiring comments. And I think that last achievement driven by community efforts and carried out by the community is really remarkable and speaks in very important ways and with regard to what the community and what these collaborations are doing to have a true impact. All right, it is now my great pleasure to introduce our first keynote speaker, Dr. Alan Lesse. Dr. Lesse earned his MD from University of Virginia, did his residency in internal medicine at Temple University, and then fellowships, both clinical and research fellowships in infectious diseases at the University of Virginia. We were fortunate that he joined the University of Buffalo faculty, where he's currently associate professor in 3 departments: medicine, pharmacology and toxicology, and microbiology and immunology. And he is also Senior Associate Dean for Medical Curriculum for the Jacobs School of Medicine and Biomedical Science. And this is very important for our discussion here today, in particular, because of the influence that will have on future physicians and how they'll learn and what they will learn. And under his guidance, the curriculum is being transformed so that health disparities and health equity are integrated into every aspect of what students will learn, our future physicians. More than just an occasional lecture, it's really integrated as part of the curriculum with partnership and with input from the community. I can tell you it's a real special privilege for me to introduce Alan because we worked together for 19 years at the Buffalo VA Medical Center. Our offices were next to each other. We saw each other every day, taking care of patients, doing our research, teaching, and so forth. And I can tell you that Dr. Lesse is a compassionate physician, a scholar in infectious diseases, a gifted teacher, and a wonderful colleague and friend. So he's going to talk to us today about the COVID-19 pandemic, a magnifying lens for health disparities. Dr. Lesse.
Tim, thank you very much for that far too kind introduction. It was an enormous pleasure to be able to work with you at the VA. And the VA holds a very special place in my heart for all of the work that we've been able to do there, as well as working together on the Health Equity Task Force. So what I thought I would do today, and hopefully I'll be able to share my screen, is talk a little bit about the COVID-19 pandemic. And I believe that the pandemic really is a magnifying lens for health disparities. It's been my sincere pleasure to have been involved with the conference since the very beginning. And it is one of the great attributes, I think, of the school that it hosted its first conference in August of 2017 or 2018 for the Igniting Hope Conference in our inaugural conference. I'd like, to welcome everybody to this virtual version of the conference. While it's, not in person, it really is not quite the same conference. I think, though, Pastor Pointer and I probably do appreciate the fact that we won't be taking down the tables this afternoon, and I don't have to manage the AV. I thought I'd put in my, health record from the conference last year, where I managed only to be up for 17 hours. And it's a sort of an early start with the 18,000 steps and the 9.3 miles. That's all indoors. So the conference, I think, does take a little bit of work, but it was really good for my calorie count that day. So I'm not complaining. With the few extra pounds that COVID has put on me, I think I could probably use a few more steps these days. I really would like to thank the African American Health Equity Task Force for taking me in and for teaching me. And I'd like to give thanks to, as Dr. Sheehan would say, really an army of 720 motivated, energetic, empathic students who really drive us to be the best that we can be every single day. And to give you an example of what our students are and their passion for this, let me just play a little video for you to give you some idea of who we are working with.
I am a medical student
at the Jacob School of Medicine and Biomedical Sciences at the University of Buffalo.
I stand with my friends,
colleagues, future patients,
and community members
in the fight to acknowledge,
address,
educate about,
and take action.
Take action. Take action
against racism
and discrimination
against people of color.
Systemic racism must be dismantled.
In healthcare and beyond.
It starts with us
Knowing the facts.
Police violence is a leading cause of death
for Black young men in the United States.
Black infants in America are more than twice as likely
to die as white infants.
Studies show some white medical students and residents falsely believe
that Black people feel less pain than whites.
That Black people's blood clots more quickly and that Black skin is thicker than white skin.
African Americans have higher incidences of chronic kidney disease,
heart disease,
and diabetes.
Deaths due to COVID-19 have disproportionately affected
the African American community.
all of these facts and more
contribute to the premature death of African Americans living in the United States.
My name is Sophia Espinosa,
Chelsea Coronaldi,
Andrea Matole,
Jenny
Renee Nelson, Christine Tufaxis,
Dalapo
Widerman,
Ariel
Jonas, Carol
Collins, Olafui.
and racism is a
Racism is a public health issue.
Racism is a public health issue.
and racism is a public health issue.
And while you may think that this is a professional production done by a team of video engineers, this was created and made by our students, to which I think it shows their talent, their compassion, and their drive. So for today, we have a few learning objectives, and as the first speaker, I guess I get the easy part because I don't have to worry about what somebody else has said. So hopefully my speakers that follow, I'm not stepping on any of their toes. By the end of the session, hopefully I'm going to review just a little of the basic biology of the SARS-CoV-2 agent, the etiologic agent of COVID-19. I'm going to review a little bit of the impact of COVID on people of color. I'll describe just in brief the segregation of Buffalo and some of the health disparities that occur due to social injustice, highlight the impact of COVID-19 and the magnifying effect of the pandemic on the inequities seen in Buffalo and Erie County, and then list some of the goals and accomplishments of the African American Health Equity Task Force, the Buffalo Center for Health Equity, and the Buffalo Community Health Equity Research Institute. Nearly everything I'm going to say and show you is the direct work of all of these agencies, and I don't want to take credit for any of these. I'm just sort of here as the reporter. Just very quickly, you can't go to a infectious disease physician's talk without a picture of a virus. So this is the virus, the coronavirus. Normally, coronaviruses are a common cause of colds, the winter cold that we normally have. It does attach to a receptor that's quite common. And coronaviruses prior to this pandemic have caused other major epidemics worldwide. The first that you may remember in 2003 was the SARS virus, and that's where our current agent gets its name. It was from 2003, it was thought to be transmitted by civets, which is this animal over here, once again through Chinese market and the consumption of many different exotic animals. This is a busy slide, but some things that are quite important in the current epidemic. What this worldwide epidemic, not pandemic, occurred because there was a wedding in a hotel in Hong Kong from which people from Vietnam, Singapore, the United States, Ireland, Canada, and China all attended. And it was basically a perfect storm where everybody flew in for this wedding and then redistributed out throughout the rest of the world. You may remember that our friends in Canada had a major problem with the disease, and it occurred in two phases, one of which was the transmission from people from around the world coming back into Canada. And unfortunately, they had a small lapse in their infection control policies. They actually did a phenomenal job, but had a second wave of disease later in the time period. But this disease came and went and has not been seen since the original epidemic, but much of the science that we have now originates from this disease. MERS is the next outbreak. It was in 2013, 2014. It's the Middle Eastern respiratory syndrome, and it's thought to be transmitted to humans through camels. It is slightly more virulent, but there have been far less cases. And one of the reasons why South Korea, and I'll talk about South Korea in a minute, has done so well against the pandemic is that they were one of the major sites of outbreaks of MERS. And so it gave them a little bit of a heads up, and they were much better prepared nationally than the United States. I'm going to take you back for a little bit of history, which now seems like ancient history. This is the December outbreak in Wuhan, and the timeline as it appeared in the New England Journal of Medicine. It's almost nostalgia, even though it's only 8 or 9 months ago, that I looked at these slides and showed that this virus for the original SARS and MERS is in a family of coronaviruses that exist in many different animals. And for a very long period of time, people have known that these, what are called zoonoses, infections that go from animals to humans, pose a major risk of pandemic disease across the world. And unfortunately, that's what we saw in December and January. This virus is a new novel virus that humans have never had immunity to, and so it's easily spread throughout the world. I really like this diagram, and it is one from the New York Times. Many times these days, our best graphics and information come from our reputable sources. And along the x-axis is the relative infectivity of an agent, and along the y-axis is the relative fatality of the disease. So these diseases, MERS, bird flu, avian influenza, and Ebola, are quite deadly, but they're not as infectious as measles, and pertussis would appear over here as well, and chickenpox. So by graphing it in this direction, this new coronavirus, and we don't really know what the numbers are, probably every infection in a human in a susceptible population infects anywhere from 1.5 to 3.5 individuals. Sometimes these are difficult concepts to understand. So this is from the Washington Post, and it looks at the infectivity of this virus. And all you really need to do is follow the pictures. The R0, which is 2.3, so every person infects 2.3 individuals on average. And this R effective is what happens as the disease goes through the community and what happens to the spread of the virus. And so if you just watch this, you'll see an infection in a susceptible population will spread rapidly, and the death rate is somewhat low. Those are the black squares. The infected ones are higher. And as the infection proceeds through the community, you get increasing concentration of people that have recovered. And unfortunately, you also see deaths. So this is the appearance of COVID-19. If we look at measles, please watch very carefully, because this is an R0 of 18. And this shows you what happens when a very infectious virus travels through the community. A few cases, rapid spread and resolution with deaths in the low numbers, but still quite high. If one looks then at what happens with quarantine, which is why we really need to isolate patients, and this is the same disease with an R0 of 2.4, you'll see that if you quarantine the person and don't allow that group to come in contact with susceptible individuals, the total number of cases is limited, and this is the basis for our infection prevention policies to try and quarantine these patients and prevent the disease from spreading in the rest of this community that hopefully at some time will be protected by vaccine. If you want to see, unfortunately, what happens with a disease that has a very high fatality, but a still roughly equal infectivity, this is Ebola. And you'll see that it spreads at about the same rate as the coronavirus, but what you'll also notice, unfortunately, is that it has a much higher lethality, and the number of individuals that succumb to the disease is much higher. So we can be fortunate that the lethality of the SARS, of the COVID-19 is not anywhere near what Ebola is, but its infectivity is high enough that it causes massive disease and worldwide pandemics. As a bit of nostalgia, you might even remember all the way back to January when we were concerned about this massive outbreak in China of 75,000 people, which now seems like a trivial disease. And we had only 35 patients in the United States. And this is the patient in Washington, and at a time in January and February when this occurred, we, at least some in our government, felt that we had this under control. I show you this graph. This comes from our World in Data, and there's a number of excellent websites that anybody can get data from. which shows the cases per million people starting in December of 2019. And I've chosen a few countries for you to look at, but pay close attention to South Korea because they had their first case on exactly the same day that the United States did. And watch what happens, unfortunately. As you'll be able to see, the cases per million people start to bounce around the US at the same time as South Korea. But you'll see that South Korea had a spike and went up to very high numbers that rapidly decreased as the pandemic ravaged both Italy and Germany, and the US lagged behind. But unfortunately, in this horse race, we have the fastest horse. And as you can see, the United States far outstrips the rest of the world. We're now in late June, and now it's a horse race between the United States and Brazil. And unfortunately, we continue to win this race with 16,000 cases per million people, with Brazil close behind, the United Kingdom, Italy, Germany. And notice South Korea. As I said, they had experience with MERS. They had a massive governmental intervention with a centrally planned policy, and they were able to control this pandemic, being infected their first case in the United States on exactly the same day. Policy does matter, and that is something that we must try and correct. For those that think that this disease is merely just amplifying the diseases that exist in the United States and it's not that virulent, let me show you data from the New York Times, and this is from this week. We track deaths across the United States every year, and they follow a relatively stable cyclical pattern. These are excess deaths, excess deaths. We are not talking about a simple case of the flu or something that is just other people are dying with and they're labeling it as COVID-19. These are excess deaths. And if you look in the Northeast, this is the severe New York outbreak. The Middle West and now the West and the South are catching up, and the numbers are actually increasing. So this is a major cause of increased death and mortality in the United States. And so let's take a look then, having that as a background for the disease, let's look at the impact of the COVID epidemic on people of color. And this is data that comes both from JAMA this month in August the 4th, and also some data from the RADX Up grant that was just submitted. Blacks across the United States account for 13% of the population, but nationwide account for 24% of deaths when race is known. Of the first 100 people to die in Chicago, 70 were Black. Blacks make up the highest percentage of our essential workers, and Blacks are more likely not to have an automobile for transportation and use public transportation. And so even if these essential workers are in areas that are of relatively low risk, and surprisingly that's in healthcare centers and hospitals, they must travel frequently on transportation that carries much higher risks of exposure. Blacks are far more likely to live in multi-generational homes and have crowding indices that are far higher than the rest of the population. And they are more likely to live in the urban settings of large cities than in the suburbs. And so all of these factors significantly contribute to the increased propensity for people of color and Blacks to have a much higher risk of infection, and because of associated healthcare conditions such as hypertension, diabetes, obesity, are much more susceptible to poor outcomes than other people in the community. If we take a look at the segregation in Buffalo and the health disparities that exist, many of these exist because of the conditions of social injustice. And I'll take a little tour through the Buffalo data that we looked at to try and highlight some of the problems. And then, as Reverend Nicholas talked about, to also highlight some of the successes that have been seen. So if you look in Buffalo, we have a city that has major health inequities. And I have to continue to correct myself. I frequently say disparities, but these are truly health inequities. The life expectancy of an African American in Buffalo is 5 years shorter compared to the white residents in the city of Buffalo. African Americans in Buffalo have a 50% higher rate of hospitalization and a 25% higher rate of death from coronary artery disease or heart disease. They have a 250% higher rate of hospitalization for diabetes than whites in the community. And they have a 500% higher rate of hospitalization for asthma when compared to the white population in Buffalo. These are damning statistics, and they highlight the problem that we see in Buffalo. The population that we have in Buffalo, as Dr. Murphy has told me, is a population mixture that is going, that people predict will be seen in the rest of the United States in the year 2050. And so Buffalo has the ability to be a center where we can study what happens in urban areas of great diversity. And as it stands right now, we have serious problems that we need to correct. So the African American Health Equity Task Force was founded in 2014 by Pastor George Nicholas and Dr. Willie Underwood. And I was lucky enough to join in 2015 when I became the Senior Associate Dean for Medical Curriculum. And I can say that I learned an enormous amount over that period of time. And the task force looked at health inequities that were concentrated in 6 zip codes on the east side, 14204, 6, 8, 11, 12, and 15. When the COVID pandemic hit the Buffalo area, we had some things in our favor. Unfortunately, the disaster of New York City and the massive effects of the pandemic caused quarantines and shutdown basically across the United States. And that health prevention strategy likely improved the severe mortality in Buffalo by actually having these control measures prior to seeing the severe spike in death and mortality. And so, let me go back. The county, the Erie County Department of Public Health has been tracking the number of cases per zip code. And so we wanted to find out what was happening, and exactly as Pastor Nicholas was talking about, we were seeing, at least to the naked eye, a marked increase in the number of cases of people of color. And so when you look at the zip codes, and I haven't drawn the map in here, but this is the area of the maps that I want you to take a look at. We drew maps of the zip codes up to May of this year and saw this particular pattern. So this is in terms of number of cases, 225 cases down to 25 cases. And this data is restricted for zip codes with 25 or more cases. You'll notice that the zip codes of interest here are not the ones that are highlighted. And anybody taking a look at the maps in the May period would say that, you know, this is the areas that we're concerned about, with the exception of 14215, are not the ones that are most severely affected. However, one really needs to look at this data in terms of cases per 1,000 or 10,000 or some control for the population density. And what you'll clearly see is that as you look at population density, you see a transformation of the data and see that the areas that are of major concern to the Health Equity Task Force are the ones that we're seeing in those zip codes that are severely affected. And if you're wondering why there is a concern here, this is one of the sad legacies of Buffalo, is that if you look at percentage of African Americans, you'll see that as a percentage of the population from 0 to 80%, Buffalo is one of the most segregated populations in the United States. So one can easily map on top of the African American community the severe outcome of number of cases of COVID per 1,000 people. And if one looks at it in a tabular form, and this is sorted from cases per 1,000 population, you'll see 14209, which if you look at the legend, is about 40 to 50% African American and also high population of Latinx. You'll see that in the first 7 zip codes, and this is data as of May 1, please remember, 14208, 14215, 14204, and 14211, 4 of the 7 highest zip codes of cases per 1,000 population existed in this region. But as my good friend, Pastor Pointer points out, one of the goals of the African American Health Equity Institute and the Health Equity Task Force was to basically place boots on the ground. And when this disease first started, as Pastor Nicholas pointed out, the mortality of COVID-19 in Erie County was 38%, while the mortality, while the population was only 16%. So 38% of the mortality in Erie County was accounted for by African Americans, whereas they only comprise 16% of the population. With the help of the $8 million grant that you've heard about from DESRIP, distribution of healthy foods, education regarding COVID, personal protective equipment to homebound individuals, transportation to medical appointments, as well as the 15 churches which form this enormous call center to deliver necessary services to enable shelter to safely stay in place, to visit homes of community members whose telephone numbers were not in the databases. The deaths due to COVID-19 in Erie County are now down to approximately 18% in minorities, which compares very favorably to the 16% of the population that has been seen since March. And as Pastor Nicholas pointed out, this is in distinction to what's seen across the United States. And if you look at the data up to last night, you'll notice that now there are only 3 of the zip codes that are in the top 9 zip codes, and these zip codes are no longer amongst the highest in Buffalo. And so the work of the Health Equity Task Force has been phenomenal, and they are to be congratulated for all of the work that has been done. There's still an enormous amount to do. The causes of inequity in Buffalo exist because of structural racism. And as Dr. Taylor pointed out to me many times, this system has been created that concentrates these disparities, and something really needs to be done. Systems need to be designed to reverse this effect. And we need to have continued vigilance with regard to COVID-19. I'll stop here and thank my lovely wife who you see here She hasn't seen a lot of me since March the 16th when the medical students were pulled off the wards. And we were able to go to the sunflowers of Sanborn very recently, where I was able to comment that not all of the lovely flowers in there have roots. So many thanks to my wife for putting up with me over the last several months. She's been taking care of everything while I spend a little extra time at work. So thank you very much. I really appreciate this opportunity, and I'll be more than happy to try and answer any questions.
Thank you so much, Alan. Let me just say one thing, Kelly, and then you take over, and that is I would like to wish Dr. Lesse a happy birthday on behalf of everyone in this room, and for working on his birthday. Great job.
Thank you.
Happy birthday, Dr. Lesse. I would ask everyone to unmute their phones and sing happy birthday to you, but we're gonna focus on the questions, and maybe we'll have an after party at 3:15 virtually here. So if anyone has any questions for Dr. Lesse, could you please place them in the chat box? We're getting a lot of happy birthdays. I don't know if you see those in there. But we have someone that asked, and it's a really great question and will be addressed in part in our breakout session. Any thoughts regarding schools?
I think it really is possible to send people to school, especially if the case positivity rate in a community is less than 1. The problem that we have is that we are still elevated in Buffalo. If you look at New York State overall, we are less than 1% case positivity rate. And in countries that have great national programs for control of the virus and testing, they've been able to safely send children back to school. I don't think there's a lot of people that would argue that we have a world-class national response to the virus. I think that New York State has been excellent in terms of once we had the large outbreak and the initial problems in New York City, really the rest of the state has benefited. But I think that schools currently, we need to have systems in place. We need to have mitigation. We need to have ability to have proper air handling and spacing. And so if all of those things are in place, I think that that can occur. But that really is almost a case-by-case and school-by-school decision. I think in terms of, you know, would I do it right now in Buffalo? I think it depends on the school and how it can handle the situation.
Thank you. And your next question is, what measures would you say were implemented in Buffalo that helped flatten the curve compared to other cities?
I think it was all of the things that I listed on the slide that the Buffalo Health Equity Institute and the community effort that was done. It really was, I think, the boots on the ground and the ability for, I mean, think about that, calling individuals, and when they knew that they couldn't get a hold of them, actually go to the house to see what they could do for them. The rapid, significant pulse increase in testing in the communities of color, and Dr. Vazquez and the grant that was given, I think, played a major role. And all of those activities, I think, really did flatten the curve.
And Dr. V will be going into more detail about that later on in his keynote, folks. So stay tuned for more information on how the curve was flattened in Buffalo. Your next question, would you talk a little bit more about the underlying reasons for the disproportionate impact of the pandemic in communities of color?
I think that communities of color have those social and structural conditions that are perfect for transmission of the virus, which are high density of population, high rates of exposure because of both the designation of the high percentage of essential workers, which then leads to, household and community spread. We know that individuals that have diabetes, hypertension, coronary disease are at higher risk of poor outcome. And since those diseases exist in the population at higher frequencies in communities of color, then almost by extension, those communities are going to have a worse outcome from spread of the virus. If you want to look at the root cause for why those populations have the higher degrees of mortality and morbidity, then I think you actually have to go all the way back to the concept of structural racism and realize that, the system is designed perfectly to get the results that you see. And the results that we see are one of segregation and higher rates of disease. And so something has to be done about the system to try and correct that.
Our next question comes from an educator. How can schools use this data in returning to school planning? For example, schools with a high population of students from the zip codes that you mentioned in your presentation.
I think this data is just extracted from the county data. Rates of positivity are difficult because I don't know how many people are tested per zip code. That particular information is more difficult to obtain, but I think that it would be possible to look at rates per zip code to give yourself a little bit better understanding of what's happening in that location. But we all know even within certain zip codes, there's a wide variety of and a very heterogeneous mix of populations, social structures, and population density. So even, trying to generalize to zip codes, I think if the overall community spread is, at that 1%, and that's sort of an arbitrary number, 1% or lower of the cases, then I think that it's safer. Nothing is absolute. I think that's the other thing that most people have difficulty with, that there is nothing that's absolute about any of this. It's all risk benefit. And so there is clearly a benefit to students going back to school, but at what risk? And it's not just the risk of the students. I do wish people would stop talking about that. Students exist in schools with teachers, and teachers are at risk in bringing that back to their houses and communities, and that results in community spread. And so one has to be very careful. Children may be at low risk for severe disease, but they run the risk of spreading that disease to populations at much higher risk.
Thank you. Your next question, Dr. Lesse, based on the data, can you please explain where you think we're headed as far as continued infection rates in those hotspot zip codes, especially over the next 6 months?
I think it depends on how diligent we are. I think if you think about New York in March and April, especially New York City, you would have said that, and it was a disaster, but now New York is the poster child for control. I think that carefully planned and diligent observation of situations on the ground and continued testing and continued emphasis on the factors that have gotten us here, which are, proper use of masks, social distancing, and decreasing, unnecessary interaction are what's going to keep the pandemic at bay in specific regions. If you look at what happened in the South and the West and rapid reopening with the hope that it had gone away, hope is not a really good strategy right here. We want to ignite hope, but we don't want to hope that that this virus will just disappear, because it won't. We have to be vigilant with all of the procedures that we're currently doing now. It is possible that the pandemic will worsen in the fall and winter as influenza season takes place. But actually, if you look at Chile, which is in its winter now and is having a significant COVID-19 outbreak, their cases of influenza, they precede us in the Southern Hemisphere, are literally trivial this year. And so I think our ability to control COVID will help predict what's going to happen in influenza season. I am worried about a second wave, but I think that that'll be because we've let our guard down.
Thank you. And a follow-up question to that. Are there specific strategies that South Korea implemented that the US should or needs to do here at home?
Yes, the South Koreans implemented a massive centrally driven testing system. The society is much more receptive to mask wearing. It's actually part of the culture, and especially given their history with MERS and the high rates of fatalities that were seen 6 years prior, they were perfectly situated for the implementation of a sophisticated and rapid deployment of national testing and quarantine and isolation. And that is in significant distinction to what's happened here. So I think ramping up testing, maintaining mask and social contact precautions are the way to limit the spread.
Thank you. The next question is, this is regarding the asthma hospitalizations. Are Black people receiving substandard treatment when they access the system? Do we know, is the question. And is it similar to Black women not being listened to during pregnancies?
I think that that clearly is a component of it. Is also is the environment that they're in, is the amount of air pollution and the local conditions, especially in the homes as well, stimulate repeated asthma attacks. And so I think that there is a greater stimulus for exacerbation of asthma. And then similarly to many of the other diseases, unfortunately, Blacks have a higher rate of complication than do others in the community. And I think that that can be the result of care, either frequently because of implicit bias and affecting the type and quality of care.
And do we know how nutrition plays a role in health outcomes and the susceptibility to COVID-19?
I'm not aware of specific data, but I think clearly a person with better nutrition has a more effective immune system, has less coexisting or comorbid diseases, is less likely to be infected, and if infected, it likely, I don't have the data to support it, unfortunately, is highly likely to have less severe disease and probably lower mortality. So I think that all of those factors are exceedingly important. Nutrition, because of its multiple factors that go into nutrition, is a difficult is a difficult process to study. We're just not sophisticated enough yet, I don't think, to study it well enough. Hopefully the CTSI and Buffalo Center for Health Equity will be able to contribute to that as well.
With that in mind, can you remind us, great question, of the symptoms and what to do if you think you have COVID-19? And also that is the first question. And then a little bit of context around testing and contact tracing, the importance of the two.
Yes, I probably just will have part of my infectious disease degree rescinded for not talking about signs and symptoms of disease. Tim, sorry about that. The signs and symptoms of COVID-19, predominantly fever, although not everyone has to have fever. It's one of our screening tools. Cough. The ones that are particularly relatively specifically associated with COVID-19, loss of taste or loss of smell seems to occur in a very high percentage of patients, and it's unusual for other diseases. So fever, cough, and if you lose your sense of taste or smell without the other two, I would still probably be tested. Testing is quite accurate in terms of the RNA amplification tests, the PCR-based testing. We have tests that range from an hour to 18 hours. The problem is turnaround time, especially in the commercial labs. Locally within the system, we still have a good turnaround time for hospitalized patients and people in the Kaleida system. But Dr. Tomaszewski has talked about these are worldwide shortages of not just the test kits, which are actually not in horribly short supply, but things like pipette tips. In order to be able to do the test, you need pipette tips, you need swabs, you need things that have strained the worldwide supply chain. Contact tracing is absolutely essential to try and identify people who've come in contact with a case. The way that it spreads is that each infected person infects on average 2.3 to 2.6 individuals. If you isolate that person, they don't spread it to anyone. So the quarantining of people is important. And because of asymptomatic spread, I may not feel sick, may never develop a symptomatic disease. I'll still spread it to my 2.6 and other people will as well. So those people, you need to be able to identify the asymptomatic contacts. Testing is highly accurate in those settings, but you have to know who they've come in contact with. The other thing that the South Koreans did was implement, and actually in Singapore was really highly implemented, the use of cell phones for contact tracing passively in the background. That raises personal rights and invasion of privacy concerns. I mean, if people are arguing about wearing a mask, I cannot imagine a national government policy on requiring cell phone contact tracing like they have in Singapore. But I think we do need something like that, especially during outbreak situations.
Thank you for that. We have a couple more questions. Can you speak to the infection rates among pregnant people, especially given the racial disparities? Are there particular risk factors or precautions when it comes to COVID and pregnancy?
Interestingly, so pregnancy for influenza, which is a different virus, clearly is a risk factor, especially H1N1. You may remember in 2009, pregnancy was a major risk factor in some of the groups that were initially vaccinated first, with healthcare workers, patients with obesity, and pregnant females. There does not appear to be an increased risk to pregnant women that I'm aware of, but I'm happy if I don't know that information as well as I should, being at the VA hospital. We don't see a lot of pregnant veterans, although they clearly have many of them in society. But in the data that I've read, I don't remember seeing an increased rate of disease in pregnancy, and transmission to the fetus or to the child occurs, but it's rare and at a relatively low frequency.
Many of the contributing factors on slide 21, I'm not sure which slide that was, are commonly considered helpful mitigating factors for those working to address climate change, density, transit dependence. Are we considering redevelopment and revitalization in 14215? How can we preserve those factors and protect the public at the same time?
Yeah, I mean, that.
Can you first explain the components of that question and then answer the question?
Yeah, slide 21 talked about high percentage of essential workers not having autos for transportation, multi-generational homes, and suburban versus urban distribution. In terms of global warming, paradoxically, global warming, one of the potential solutions to, or one of the potential ways to decrease the effect is public transportation instead of so many individual cars. So that paradoxically might not work as well there, but the adoption of increased amount of green space, the proper housing with lower housing density. You don't want to go all the way to the suburbs where it's so low. All of those factors can contribute. I think it takes teams with people like Dr. Taylor, epidemiologists, so, you know, architecture, epidemiology, urban structure, all of these need to be taken into consideration. Right now, I don't consider myself smart enough to be able to analyze all of those factors at the same time.
Thank you, Dr. Lesse. What we will do next is I just want to explain what our next phase of our conference today will be. Dr. Lesse will remain in this Zoom room for his breakout session. So if you have more questions, you want to dive deeper into this particular aspect of the work around COVID-19, please stay in this Zoom room. Like, don't go anywhere, stay right here, because this is where his breakout session will be. I'm gonna ask that Joe place the link to the breakout sessions. So the breakout sessions are not gonna be in this Zoom room. Don't leave yet, you gotta get all of the information first. The breakout sessions are in Zoom, but each breakout session has a different link. So Joe is gonna place in the chat the link to the page where all of the breakout sessions are listed. Just click on that link. It's going to take you to a UB website page, and then you'll see the links for each of the breakout sessions. We have several. Again, Dr. Lesse's breakout session is going to be in this room. And that's the community response breakout session. There's a mental health during the pandemic breakout session, a session on employment, a session on education, and a session on housing. We have 3 breakout sessions throughout the conference. What we would like for you to do is pick the topic that you want to work with for the conference and stick with that breakout session, because each session will build on the previous. So this first session, everyone is pretty much going to give you background information, focus in on that breakout session topic. And then the next breakout session, you'll be doing more work associated with the information you were giving in the first breakout session. And then the third and final breakout session is really going to be your next steps, your action planning, taking the movement to the next phase. So we really want you to participate in one topic throughout the entire conference. You have all the links, so you are all adults. You don't have to if you don't want to, but we really want to make sure that we have robust conversations and aren't really being repetitive in the work that we're doing. We want to continue to move the agenda forward. So Joe has placed the link in the Zoom chat. If you click on that, it will give you a list of all of the breakout sessions. At the end of your breakout session, we're all coming back to this Zoom room, but your facilitators in those groups will place this Zoom chat link in that box. So you don't have to keep up with anything. You don't have to wonder how you're going to get back here for our next session. Everything will happen in your Zoom chat. We want you to be interactive. We want you to ask questions. We can't do this work without you. It's truly a community effort across the board. So you have 6 minutes until the beginning of your first breakout session. Breakout sessions will begin at 9:45. And again, our tracks are impact of COVID in the community, which is the breakout sessions associated with all of our keynote speakers, mental health during the pandemic, employment, education, back to school, and housing. We will see you back here at 10:30 because after your breakout session, we're going to give you another 15-minute break. We know it's a long day. We want you guys to stretch and move about and be ready and active. For the first session, if you are going to stay with Dr. Lesse, you will stay in this Zoom room. If you are going to join one of the other breakout sessions, click on the link that Joe placed in the box. Joe, if you can put that back in the chat room for folks, it would be greatly appreciated. Click on that link and you'll see all of the breakout sessions right there for you. You can click on that and you'll be good to go. I will stay here for a few moments. Everyone, you're free to head over to your breakout sessions. We will see you back in this room at 10:30.
Kelly?
Yes.
It's Linda Pissar. Hi. I don't see the links to the breakout sessions when I click on chat.
There is a link to UB webpage. If you click on that link, Joe Ventresca put it in the box.
You got to hit the little plus, and the plus expands on it. There's a little plus. When you hit the plus, then you have all the different sections.
It's
so within that same
session, information, and links.
Where is that?
If you click the link that Joe put in the box.
In the chat box?
In the chat box. Mm-hmm. When you get to that page, scroll down a little bit, and you're going to see a hyperlink that says breakout session information and links. It's in blue with a little plus sign. It's right above the agenda.
Hey, Kelly.
Mm-hmm.
Good morning. This is Doris Carbonell Medina. I'm trying to access the link to the employment workshop. Yes. And what I get is a UB screen with the request for a name and a password. I put in my name and the password that I was provided, and I cannot get in.
Okay.
Yeah.
You can't
sign in UBIT name, username, and password. So it's not taking me to an open Zoom screen. I am landing on like a UB link page. So I don't know if that's the experience of the other facilitators and the leads for the workshops, but that's mine.
Okay.
It's taking me like to a regular UB web page to sign in as if though I'm a student.
Joe, let's see. No, not Joe. Jennifer just placed the link in the box, although you're in Zoom, so you're going to have to leave here.
Session, the meeting host hasn't started yet.
If you're a meeting host, sign in to start the meeting. So that's not me, right?
Correct.
Okay. Well then.
So your facilitator will be there.
And I think after it.
So I gather then we're all waiting for the facilitator to arrive. I'm not getting in.
For employment.
I'm not getting in. Yeah.
Kelly, what I'm going to do is go back to my email message, which has the links.
Yes.
And join that way.
Yes.
Okay, great.
Which side note, my apologies. In your inboxes, there is an email with all of the links for you to be able to hop in. All of the Zoom rooms have the same password.
If you don't see me, send me a text with directions.
Linda, I just emailed you the link.
Okay, great.
I'm leaving, Tim.
All right, looks like we have open.
All right, so maybe we'll give a couple more minutes for people to get where they need to be, and then we'll start the main breakout room.
I will grab one thing to drink. I'll be right back.
Okay.
All right, all right. Well, can everyone hear me? All right, so welcome to the main room breakout session. I am Louis Wong, I'm your facilitator. So basically this breakout room here is to provide sort of a deeper dive into the keynote topics, maybe get a little more time with the speaker, and so on and so forth. So right now, we're back with Dr. Alan Lesse, the Jacobs School's Associate Dean for Medical Curriculum and Associate Professor of Medicine, Pharmacology, and Toxicology. And he's here for a closer look at his talk on health disparities and the pandemic. And he's also here to field any additional questions that you might have. If you are accessing us via the Zoom and not the Panopto, please feel free to contribute a question either by clicking on the raise your hand icon or just send me a question in the chat function. We will try to address as many questions as possible. Dr. Lesse, would you like to add a few more words about your topic first, or should we move on to the questions?
I would, let's see, am I muted? No. I would just say that it's a, a pleasure to be here. I think in terms of the topic, I think that COVID-19 has really just sort of elucidated or shown us in more stark detail all of the problems that we have with health inequities. But I also think that all of the work that's been done in the community indicates and shows what a community can do to be able to try and overcome some of these aspects. So I think the community deserves all of the credit here, but it's nice when the university and the community can work together.
Thank you, Dr. Lesse. So as to some of the questions, you've really laid out a clear case for these health disparities, or I guess more accurately, health inequities being pre-existing conditions that are being amplified by COVID. You've also talked about some of the wonderful organizations that address these issues, but have noted that there's more work to be done. In order to finally sort of narrow this gap, would you say that we need more of an acceleration of extant approaches, or do we need maybe more of a new comprehensive approach? What do you think?
I really think that it has to be more of a comprehensive approach, and I would be interested in Tim's assessment as well. I think, Pastor George always talks to us about the big picture and the big dream, where I'm starting to understand it. I think for a while it was sort of beyond my grasp, but it's the whole concept of this didn't just happen by accident to this group of people. I think we need big designs, big urban redevelopment, big structural changes, and those things aren't going to happen overnight. And I think it's sort of like the way that I've learned about some of these things. I think it's slow, steady progress that brings us forward. I do think, though, that the events of the recent time with George Floyd and all of the problems, that I think a lot of people are tired of waiting slowly for change, and that this actually provides us with an opportunity to really jumpstart the changes that are necessary.
Sure. So it sounds like that you really kind of think that there is sort of this tension between sort of a slow development of changes, but then with the recent events, there are sort of this call for big changes to happen. Do you feel like there is a difference between addressing them in, say, mid-scale urban areas such as Buffalo versus large-scale urban areas such as Los Angeles? What do you think?
I mean, I think that it's probably easier to do it in an area like Buffalo than a much more dense urban area like New York or Los Angeles. So as Tim said, and I think Pastor George said, we have the ability to become a nationally recognized center to be able to carry out some of these things. I think it would be easier in Buffalo than it would be in New York City.
Thank you. I think Francesca Messia has a question. Could you please unmute yourself, please?
Yeah. Good morning, everyone. This is a great way to start the morning, great way to start the day. I'm so used to typing in the chat box. My question, health disparities, housing disparities, economic disparities, none of this is new. And the community, and people in the community are aware of this. We've been collecting data for years. We've been collecting data in Buffalo, the city of Buffalo, United Way, different groups for years. At what point do we begin to engage the community to ask them, is this what they feel is the best strategy for their health, for their, let's stick with health because we're on health. At what point do we begin to share the information with them? So we're not talking about them, we're talking with them, we're engaging together to begin to make strategy, to begin for people to improve their health. People know that they're not healthy. You know, that's one thing. Many of us aren't healthy, as healthy as we could be. Also, and that's question number one, when do we begin to engage community in this conversation so they can see if we're on the right track? Are we on the right track? Also, in terms of health and nutrition, is it possible to utilize church vans that pick up members on Sunday morning to take groups to Sam's Club and BJ's? You know, people talk about food deserts. Yes, there are food deserts. I don't think for the most part going away anytime soon. However, can we encourage people to, in neighborhoods, by blocks, for people to chip in and get a Sam's Club card, chip in to get a BJ's card? Then can we work, and I know it's an insurance issue, work with the church vans to take people to stores where everything is, where products are sold in bulk. So as we look at the health of our community, can we look at different strategies? Number one, I don't know if we can do that with church vans. And number two, when do we begin to sit in the meeting and say, this is what the problem is, and they know. I mean, this isn't, so I'm just wondering if are those types of things that this group has been working with. Thank you. I'll mute myself.
Certainly. So I think that, let me address them one at a time. I think clearly we can do more in working with and talking with the community. I do think that one of the hallmarks of the current collaboration is that it is community driven with university assist. And as you said, there's lots of data that's already been gathered by agencies in the community. I think all of us are more than willing to talk with the community and to engage in that conversation. I think there's always the concern that we spend all of our time talking and not as much time doing. So we probably have undersold the concept of talking with the community in an effort to try and actually do things. But I think, as with everything in life, there needs to be a balance. So if we've gone too far to one extreme, then we probably need to ratchet that back. In terms of your idea about, if the food's not near the people, take the people to the food. I think that that's an excellent idea. The one caveat right now would be during the COVID pandemic, gathering people together in a van may be more problematic. It might even be nicer, and I have no idea of the availability of anything like this, but ice cream trucks come around the neighborhood here all the time. And the kids come out to that, distributing, fresh fruits and vegetables or having things available for people to be able to purchase at obviously a reasonable price. Those kinds of ideas. I think we do. I think we have to think outside the box. It will take years to refashion the communities, and the people there can't wait. So I do think that we need new innovative ways to look at these problems.
Can I just add to that? I think the call centers, one of the things that they were doing was when they identified individuals in the community who had no resources in terms of food or things like that, food was taken to the home and provided to them. And the other thing is our joint involvement with the REACH grant, which is the Racial and Ethnic Approaches to Community Health. One of the components, one of our highlights is food and nutrition. So we are working with the Healthy Corner neighborhood food stores to increase the availability of fresh fruits and vegetables within the community and the stores, which are most people go to because of a walking distance and that type of thing that are actually embedded in the neighborhood. But I think all of those activities have been informed by talking with the community, engaging the community in either focus groups or that type of thing to kind of get their perspective, because they have a different lens than most of us who are engaged in the movement.
Thank you, Dr. Grinslade. So one of the questions from the box. So what was written here is that, Dr. Lesse, both you and Pastor Nicholas mentioned the boots on the ground and the great works of the Health Equity Task Force in controlling the spread of COVID-19. Could you maybe talk more about these specific actions and how they could be replicated into a model that addresses chronic diseases like diabetes and heart disease?
Yes, I think that kind of model could be created based on, I think some of it's already being tried. One of the concepts, especially in, we have a class called Health in the Neighborhood. It's an elective, and it's a great course for our students that we want to hopefully model into the curriculum, that talks about health as sort of a neighborhood concept and the constructs of the neighborhood leading to a healthier environment. One of the problems that's been identified in the current healthcare system is, frequent use of the emergency room as the primary care location, and the concept of what's called hotspotting, where people frequently use the emergency room for their care and don't have the health maintenance and promotion of health aspect that primary care brings to the table. So identifying those areas and trying to connect people with primary care practitioners and community resources can be directed at almost any of these diseases. We are, mining data and have access to very large amounts of data on both a population and, neighborhood and level. And the same kinds of tactics that are done for COVID-19 could be done for many different diseases. I think it's just like the movement, however, the current movement for health equity and for social justice, COVID-19 just really lights the fire under people. It's an emergency. It is an agent that's transmitted person to person. The diabetes and heart disease don't get the attention that the COVID-19 has gotten, probably because of some of those features. So it may be more difficult. It may take more determination to do that because it is a chronic problem. But I think I think it could be addressed in that fashion.
Maybe can I add to that and one of your other points, Alan, and that is when we think about the impact of the disproportionate impact of the COVID pandemic on the communities in the east side of Buffalo. And one of the fundamental reasons is because of the underlying illnesses. So let's go a step back from that and think about what are the causes of the higher death rate and the higher rates of disease, and it's the social determinants of health. So it's poverty, it's unemployment, it's education opportunity, it's crumbling neighborhoods, it's food deserts. And these are the underlying fundamental problems when you think about why the pandemic has had such a devastating impact on our communities of color throughout the country. So that means, the way I see it is, these emergency measures, these boots on the ground efforts that we're doing, which is sort of stimulated by the pandemic, what we need to do then is begin to address those underlying social determinants. So in other words, I think the immediate response to the pandemic should be the beginning of a more sustainable and a broad-based effort to address these underlying issues. And it's so a lot of it is not health related, you know, it's housing and it's neighborhoods and it's employment and it's education. And these are the things that ultimately are going to lead to the solutions to diabetes, heart disease, pandemics, and so forth. So I think my take on it is we should be doing, if you want to say, both things. So in other words, we need to focus on the pandemic. It's a public health emergency. But then while we're doing that, we need to establish systems that are going to be sustainable and try and change these things for the next pandemic.
Thank you. So thank you, Dr. Lesse, for talking about the importance of primary care in all of this. And thank you, Dr. Murphy, for talking about the need to address underlying social determinants. One of the questions that has been brought forth in the chat box is that even though it is wonderful to address these different issues, there's sort of a history of a lack of trust in health systems that is a big concern in marginalized communities. Do either of you have any suggestions on sort of the best practices to encourage testing, compliance with vaccinations, and these other safety measures all related to stopping the spread of COVID?
Yes, actually, I heard a great lecture yesterday by Dr. Jarvis, who is a member of the indigenous people, Native Americans here in the United States. And there's, you know, great distrust in that population with, you know, the healthcare and science and research. And he said, you know, one of the students asked, how can you increase the trust, which is sort of the same question you're asking here. And he said, well, you have to be humble. You have to sit down and keep your mouth shut and learn. And I think that that's a really, you know, effective definition. I think I learned enormous. I don't think that I talked very much in literally the first year of meetings with the task force, other than people would ask me questions and I'd try and fill in. You know, the thing that I learned most quickly was, hi, I'm from the university, I'm here to help you, is about as welcome as, hi, I'm from the IRS, I'm here to help you. It's well-meaning, but it totally destroys that sense of trust. And if there's a problem with that going in, it just gets amplified. I think we have to maintain some humility. I think we have to maintain a lot of humility and work with the community. Identify the community needs to identify its needs, and then the university or science needs to help. It can't be the other way. So I think the way that we build trust is asking people what the problems are, listening, and then working with them to try and figure out solutions. And then bring the power of science and the university to bear with the problem, not think that we can, you know, come up with all the solutions.
I'd like to add to that, Alan, and it specifically sort of addresses you. In a meeting that we had with the Institute Advisory Board yesterday, or the Associate Directors, Kelly made the comment that the most important thing is for people to show up authentically and to rid themselves of their mantles. And she cited the fact that you and Pastor Pointer, and you even mentioned it this morning in your presentation, spent hours taking down tables and chairs, etc. It was you authentically showing up to work with others. And I think that's what for those of us who are involved in the task force, I think that's been a very humbling experience. And I think we've all learned that lesson. And I think that's also what makes us effective in the community.
Thank you. Yeah, no, it's I can't, you know, I don't even like using my title a lot. You know, too many words in front of my name. You really, I think you have to be able to work with people. And nobody in the community cares that I'm Senior Associate Dean for Medical Curriculum. But if I'm there working, you know, like with our students the very first day, the Saturday before we start, you know, just working in the community. That's what we need to be doing. And that's one of the points of the medical students with service learning, trying to find out, work with the community, find out what their needs are and try and assist. And I think as we redesign our curriculum, and I see Dr. Mecca and Dr. Jacobson are on this as well, you know, it's those kinds of principles that make and train great physicians. We just have to give them the opportunity.
I think we can all relate to what Dr. Lesse and Dr. Greenslade is saying in terms of first shutting up and listening, and also the importance of showing up authentically and really, really working with people. I think there are maybe a couple more chat box questions we can address before we have to get back to the main session. The first question is, what role does COVID testing play in reducing the impact of the pandemic on East Side communities? And the second question, I think, is, and sorry, this is sort of an unrelated question, but this is the second one on the text box. Is there anything else we can do to protect our elders and the caregivers who are taking care of them?
Yeah, so the role of testing is almost paramount. I think you don't know what the problem is until you've identified it. I think easy access and rapid turnaround to testing is going to be the key to limiting the spread in the community. And as I said, the problem with asymptomatic spread is particularly difficult. The concept of super spreaders is extremely worrisome. Luckily, there haven't been as many of those events, but they are real. So I think you have to be able to deliver testing to the community. And what's the best way to do that? I think that's what the grant is going to look at. Is it people coming door to door? Is it mobile clinics? Is it clinics in the neighborhood? Is it things at the churches? I think those are all ways to try and deliver the testing. And I think that we'll look at that and try and figure out what is the best way and the best location. The second question was?
It is about protecting our elders and caregivers. Sorry.
Yeah, I think in terms of protecting elders and caregivers, you know, I think the elders are actually sort of living in fear these days, especially going outside their own home because of, you know, still spread in the community. If I think the thing that we can do is to make absolutely sure that we're not doing anything that increases our risk of acquiring the disease and then spreading it on to them. So if we are caring for elders, if we are, you know, assisting in their care, we have to be absolutely diligent to make sure that we don't become accidentally infected and transmit the disease. The older population can't get out as much, and that carries its own psychological tolls as well. And hopefully, if we continue to do things right and open up the society, and then they'll have a better access to returning to society, but they'll still have to be extraordinarily careful.
Thank you very much, Dr. Lesse. It is 10:14 right now, and we will probably be returning back to the main keynote shortly. But for those of you who didn't get your questions answered, thankfully, Dr. Murphy will be here on the next main group breakout session, and I will bring those questions to him at the next breakout session. Thank you very much. And thank you, Dr. Lesse and Dr. Murphy again.
My pleasure. Thank everyone for staying here for the questions.
Yeah, thank you. Thank you, Louis. Nice job.
Nice job, Louis.
Thank you.
So now we have a 15-minute break, everyone, and then we'll start promptly at 10:30 at the next main session, and you can just stay in this room.
Great. Yeah, I was a little short on the time, but I think that worked out pretty well, actually.
It was perfect.
Good. Good.
Great.
Happy birthday, Dr. Lesse.
Oh, thank you, Jennifer. Thank you very much. All right, I'm gonna step away for a minute.
Great job in that breakout session, guys. Really good job.
Thank you.
Thanks, Al. Welcome.
Yeah, good, really good program so far.
Come on, man.
Hello, everyone. As you are coming back from break, I just want to remind you to please use the chat for questions and comments and conversation. If you do not want to appear in the video, we are recording and are streaming live, so please make sure you turn off your video. If you sometimes experience unstable internet connection, it's also best that you turn off your video. You'll have a better connection to receive the information that is being delivered in our conference today. Additionally, before I turn everything over to Dr. Murphy, our next keynote speaker, if you have any questions for her, please, again, place them in the chat. If you are a member of the media or press, we have a specific contact for you to answer your questions. So I will place that information in the chat box for you. If you are a member of the media or press, it is imperative that you contact the media office. And I'm going to put that in the information box, in the chat box for you. We ask that you respect that request, and we are holding everyone to that standard. I welcome you all back to Igniting Hope Conference 2020. Tim, it's on you.
All right, thanks so much, Kelly. And looking forward to the next session. Great start to the meeting. Just excellent discussion so far. It will be my pleasure in a moment to welcome Rear Admiral Richardae Araojo, our special guest speaker. But first, I would like to introduce a person who needs little introduction to most people in this audience, and that's Dr. Michael Kane, who's been an enormous supporter of the work that we're doing that we're talking about here. Dr. Kane is Vice President for Health Sciences and Dean of the School of Medicine and Biomedical Sciences. Dr. Kane.
Thank you, Tim, and good morning. On behalf of the University at Buffalo and our 5 health science schools, I also want to welcome all of you to this year's Igniting Hope Conference. I also want to acknowledge, as Tim had mentioned earlier, the National Institutes of Health and thank them for helping to support this and future conferences, which I hope the next one can be held back in the Jacob School as we were able to do with the previous one. It is impressive, and we've heard already this morning that working together, the Clinical Translational Science Institute, the African American Health Equity Task Force, our joint Community Health Equity Research Institute, and the many community partners that Pastor Nichols showed in his slide, that together we really are a formidable force that has and will continue to perform innovative clinical and translational research and implement action plans to reduce health disparities in our community and in our nation. And so in my role as Vice President for Health Sciences and Dean of the Jacob School of Medicine, I want to publicly reaffirm the universities and that of the 5 health science schools within the university to reaffirm our commitment to achieving health equity in Buffalo. It's an honor and a pleasure for me to be part of this. And we do take this very seriously, and that commitment is very real. So my thanks to all of the organizers and staff for this important conference. Look forward to listening for the remaining sections. And Alan Lesse, if you're still out there, happy birthday.
Thanks so much, Dr. Kane. It is now my distinct pleasure to introduce our next keynote speaker, Rear Admiral Richardae Araojo. Dr. Araojo earned her Doctor of Pharmacy degree from Virginia Commonwealth University, completed a residency in pharmacy practice at University of Maryland, and then earned a master's degree in pharmacy regulation and policy from the University of Florida. She joined the FDA, the U.S. Food and Drug Administration, where she has held several positions. She's currently Associate Commissioner for Minority Health and Director of the Office of Minority Health and Health Equity at the FDA. And in this position, she provides leadership, oversight, and direction on minority health and health disparity matters for the agency. It's really a most influential position nationally. So it's my privilege to introduce Rear Admiral Richardae Araojo, who will speak to us on the FDA perspective, enhancing racial and ethnic minority representation in clinical trials.
Good morning, everyone, and I hope you can hear me okay. It is a true honor and privilege to be with all of you today, and thank you so much, Dr. Murphy, for the invitation. I am very excited to be able to share information with you about the Office of Minority Health and Health Equity and the work that we are doing to advance diverse participation in clinical trials during the COVID-19 pandemic. So I'm going to see if technology supports me today and share my screen and pull up my slides. Give me just one moment.
Looks good.
All right, and let me double check one more time, Dr. Murphy. Can you only see my slides? Okay, wonderful. Just wanted to make sure. So again, thank you all so much for the opportunity to be with everyone today and to share information about what the Office of Minority Health and Health Equity is doing to advance diverse participation in clinical trials, as well as during the COVID-19 pandemic. And I really wanted to be able to start today by, I know we have a very broad and diverse audience, and I wanted to start with sharing a little bit of background about FDA and what we actually do. So the FDA is responsible for protecting public health by assuring the safety, efficacy, and security of the range of products that we regulate. So we are a regulatory agency, of course. We regulate human and veterinary drugs, biological products, medical devices, our nation's food supply. We also, of course, regulate cosmetics, products that emit radiation. We regulate the manufacturing, marketing, and distribution of tobacco products. So we, as you can hear, are definitely a regulatory agency, but we are also a consumer protection agency. And I think that's really important when you think about the work that we do at the agency. And I thought it'd be fun just to share some facts about FDA to give you kind of the broader perspective of the work that we do. So we are responsible for the oversight of more than 2.6 trillion consumption in food, medical products, and tobacco. We regulate about 77% of the US food supply. There are about 20,000 prescription drug products approved for marketing. We oversee more than 6,500 different medical device product categories. There are over 1,600 FDA-approved animal drug products and more than 400 FDA-licensed biological products. And we also oversee more than 85,000 tobacco products. So this just gives you the perspective of the range of work that happens at the agency. And as I mentioned, we are a consumer protection agency as well. And I think that really comes to mind when you think about the Office of Minority Health and Health Equity. The office was established in 2010, and we were renamed to the Office of Minority Health and Health Equity in 2019. We're very excited about our new name. We think it really helps to highlight the scope of the work that we've historically done and what we will continue to do, which is working to protect and promote the health of racial and ethnic minority, underrepresented, and underserved populations by focusing our efforts on research and outreach and communication that works towards addressing health disparities and ultimately our goal of working towards trying to achieve health equity for all. Our office sits within the Office of the Commissioner, and we also work across our agency as well as working very closely with both public and private sector stakeholders. And I have to say, it's really exciting to be a part of the meeting today because partnerships and collaborations, as we all know, are critically important if we want to be able to continue to work to address health disparities and the issues impacting our diverse communities. We have 3 overarching broad goals for the work that we do within the Office of Minority Health and Health Equity. We work to improve regulatory science by increasing data available on the populations that we serve. We also work to strengthen FDA's ability to respond to minority health concerns. And in addition, we promote health and safety communication to minority populations and others who often experience low health literacy, speak English as a second language, or not at all. We are able to achieve our mission by working in 2 key programmatic areas. We have a research and collaboration program that aims to advance minority health and health equity focused research. And we do this in a variety of different ways. We support intramural research, so research conducted by our FDA investigators. We support extramural research. We participate in research opportunities across the agency. And an example of that is our Centers of Excellence in Regulatory Science and Innovation. We also really focus on trying to ensure that we have training opportunities. We want to continue to build that workforce that thinks about health disparities and working to solve the issues impacting minority populations. So we offer internships and fellowships. We also have an outreach and communication program, and that program works to improve FDA's communication with racial and ethnic minority, underrepresented, underserved populations. And we do this through a variety of different programs, initiatives, and campaigns. For example, we have a language access program. And within that program, what's really important for us is so that we can ensure that we are developing culturally and linguistically competent tools, resources, health education materials. And in addition to that, ensuring that our initiatives that we develop are also culturally and linguistically competent. And one of those initiatives is our Diversity in Clinical Trials initiative that I'm going to talk a little bit about. We also engage in social media outreach. We have newsletters and e-alerts. We have our website, and all the information that I talk about today can be accessed from our webpage. We also, of course, work closely across other HHS agencies. And again, one thing that you'll hear me say throughout the entire presentation many times is that we really work to also foster partnerships and collaborations. We know we cannot do this work alone, so we really value where we have opportunities to collaborate. There are a number of different areas that impact the work that we do within the Office of Minority Health and Health Equity. Some of those, of course, are congressional mandates and legislation, the Department of Health and Human Service strategic priorities, as well as, of course, our FDA strategic priorities. And really what's important to us when we're thinking about getting input on our strategic priorities, we want to make sure that we're getting stakeholder feedback and input. So we recently opened a public docket so that we could solicit comments from our stakeholders to help us ensure that we are addressing priorities that impact diverse communities and that we are ensuring that we are addressing priorities for significant health concerns. And this docket was open in January, and we are actively reviewing the comments that came in from this. These are some of our priority areas. As you can see, it's focused on diseases and conditions that disproportionately impact our diverse communities. And of course, a key priority for us right now is COVID-19 and continuing to address clinical trial diversity. Whenever we talk about clinical trials, I think it's really important to really highlight what that means when we're thinking about FDA. So we know that clinical trials are voluntary research studies conducted in people and designed to answer specific questions about the safety or effectiveness of drugs, vaccines, other therapies, and new ways of using existing treatments. And the one thing that I think is important to highlight about FDA, and we are a regulatory agency, is that we do not conduct clinical trials. And I think sometimes that may be a misperception. So as we talk about this, we do not conduct clinical trials, but we do review the data that's submitted to us in product applications. So why are we talking about clinical trial diversity? And we have been talking about this for many, many years, for decades. And I think it's important to remember why we talk about this. We talk about this because at any given moment, if you were to do just a random search, you see a very consistent and common theme. And that's that clinical trials have far too little racial and ethnic diversity. And we know that there are many reasons to why we see minority underrepresentation in clinical trials. Many of these reasons are due to past historical abuses. We know that other barriers to participation may be based off the population that you're seeking to enroll. So, for example, there may be cultural differences, there may be language barriers, there may be time away from jobs and other commitments. There could be concerns about the trial design itself, the frequency of study visits, the inadequate recruitment and retention efforts. So there's so many different barriers. And if you look at these barriers, they cross so many different sectors. But one barrier that we hear too often about is that there's a perception that minorities do not want to participate and they simply aren't asked. So why do we need diverse participation in clinical trials? Clinical trials provide a crucial base of evidence for evaluating whether a medical product is safe and effective. And it's also important for us to ensure that enrollment in trials reflect the population that's most likely to use that product. We know that any trial, we learn different things about how specific products might react in certain races and ethnicities. So it's important for us to have diverse populations enrolled in those trials so that we have up-to-date information to be able to communicate to the public. So of course, one of our key take-home messages that we always emphasize is that we should be asking all patients to participate. So I wanted to provide some background about the work that we do specifically within the FDA space when we think about working to advance clinical trial diversity. And one of those areas is really important to me to highlight the most significant recent legislation that we've had in this space. And that is the 2012 FDA Safety and Innovation Act, specifically Section 907, or what you'll hear us saying at FDA, FAAFP. And this was really important because it emphasized the need for increased representation of racial and ethnic minority groups in clinical trials. And ultimately from FAAFP, we had the agency's action plan. And the action plan had 3 key priority areas of focus. Priority 1 was focused on improving the completeness and quality of demographic subgroup data collection, reporting, and analysis. So again, a specific emphasis on quality. And we achieved this through issuing 2 guidance documents. I'm going to talk about these in just a little bit. The first was focused on collection of race and ethnicity data in clinical trials. And the second was focused on evaluation and reporting of age, race, and ethnicity-specific data in medical device clinical studies. Priority 2 was focused on participation and working to identify barriers to subgroup enrollment so that we can employ strategies to encourage greater participation. And this is an area where we are consistently doing work across the agency. And I'm going to highlight some of the work that we have within the Office of Minority Health and Health Equity from tools and resources that we've developed to continue to work to advance diverse participation in clinical trials. And then lastly, priority 3 was focused on making demographic subgroup data more available and transparent. And this was achieved from the Center for Drug Evaluation and Research at FDA. They developed and they currently lead the Drug Trial Snapshots program. And Drug Trial Snapshots provide information to consumers about who participated in clinical trials that supported FDA approval of new drugs. And I always think it's important to highlight some of the information we've learned from Drug Trial Snapshots. Each year, the Center for Drug Evaluation and Evaluation puts out summary reports. And these summaries are aggregate reporting. So we know that approval of products vary per year, but they put out aggregate reporting and looking at all of that data together. So, and for example, 2017, we see that for Black or African Americans, we had about 17% representation. And then in 2018, about 11%, 2019, 9%. Then we look at Hispanic population, and in 2017 and 2018, we have about 14% representation. And of course, in 2019, we had about 18% representation. But when you look at this information across the board, what you'll see is that we still have work to do. There are other regulations that we have, for example, the demographic rule, just highlighting this to really highlight the information. But for our IND regulations, investigational new drug regulations, this regulation specifically talks about presentation of data in our annual reports that are submitted to the agency. So we do have presentation of data, for example, by age and race. Our new drug application regulations also require that sponsors of NDAs include summaries of effectiveness and safety data presented by gender, age, and race. And these are some of our guidance documents. So I mentioned two of these already. Two of these came from from FAAFP, and the first was the collection of race and ethnicity data in clinical trials guidance document, and also then following that, our guidance document focused on medical device clinical studies. And I think to just go back to the collection of race and ethnicity data in clinical trials guidance document, that guidance document has a very consistent theme with what you've heard me say, where we expect enrollment in trials to reflect the diversity of the population that's ultimately going to use the product. And most recently, in June of 2019, the agency issued a draft guidance that focused on enhancing the diversity of clinical trial populations with a specific focus on eligibility criteria, enrollment practices, and trial designs. And I think this guidance is really important because it helps us to think about how all of those things together can continue to help us to advance diverse representation in clinical trials. So in response to FAAFP, the Office of Minority Health and Health Equity developed our Diversity in Clinical Trials initiative. And this is an ongoing multimedia campaign to provide positive reinforcement and raise awareness around the importance of racial and ethnic minority participation in clinical trials so that we can ensure medical products are safe and effective for everyone. And I think what's really important is as the COVID-19 pandemic continues to disproportionately impact racial and ethnic minority communities, the relevance of all of this work and the work related to this campaign cannot be overstated. We are working to continue to amplify messages from this campaign, continuing to highlight tools and resources from this campaign. And most importantly, one of the things that we are trying to do is to ensure that our diverse communities, especially during COVID-19, that they understand what clinical trials are, what it means to participate, and why it's important for diverse communities to participate. Our campaign, as I mentioned, has been ongoing for multiple years. We are constantly adding new tools and resources. We have videos that highlight the importance of different groups to participate in clinical trials. All of our resources are available in multiple languages. We have newsletters. We have our dedicated clinical trial diversity webpage. We have a podcast. We have a communications toolkit. We focus on ensuring that the information we develop is culturally and linguistically competent. And one of the areas, again, that's most important for us is ensuring that we have stakeholder engagement and collaboration and partnerships to continue to advance diverse representation in clinical trials, especially during the COVID-19 pandemic. Some of the motivators for why we established this campaign many years ago was really so that we could focus on providing positive reinforcements as to why minority health issues matter, educate consumers about the key issues surrounding diverse participation in clinical trials and why it's important, and to continue to help to stimulate dialogue. I think that if anyone were to look at any of the tools or resources that we have available, and it prompts you to talk to your peer, to talk to a friend, and it might prompt you to talk to your provider, that to us is a positive step forward so that we can continue to encourage conversation about clinical trials. These are some snapshots and highlights from our diverse participation in clinical trials videos and podcasts. One of our big videos that we feature is a video that features Shirley Miller, who is an African-American woman living with sickle cell disease, and she highlights the importance of participating in clinical trials and why it's important for diverse communities to participate. We also have our Latinos in clinical trials video, and again, highlighting why it's important for us to have Latino participation in clinical trials. And again, all of these videos feature different themes and key messages that are important for us to continue to provide education about what a clinical trial is, what it means to participate, and to prompt what we hope is our consumers to think about this further and ask questions among their providers and their peers. This is a snapshot from Shirley's story, and I thought I would just share this. I'm not going to try to play the video right now. I'm sure I may have some technical difficulties, but again, all of these resources are available on our webpage. I did just want to highlight this. This is one of the videos that we have that again emphasizes that diversity is critical to making better products. And I think that's a very important key message. We know that Research is better when we have diverse populations participate so that we can ensure that the products we develop are safe and effective for everyone. And I also wanted to highlight two of our most recent videos within this space. And this was our Veterans in Clinical Trials campaign. And we partnered with the VA Office of Health Equity on this. We know that our veterans can oftentimes face unique health challenges. And it's important for us to have veteran participation in clinical trials. It's also important for us to have minority veteran participation in clinical trials. And we were really excited to be able to partner with retired Staff Sergeant Conrado McLean, as well as retired Command Sergeant Major Zuma Santiago. And they were able to highlight in these two videos why they felt it was important to participate in clinical trials. And they went on to share their story further in our first podcast series. These are some of the other resources that we have available. We have fact sheets, we have brochures, and again, we have a dedicated webpage. And one of the areas for us that's been critically important during the COVID-19 pandemic is working to ensure that we are getting these communities and amplifying the resources that we have available to our diverse communities, whether it be through social media outreach, through working and partnering with organizations, because we really, again, want to continue to raise awareness about education on clinical trials, what it means to participate, and why it's so important for our diverse communities to participate. So throughout the COVID-19 pandemic, of course, we've been working to raise awareness about clinical trials, but it's also been really important for us to ensure that we're disseminating COVID-19 health education information to consumers in multiple languages. We've partnered with other FDA centers and offices to ensure that we are providing accurate and current information on our FDA website that's available in multiple languages. So we have our COVID-19 main agency webpage that's been translated into Spanish. This also features FDA's frequently asked questions that are available in both English and Spanish. And we also have a multilingual resources COVID-19 webpage. And this webpage we thought was very important because it has all of those multilingual resources and health education materials in one key area and one place. And you can link to all of this again from the Office of Minority Health and Health Equity webpage. Our multilingual resources are available in a number of different languages, and we're continuously growing our collection of information in multiple languages. So for example, we have information available in Spanish, Simplified Chinese, Korean, Vietnamese, Tagalog, among a number of other languages. And one of the areas that was really important for us is that we wanted to ensure that we were providing this health education materials in multiple languages because it was really important to have these, excuse me, pertinent health topics information available. Excuse me. It was also important, I'm so sorry. It was also important for us to be able to further enhance outreach and dissemination by launching our COVID-19 bilingual social media toolkit. And this toolkit was really important because it provides information to our consumers and culturally appropriate graphics. It's a shareable toolkit, and it helps us ensure that we are providing consistent messaging to our diverse stakeholders. Another area that was really important for us was to ensure that we were providing targeted communication to our diverse communities. And one of the ways that we've been able to do that is partnering with the FDA Office of Counterterrorism and Emerging Threats. And this was really important for us because we are now able to provide weekly targeted communications to our diverse minority health and health equity focused stakeholders on FDA's COVID-19 information.
Dr. Richardae, would you like to take a 5-minute break?
I think my voice is finally coming back. I am so sorry. lastly, in addition to providing tailored FDA COVID-19 communications to our diverse stakeholders, we also thought that it was really important for us we also thought that it was important for us to hold a listening session. And this listening session provided an opportunity for us to be able to talk to our diverse stakeholders and really hear and understand the issues that are impacting racial and ethnic minority communities, including understanding the challenges, gaps, and needs. And in addition to be able to understand how the impact among our diverse communities, it was also important for us to be able to share with them the work that FDA is doing related to COVID-19. I also wanted to take a moment to highlight a public-private partnership that was established between FDA and Duke University, and that's the Clinical Trials Transformation Initiative. And I wanted to highlight this because within the Clinical Trials Transformation Initiative, there are a number of projects. There's also a most recent diversity project, which is focused on advancing diverse participation in clinical trials. But I wanted to highlight that in addition to this, the Clinical Trials Transformation Initiative also held a webinar on engaging racial and ethnic minority patient populations in COVID-19 clinical trials. And lastly,
let's take a 5-minute break, Rear Admiral. It's totally okay.
Okay, thank you.
Okay, we'll
Thank
be
you.
here. You just let us know when you are back and ready. With that, I would like to remind everyone that you can place your questions in the chat box. We have several already. If there's any press or media in the room, please send your questions to the FDA media office. I will repost that email address in the chat box for you.
Kelly?
Yes.
One of the things that's really important as we move through this work is, and some of the work that the Rear Admiral was sharing with us, is really breaking down some of those, there's two things, really breaking down the stigma within the Black community about participating in clinical trials, but also making sure the research institutions, like the ones that Dr. Murphy runs, really operates with real intentionality in terms of reaching into the Black community. And I think one of the great outcomes of our work here is that we're developing the relationship not only with the medical school and the academic disciplines within the university system, but also the research component of the institution. And so that we can, because we, especially as it relates to the upcoming vaccinations as it relates to COVID-19, we really want to make sure that African Americans are participating in those trials, so that when the vaccine starts, that there will be things that'll be, effective in our own communities. We're all equal, but we're not all the same. And so it's really important for us to do that. Maybe Dr. Murphy, you could kind of share how important it is for us to have that, break down that stigma, and then begin to really start working in collaboration, community and researchers to start improving community health.
Yes, thanks for that comment, Pastor George. I think that is really critical. And as you may know, there have been recent surveys asking people what their feelings are, their thoughts are about accepting a COVID-19 vaccine. And in the African-American communities, something like half or so are reluctant to even get to accept an approved vaccine. So I think it's going to be really important for us to have those conversations and for us to understand some of the barriers and deal directly with the mistrust in the African American and minority communities about these things. You know, most experts, all the experts say that a vaccine will be critical in terms of mitigating this pandemic and really solving the pandemic. And so these are going to be very important discussions for us to have, for sure.
And it speaks to the intentionality of how we got here, right? And how COVID really just exposed the situation that we have all been talking about for decades now, right? But how we need to intentionally move forward, how we need to break down those barriers, how we need to have those those conversations, how we need to rebuild, I would say build, not even rebuild, build the trust between the African American community and the medical community and the academic community. It's more than one relationship or type of relationships that we're talking about. And we actually started to talk about this in the mental health breakout session. But that is really the work that we're doing, right? Building those relationships, making those connections so that when the time comes, in this case, it's COVID, but there will be another situation, there will be another issue. We're looking at cancer clusters and the lack of research that has been done in those areas as it specifically relates to African American. So I just wanted to add that piece that it is more than COVID. If this disappears tomorrow, it is still an issue that we need to continue to address. I see Rear Admiral is back in the room. Are you ready? Would you?
Take your time.
Yeah,
we're all here. It's all good.
We'll wait. You see, we can talk. So
I know it doesn't take. You gotta be. You see, you gotta be careful around us. You take a breath, boy, and we'll jump right in.
I don't know. I swallowed wrong, and then it just. So my sincere apologies. I will go ahead and share the remainder of my slides and hope that I can get through this without coughing again. Give me just 1 second. I'll share my screen again.
No worries.
Okay. All right. So as I mentioned, it was important for us to ensure that we were providing tailored COVID-19 communications to our diverse stakeholders. And in addition to that, we held a listening session. Listening sessions are so important for us because we can really hear what's happening in our communities so we can understand how best to meet the needs of our communities, but also to share the work that we're doing at FDA. I highlighted the work of the Clinical Trials Transformation Initiative. And lastly, I wanted to mention the Department of Health and Human Services fact sheet that they have available on initiatives to address the disparate impact of COVID-19 on African Americans and other racial and ethnic minorities. And a number of our multilingual resources are featured in this fact sheet. I also wanted to spend some time talking about the guidance documents that the FDA most recently put out. And these guidance documents are very important because you've heard me talk throughout the entire presentation about how we are working to advance diverse participation in clinical trials. One of the areas for this that's most important for us when we think about COVID-19 and the way that it disproportionately impacts our minority communities, we want to ensure that those groups are included in the trials. So again, we can understand the impact among our diverse communities as well. So we have two guidance documents that came out, the FDA guidance for industry on development and licensure of vaccines for to prevent COVID-19. And this particular this guidance document specifically talks about and states that FDA encourages the inclusion of diverse populations in all phases of vaccine clinical development. and that this inclusion helps to ensure that vaccines are safe and effective for everyone in the indicated population. And I think this is really important. We have a guidance that specifically highlights and encourages the inclusion of diverse populations specific to vaccines related to COVID-19. The guidance goes on to state that FDA strongly encourages the enrollment of populations most affected by COVID-19, specifically racial and ethnic minorities. And in addition to this, the guidance for industry, there's another guidance for industry that we had come out that focuses on developing drugs and biological products for treatment or prevention. And this guidance goes on to also state that racial and ethnic minority persons should be represented in clinical trials, and that sponsors should ensure that clinical trial sites include geographic locations with a higher concentration of racial and ethnic minorities. And I think that's really important for us to think about. Throughout the COVID-19 pandemic, FDA has strongly encouraged that racial and ethnic minorities are included in COVID-19 clinical trials. And this is, of course, highlighted in these guidance documents. I also wanted to take a moment before I close out and take questions, just to kind of highlight, we talked about COVID-19. I think this was just mentioned right before I came back on. When we've been, COVID-19, I think has highlighted disparities that we have been working to try to solve for many, many years. And I want to highlight just some general information about the Office of Minority Health and Health Equity. In addition to the COVID-19 work that we're doing, we also continue to work to make sure that we're providing health education on diseases and conditions that disproportionately impact minority populations, that we have our webpage that has a number of tools and resources for our stakeholders and organizations that they have available and accessible for them to use. In addition, I've talked a lot about how it is so important for us to ensure that we have partnerships and collaborations. We know that when we're working to address health disparities and trying to achieve health equity and work on issues that are impacting minority health, we can't do this alone. We need partnerships, we need collaborations, and we need bi-directional community engagement as well. And I want to highlight two of our most recent partnerships and collaborations. One of the ways that we do this, of course, at FDA is through memorandums of understanding. And we have an MOU with the Alliance of Multicultural Physicians. This is an alliance of the 5 major national minority physician associations. And the MOU allows opportunities for us to collaborate on developing educational outreach, training initiatives for physicians and patients that they serve so that we can continue to advance health equity. And a component of this is also working to address clinical trial diversity. I also wanted to mention an MOU with Yale, and this is specifically with their Cultural Ambassador Program, which is an engagement of the racial and ethnic minority community partners to advance diverse participation in research overall. I mentioned earlier that we have different ways that we can support research at the agency. One of those is through our Centers of Excellence in Regulatory Science and Innovation. You see the institutions listed here that are a part of that for right now. And this is something where we are able to collaborate with academic institutions to help us answer pressing minority health or health equity issues. And not only do we want to be able to support and fund research, it's really important for us to be able to get that data out there and communicate the data. And one of the ways that we've done that is through, for example, our tobacco and health equity supplement. This was a journal supplement that we issued in the Health Promotion and Practice in January of this year. And it features tobacco-related research and interventions that contribute to understanding health disparities among diverse populations. So again, we want to ensure that we're supporting the research, but we also want to make sure that that information is being communicated broadly. And then lastly, I've talked a lot about our external engagements, work that we've done related to clinical trial diversity, our multilingual resources related to COVID-19. And I wanted to also talk about and take a step back to say, even from an internal perspective, what are some of the things that we think about and that we do? We do a lot of communicating with diverse communities, but we also know that there are a number of offices throughout our agency that also communicate information to consumers. And we developed an internal training that focuses on communicating with confidence. We had a training that was specifically focused on strategies to create effective communications for diverse communities. And in addition, we have a training that will be upcoming that focuses on the impact of bias on health education communications. So these are just some of the ways that we also try to work internal to our agency to continue to advance cultural competency and minority health. And my communications team within the office would not be happy with me if I don't make sure that I highlight and share how you can follow us on Twitter. We also have our email address there, our webpage, and of course the link so that you could join our Health Equity Lecture Series webinars. Thank you so very much for your time today, and my sincere apologies for getting choked up there a second, but I appreciate the opportunity to be able to be here with all of you and share information on the work of the Office of Minority Health and Health Equity.
Thank you so much, Rear Admiral. Don't worry, if you need to take more time, we'll be here. It's okay. Coughing. So we will move into our Q&A section. Everyone, if you have questions, please place them in the chat box. The first question, before we get too deep, is how do we access the trainings that you identified?
So right now that training is internal. So I wanted to highlight that to highlight some of the work that we do internal to the agency. But it's interesting that we've got a lot of requests to be able to also host that type of training external. So I appreciate the question, and it is something that we are considering.
You feel free to give us a call first when that's available, and we'll take it from there for you. So a lot of thanks that you see in the chat. Thank you for being here with us today, for spending your Saturday with us. We do have some questions that have come through. How do we reconcile the history of clinical trials in communities of color with our desperate need for inclusion of racial minorities in clinical trials? And what should we in the community do to help with building that trust and dismantling fear?
So I think that's a good question. And, you know, we've done a lot of work, which I highlighted, about trying to continue to overcome those barriers with regard to trust and just the, and I think the other thing to highlight too is that we know that those barriers may vary depending upon your community, depending upon where you are, depending upon what state you live in, what city you're in. So we recognize that those are all things that we need to think about. And some of the things that we've done is trying to make sure that opportunities like the opportunity today, that where you have community engaging with academic institutions, those are great ways for us to continue to work to overcome barriers. Even being able to share this information today, you have a broad reach, you're able to highlight the importance of diverse participation, but we also recognize that we also need to have kind of that bi-directional engagement and consistent engagement with the communities so that we can continue to understand where the barriers are, what they are. You know, mistrust is one barrier, but there are often many other barriers. Other barriers may be simply that I don't have transportation to get to and from that trial site. Other barriers might be that they don't have resources available in multiple languages. So I think it's important for us across all sectors that impact clinical trials that we continue to have that communication and understanding how we can continue to advance participation in overcoming those barriers, but also not getting too comfortable to say these are the barriers, but we need to really continue to evolve and understand how those barriers are also evolving. I think when we think about COVID-19, you know, also trying to understand what those barriers are specific to COVID-19. There are barriers sometimes that are specific to the disease or condition, but there are also the barriers that we talked about where how do we continue to build trust? And I think being able to continue to build trust is making sure you're not stepping in for one trial and stepping out, but when you're engaging a community that you're consistently engaging with them, that you're communicating results, that you are ensuring that you understand what their barriers are. So those are some of the things that we recommend to be able to continue to go beyond those barriers and to we can really be able to kind of have that bi-directional engagement with communities.
Thank you. Thank you. So how can we, organizations in general, the university, national organizations, how can we assist with communicating FDA research to our networks?
So we are always happy to share our resources. We have different organizations that might reach out to us and ask for print materials. Happy to share those, happy to ship those. We also, of course, have everything available on our website. So even the videos that I mentioned, they're all on our website. You can link to that. You can play it at a community event. We've heard that many organizations have been able to do that. but all of our resources are freely available for use. And the email at the, my last slide, the email there, you can always email us if you have any questions or if you are trying to reach or can't find some of our resources. We're happy to help.
Would UB be eligible to be a CRC partner? If so, what do we need to do? I don't know if that was for you or someone at UB.
So we have our FDA CRC page, and I'm going to highlight that. Our CRCs are led by the Office of the Chief Scientist at FDA, and they are collaborations between the FDA and academic institutions. And those are revisited every 5 years. So if you look at the FDA CRC website, it's more information is provided there. And also happy to answer any specific direct questions following this as well, and connect you with the right person at FDA.
Wonderful. Are you aware of the clinical trials community members can do at home that would help eliminate some of the barriers that you spoke of?
Can you repeat the question again?
Are there clinical trials that community members can participate in from their homes versus coming into sites to help address the barriers that you spoke about?
So the clinical trials can be organized in so many different ways. And I think it really is going to depend on the type of trial that you are seeking to participate in. There may be some trials where you are able to participate at home, or they may have someone that comes directly to your house. So there are many different ways how trials are designed. We always encourage that patients be engaged very early on to help in designing clinical trials. So it really would vary depending upon the trial that you are seeking to enroll in.
And has the FDA been effective in ensuring that race and ethnicity information are collected on participants of clinical trials? And is the reporting of race data on clinical trials mandatory?
So we have the reporting of race data within the US. A lot of the data, of course, that comes into the FDA may not be US-based data. So sometimes we have all of that data, and sometimes we may have some missing information. However, if you look at our drug trial snapshots, and I brought that up in my presentation, you can see that we have within the US the percent, we have the breakdown of the, for example, in the summaries. I'll use that one as an example. For our aggregate reporting for particular years, we do have presentation of that data based on that particular year and the drugs that were approved within that particular year. And it highlights, and of course, this could be US, might be non-US data, it's kind of all put together. But we also have within drug trial snapshots, you can go in and search for that drug, the new drug that's approved, and it'll give you the information for that particular drug.
Thank you.
And I do have the link to drug trial snapshots on the slide as well.
And will you be able to make that available so that we can then share it with the folks in the room? Okay, thank you.
Sure.
So this is a comment and ends with a question. Everyone should have equal access to clinical trials, as these are often cutting edge treatments. However, why do we see some folks promoting the idea that treatments might function differently in different races when all scientific evidence suggests that genetic differences in health outcomes and responses to treatment due to ancestry, let alone race, are few and far between? In other words, how can we both biologize race and say it's a social construct at the same time?
That is a very, very good question. And we recognize that, for example, in some of our trials where, for example, if we were to have diverse representation, I'll say diverse representation, and if we were to see something or a difference by a particular race or ethnicity, that then being able to have those genetic studies to understand that more would be helpful. So one of the things that we think about, though, is being able to initially get that data. And if we don't have inclusion in the trials, then we don't even have it at that basic level of being able to understand it from a perspective of having diverse enrollment, making sure that we have representation of African Americans and other diverse groups within these trials so that we have that data to be able to further analyze and understand. And that doesn't mean that that one trial doesn't prompt different types of studies that we need to explore further.
Our final question. Are there any initiatives that have been successful in other communities in getting more diversity in clinical trials that we can learn from?
I'll highlight for example, one of the memorandums of understanding that we have that I mentioned with Yale University and their Cultural Ambassador Program. One of the things there that we were looking to learn more about was because they were able to increase their percent representation across their research studies to beyond 30% minority representation. And that was specifically because they actually developed over the course of 10 years or more relationships with the community. And these were relationships with the community where they were helping them to determine what they needed to do to advance representation in their trials. They had health fairs. They have worked with them in various different ways. They actually come and educate the researchers on how best to engage with their specific communities in that specific geographic area. So I think where you have the opportunity to build those relationships with the community that are bi-directional, that are long-term, and you understand that it's not one side telling the other what they need, but really working together to ensure that the needs of the researchers and the needs of the communities are all being thought about and being equally considered.
Wonderful, thank you so much. With that, our session has ended and we will be moving into our breakout sessions. But before we do that, Rear Admiral, thank you so much for joining us today. We are beyond words. I don't know if you've been able to, keep an eye on the chat, but we are truly thankful for having you with us today. Now, as we move into our breakout sessions, everyone, you are going to use the same links that you used for our first breakout sessions. That means if you're staying in this breakout session with the Rear Admiral, you're not going anywhere. You're not going to close the screen. You're not going to do anything. Stay right where you are. Stay right in this Zoom room. For the rest of us, Joe has placed the link in the chat box for you to get the list of breakout sessions. We are asking that you return to your first breakout session so that the work can continue. Again, each session is going to build upon the previous, and we want to make sure at the end of our time that we are able to continue to move the needle, move the agenda forward with the work you are suggesting that we focus on. So that's mental health, employment, education, and housing. Your breakout session starts at 11:30 a.m. Thank you all for being here today. We will meet back here. Now, listen to this. After your breakout session, it's lunch. So we are going to meet back in this room at 12:55. And we will start with our final keynote speaker of the day. So you're going to your breakout session, which starts in 4 minutes. Then you're going to have your lunch and then meet us right back here in the main Zoom room at 12:55. Thank you all so much. We will see you in your breakout sessions.
Hi, I'm Lewis. For this breakout session, we'll wait maybe a minute for the Rear Admiral, and then we'll begin.
Let me just interject, if I might, Louis. Richardae, if you are able to join in this breakout session, it's really like a continuation of the question session. We would absolutely love to have you. I know there are certain guidelines that we need to follow with the FDA that I want to respect as well. So I'll leave that to you.
Sure, I can join until about the next like 11:45 or so. I have to hop off before noon, but I'm happy to join for a few minutes. And I'll be very open about the areas that I can't answer those questions, but I can also redirect them to our mailbox or through our press office if we need to.
Thank you so much. Take it away, Louis.
Thank you so much. This has been great. Thank you.
Thank you. All right, well, welcome back to the main room breakout session. Again, this breakout room is here to sort of give a deeper dive into the conference topics and answering any lingering questions that you might have forgotten to ask already. For this session, we're back here with Rear Admiral Araojo, who's the Associate Commissioner for Minority Health and the Director of the Office of Minority Health and Health Equity for the FDA. She is basically here to talk about her last keynote speech. And we also have with us Dr. Tim Murphy, who will be joining us as well. They're both happy to talk about the keynote speech and take any questions you might have. Again, if you are accessing us via Zoom, please feel free to contribute a question by either clicking on the raise your hand icon or send me a question in the chat function, and we'll try to address as many questions as possible. Rear Admiral, would you like to add a few more words about your topic first, or should we move on to the questions?
Sure, I'm happy just to state that again. I think hopefully, I hope the message from the presentation I provided is, one, understanding that we do have an Office of Minority Health and Health Equity at FDA that continues to work to advance the health of our diverse communities. Of course, we are very focused from an FDA mission perspective. So one of our priorities is working to advance clinical trial diversity. And with that, we have a particular focus on research and outreach and communication. So that's the scope of the work that we do, and we appreciate the opportunity again. And I want to say a big thank you to Dr. Murphy and everyone for being able to participate and be a part of this event. This has been great.
Thank you. Thank you. So the first question we have from the chat box is, if you could speak more to how the health disparities and the disparately heavy impact of COVID on Black and Hispanic communities have sort of impacted the recruitment of patients specifically for COVID clinical studies so far.
So the one thing I'll mention, I talked about this a little bit earlier, is how, FDA ourselves, we're not conducting trials. But in general, when we're thinking about clinical trials and trying to enroll diverse communities and populations, one, we already know we have barriers from a broad perspective. And then when we're within a pandemic and COVID-19, and there may be unknowns for many of us, I think that also impacts how we're able to recruit and enroll diverse communities, especially when we hear oftentimes about the concern of mistrust based off historical abuses. And the one thing I always highlight and say is that we have to remember that there are protections in place, but we also have to make sure that we ask questions, make sure you know the facts, make sure you understand possible risks and benefits, and also remember that the one area that I'll think about and highlight, and this is even outside of COVID-19, is just that, we want participation and enrollment in trials to reflect those who are most likely going to use the product. You heard me say that in my presentation. And the reason for that is so that we have data, so that we can really communicate data to be able to say, how this impacts all of us.
Let me add, if I could, also to that question, and that is, in essence, how has the pandemic changed clinical research to a certain extent? I can comment on some of the experience we've had in Buffalo, and that is, in many ways, it's reduced some barriers. So we have a pandemic by a disease that is lethal, and we have families with family members who are in desperate condition, and there's the opportunity to participate in in trials that may bring new drugs that could make a difference. And so we've seen in some ways a reduction in barriers about that because of the urgency of the situation, which is interesting. I think it also is bringing clinical research more into the national conversation. When you listen, even in mainstream media, what are people talking about? When's the vaccine coming? You know, what's happening with the trials? When are the new drugs coming? And I think it just brings this whole topic higher into a higher level on people's radar screens of what's the role of clinical research in healthcare.
Thank you, Dr. Murphy, and thank you, Rear Admiral. So the next question is, what are the various ways in which the concerns of minority community leaders have been addressed in regards to, say, past inequities in clinical trial practice? And what do you envision as sort of the future for this in terms of addressing these needs?
And Louis, is that one to me? You want me to start off?
Yeah.
Okay. The future in addressing those needs. I think that when we think about clinical trials, and I think it really starts from the very, very beginning, when that trial is being designed and thought about, and I think patients really need to be at the table so that we can ensure that very early on, we're designing these with the patient in mind, because ultimately that should be the priority, with the patient in mind. So that's one thing that I think about, and a big part of that is being able to have these types of partnerships, collaborations with the community and others so that you can adequately do that. And I think the more that we're able to come together and work together, I think that we can continue to advance and solve the issue of, for example, how do we get our different groups and communities to participate, and also making sure that we have that meaningful representation in those trials. And it can vary depending upon the disease or condition that we're talking about and thinking about. So I think that as we continue to have patients engaged and at the table, that will help us continue to advance and solve this issue.
Thank you very much. So I think the next chat box question is, you've really spoken a lot to how the FDA has been involved in various partnerships and the various programs that you have done to sort of address these different inequities. So I think the question is then, have you seen any sort of demonstrated strategies by other organizations out there in the wild for effectively increasing participation in clinical research by historically marginalized communities, and maybe ones that you would like to highlight as good examples of what to do?
I think, you know, there are a number of different examples, and I'm trying to highlight just a couple. So, for example, there are a number of different diversity projects. I highlighted only one in my presentation. There are so many projects that are out there working to bring multiple stakeholders together to try to solve the issue. There are community leaders that are engaged in these types of projects. The other thing that I would think about where we start to talk about how we can be successful is making sure that we are keeping these programs very visible and highlighting the work that's being done. Where we've seen the most success, I think oftentimes is where you are directly engaging patients and communities. And I think that, so again, as you can hear from a lot of the things I've talked about, is the community engagement piece, which we think is very important. But we also have to make sure that we're thinking about this from our researchers, from industry, to highlight why it's important for us to make sure that we have these types of efforts that really value the importance of diverse participation, because it's not going to just be us engaging the community. We have to make sure that from that very beginning design standpoint, they understand that this is a priority, that our sites understand that it's a priority, that we have resources at our sites to make sure that we have information in multiple languages, So I think that there's probably not a one-size-fits-all solution. I think it's really a matter of all those different sectors that impact clinical research coming together and working together, not working in a silo, but trying to work together to achieve our ultimate accomplishment of trying to get, for example, diversity in clinical trials. So I think that would be an area. I wish I had the solution, like this is the one thing, but I think that there really isn't that one-size-fits-all solution, but rather all of those different sectors coming together.
Thank you. I think we can all agree that it's really important to directly engage communities and really put that emphasis on accessibility for different communities to engage. I guess with that in mind then, what do you feel are sort of, and this can be both for you and Dr. Murphy if we want, what are the sort of the current practices of reaching out to the community by clinical trials? And what are your thoughts on how the state of the current practices are?
So I'm looking at Dr. Murphy. I'll start and then I'll turn it over to you. I think some of the practices, what I have heard, and I'll say what I've heard from communities, a practice that communities do not like is when you engage with them for one particular trial, you step in, you step out, and you're done. So I think one of the things where a practice that I think is a good practice is when you engage that community on a regular basis and you're really building a foundation and relationship so that you might be doing health fairs. You might not just be focused on that particular research project, but you have other opportunities to build that trusted relationship between your organization and that community. So I think that's really important to make sure that you're continuously building that community. And the one thing I'll also mention, and this is kind of to the prior question where we talked about how do we make sure that you understand and have access to trials? And I think there's even opportunities like this where you're building that relationship and through this type of community engagement. The other thing I'll highlight is that where we have heard a lot of, if you are aware of it, and one of the things that we also try to make sure that our communities are aware of are patient advocacy sites, because oftentimes they do have a wealth of resources. They have clinical trials for that particular disease and condition in one place, so you can really have access to finding information, as well as other ways to find information about clinical trials. So I thought I'll just throw that in from the prior question as well.
I think that is just right on. And in terms of the question about where do you think the state of things are now, I think the state of things now are all over the place. I think we have investigators in Buffalo who do exactly what Admiral Araojo said not to do. And then we also have investigators in Buffalo who are actively and meaningfully partnering with the community. I think one of the key things is if you design an entire trial and then you get the funding and you're ready to start, and then you go, okay, community, let's work together. That's a failed strategy. The way to do it is you start in the beginning when you are thinking about what trial to do, how to design the trial. You engage the community in a meaningful way right from the start. And it's a culture change, I think, for some of our clinical researchers who have been doing this differently for a long time. To me, if there's one thing to do, that's the thing to do, I think, to overcome some of these barriers and act like real partners.
Thank you. That was a very sort of enlightening overview of how everything is, and it provides a lot of ideas for what could be done.
Let me, it's 11:45 and Admiral Rojo said that you have another commitment to get to. And I just want to, on behalf of all of us, RADM, thank you so much. What you've done here is just raise the level of our discussion here and given us a lot to think about and a lot to work on. And so much appreciate your important contribution and participation.
Well, I just want to thank you so much for the opportunity to be here and to participate. And this is just great. I'm looking at all the questions that are coming in. So I will definitely follow up so that I can connect. I know there are a couple questions even related to cultural competency and training. So again, thank you so very much. I appreciate the opportunity to be here and look forward to next year, I hope, as well. Thank you.
Thank you so much for joining us. All right. So I think oh, sorry, go ahead, Dr. Murphy.
No, so I think now you're stuck with me.
Good person to be stuck with.
So what I would really like to do then, instead of answer questions, I'd like to ask questions. And I think that some of the points that have been raised, a key point, I think a fundamental issue is trust. And, you know, the historical mistreatment of African Americans in particular and minority communities is a reality. And it's a reality, but my hope is that that reality will not continue to deprive minority communities and African American communities in participating in the beneficial parts and the benefits of clinical research and the benefits, and there are many of them, you know, bringing the latest advances in medicine. So I guess really we could use a specific example of the vaccines. The vaccines for coronavirus are coming. And as an infectious disease physician and as a person interested in public health, I firmly believe that that is going to be one of the most important solutions that we have to ending this pandemic, you know, so that we don't have to socially distance for the rest of our lives, you know. So my question is, tell me about the barriers, or let's talk about the maybe ways to address some of the mistrust and some of the barriers to vaccines in community in our East Side minority communities in particular.
Tim, this is Nancy. I wonder if I could just piggyback on that and say, you know, using a vaccine requires that you have access to the vaccine. And I want to be sure that there's equitable distribution so that it's available. If it's not available, you know, you can talk about overcoming barriers of trust, but we have to make sure that the availability is there for those who are most at risk.
Tim, I'll help us kind of get started in the conversation. I think it all goes back to relationships. You know, I mean, we're so segregated and disconnected at so many levels, whether it's, you know, we looked at the issues around housing, we looked at our issues about where our children go to school. And so there's just this, we're just very, very segregated without, you know, not by law, but just by practice and behavior. And so, you know, there's such a distance between institutions and the Black community. And so I think one of the key things we have to do is really work on, you know, relationship building. I mean, you know, you can't just come to people that you don't have a relationship with or haven't connected with and say, hey, participate in this clinical trial. I don't know you. I don't know you from any, you know what I mean? And so I think we have to really figure out ways in which to really break that stuff down.
Hello, good afternoon. This is Jonathan Dames. I'm a pediatrician, and I think Pastor Nichols just said it right on the hit the head nail on the head. Nothing will get done without relationships. I've been practicing for almost 20 years, and I can tell you most of my clientele is a very diverse clientele, but it's predominantly African American, young parents, as well as grandparents and aunts I see in the office all the time. And it's hard enough right now and getting them to sometimes get them to get an MMR immunization, which has been around for a while, let alone the conversations regarding the flu shot, which has been around for a while, and the misperceptions of, you know, if I get the shot, I'm going to get the flu. I hear that almost every single day when I bring it up. And now you're talking about COVID, and after having these discussions, it sometimes comes down to Doc, what do you think I should do? And it's because I've built that relationship over the years that they feel comfortable and going with my recommendation. But if I'm just seeing them for the first time, I have no capital. I have not built any equity. And so it's really, really tough because there's an inherent deep mistrust actually from physicians that don't look like them and trying to tell them what to do. So I think part of it, and again, being in admissions, is creating the new generation of physicians that can go into the community, that look like them, that have shared values, shared experiences, that can help kind of build that bridge between the science and the myths around immunizations just in general. So that's kind of my 2 cents.
Thank you. Pastor Pointer, I like your comment regarding the language and some of the ways that we talk about clinical research and clinical trials. Would you expand on that a little bit?
Well, sure, Dr. Murphy. Good morning to everyone. It's good for everyone to be here today. I think it's really critically important for us to know, recognize, and understand that we don't share common languages across cultural distinctives. So we've got to endeavor to connect with the people that we want to work with. And we've got to nuance languages. The highly technical clinical language that's often used in presenting clinical trials and the very fact that you're seeking to do research, we've got to find ways to make that language comfortable, as well as to make it so that it's not threatening. Because often we deal with communities and pockets within communities that are not as sophisticated, that have not had as much access to higher education as often as clinicians and researchers. And so you've got to make a deliberate effort to make a oneness with what you're talking about and explain things in common everyday language that doesn't move people away from you at warp speed because they didn't understand one thing you said. And so you know, I was talking with this privately in the chat with Dr. Grinsley. When we began to work in the School of Nursing or with Million Hearts in the community, we made a agreement between the community and the School of Nursing that first and foremost, this would not be a one shot, that this would be a long-term relationship, and that while it may take us time to build that relationship, we would keep working at it. So it's about commitment to a process that will extend over time. And as Dr. Daniels highlighted in his discussion, without building capital and developing social means for communicating back and forth, without people having to say, okay, what did you mean by that? I don't understand that. We really have to make the effort to put language where everybody can understand it initially, where we take out all of those red flags and the technical clinical buzzwords that clinicians use among themselves on a regular basis, but which really fall flat when we're dealing with people whose educational attainment, through no fault of their own, is not as advanced as the people attempting to do the work. So it becomes really important. Let's find language that conveys the technical reality in a way that doesn't scare people.
You know, that's a great insight. And if I think, so I'm always thinking about how, all right, how can I take these insights and these comments and leverage them and do something to make it happen. So what if in our CTSI, we actually developed a training session about how to talk about clinical trials. I think traditionally physicians and researchers do a bad job of communicating what they do. It just, with all that technical language, it's a skill, but it's a skill I think that we haven't invested in terms of training all of us how to do it. And, you know, maybe, and I haven't even seen that in some of the national, you know, across the CTSA consortium and that sort of thing, specifically training about how to communicate in an understandable way to different communities about clinical trials.
Well, I think Dr. Murphy, you hit on something, and let me remind everybody that we're in Buffalo. Buffalo historically is a place that has led this nation with doing things initially. I mean, and I'll give you a quick set of proofs. Buffalo was the first community in the United States to say we need to educate all the students in the community, and in 1838 created a school district. In 1893, Buffalo said we need somebody to lead this educational effort, and Buffalo created the term that's now codified around the world for leading a school district called superintendents. And then we installed Harry Emerson as the first superintendent of schools anywhere. So, I mean, we've led in a number of ways, and I won't go into all of them because, you know, I'm a Buffalo buff. I'm not just Buffalo born. But I think this is an opportunity again for Buffalo to lead. I think what we're doing with the CTSI, the Clinical Health Equity Research Institute, the Buffalo Center for Health Equity, this kind of relationship doesn't exist in any community around this country. This is an opportunity for us in these new budding relationships to also do some additional innovation. And let's begin by, let's have some focus groups and let's have some conversations with just everyday walk around people in the community. And let's develop a glossary of terms that could be used interchangeably, and then we might be better equipped to begin to talk about training clinicians and researchers, because clinicians and researchers they're amenable to being trained just simply based on the fact that they spent most of their life in training. So we could do it.
But the thing to me personally is that there is a whole sector in the private sector that knows how to talk to the average person. What I mean by that is, look at pharmaceutical companies. Now, the researchers may not know how to talk to the public, but they have a whole marketing division that does. And they've been very successful at getting people to buy into things they don't need. Why can't you incorporate the techniques they use to get people to buy into things they do need? It seems like you're not really getting far enough afield. You're looking to get expertise from people whose expertise is not in the area of reaching out to the average person.
Well, Mr. Marcus, I appreciate your viewpoint. I appreciate your viewpoint on that kind of expertise, but let me just offer you this. I am deeply offended by a lot of things that pharmaceutical companies and others who are specialists in advertising say to us in their advertising. I think what we're talking about is a great deal more nuanced than that. I think it's about building the relationships and then the know-how at the grassroots level, and then in that way, using that to inform ourselves as clinicians and researchers so that we could do very specific work in a targeted way to a specific community. That's what I was talking about. I didn't want it to be, I'm not suggesting that there aren't methodologies and processes. There certainly are, but I'm just warning you that those methodologies and processes are already skewed and already disdained by a large segment of the community. And so if we start at the grassroots, we can actually work together to create what we're talking about.
I still think that if you look at the overall media and you say, I don't like the way they're doing things, it's not the same as saying, I don't like what they're doing in terms of reaching people. And if you know, it's kind of, in a way, a lack of inclusion to say, well, we're so good and they're so bad. There are a lot of people who do a lot of good work whose work is not recognized because they don't know how to reach the average person. But the people who do know how to reach the average person, if they are solicited, the right people can easily make an impact with the average person that you guys don't know how to do.
I mean, one of the things that I tell our students in medical school that I've been told is that we learn 10,000 new words. And those words, if I knew 10,000 words in French, not only would I be able to speak, I'd be at a translator level. And I find myself actively translating in my mind when I'm talking to patients to try and hit the right level. And I think it's something that people have to practice, and it's a skill that, you know, I don't know that we teach our students enough, or our residents, or ourselves enough.
Great discussion.
So I actually have a question of my own. So thank you so much for talking about building relationships and sort of developing a more compassionate vocabulary. I guess one of the things that we're always afraid of is, as we make things more accessible in terms of the way we talk, as we try to simplify things, we are always afraid of sort of crossing over that line into maybe something patronizing, or maybe something that seems a little paternalistic. What would you say might be some guidelines to, you know, walk that line well, to be very understanding of other people without, you know, making them feel like they're belittled at the same time?
So, Dr. Wong, you don't have to do that with people you know. We got to just find spaces to get to know people, and once you get to know someone, if you do that, they'll correct you, but not in a way that it will destroy relationship, right? Because when you know somebody, the people will get to know your hearts, your intentions. And sometimes when you get to know a person's intentions and its hearts, because you build a relationship, you're able to overlook some behaviors that come from a place of not to try to denigrate, but just because you don't know, and then we can help build that knowing. But when you don't have that relationship, when you don't know a person, and their behavior or their words are insulting to you, then you just want to sever the relationship, or it triggers the preconceived notions you may have about that person based on not having a relationship, and then you just say, "See, I told you." Right. And so it really just gets to that, you know, it sounds hokey, but it's real. It's just, I just think sometimes in America, we're in denial about how divided we are racially in this country. And especially Black and white, the division is huge. And it really goes back down to relationships. As a pastor, one of the things I can really say real quickly is one thing about in general terms, if a Black person just tangentially knows you, they'll come to your funeral. I mean, they don't have to be like deeply involved in your life, but if they might have met you, you might have been the just a postman or somebody that, but they'll stop by and pay their respects. And I'm always amazed at the times when I will do a funeral for a white person and nobody Black comes. Not to the wake, not to the service, nobody. And that makes me realize this person lived there almost their entire life, making no connection, not a deep connection, but not even a tangential connection with a person from the Black community. And that's frightening. And so we got to figure out ways because we can't get this work done unless we figure out spaces to do the relationship building.
I want to build on what you just said, Pastor George, because I think that when it comes to research,
we need to include the community and let them help us shape things. So it's not paternalistic. We're coming to you to, and here's the language, and are we messing up the language? The important thing is have the community involved in developing the language in the first place. Nothing about us without us, I think, is key.
This is a wonderful discussion, and I don't want to interrupt it. On the other hand, we have to get back at 12:55, and we should give people time for lunch.
Well, thank you very much, everyone, for your participation. We can go ahead and break for lunch, and then we'll be back for the next keynote session.
Thanks so much, everyone. Great comments in the chat as well. Really good discussion. Thank you.
Oh. Hey there, it's me. Just wanted to see how you were doing, how Laura's doing. If you get a chance, give me a call. We have a lunch break now, which goes till 12:55. They didn't provide a virtual lunch, so I guess we're on our own for lunch. I already had lunch, so I'm just going to chill out for a little bit. So I'll talk to you a little later. Give me a call if you get a chance. Love you. Bye.
Dr. Marcus, I think your microphone's still on. It's good now. It's good.
Good afternoon, everyone. Thank you for joining us for our afternoon session. We will be starting back up in just 1 minute. As a reminder, please use the chat function to ask questions and to post your comments and have conversations. We are recording, so if you are not interested in having your face show up on the video, please turn your video cameras off. Also, if you are experiencing slow internet connection, if you turn the video off, you will receive better visual coming in. We have one more breakout session after our afternoon guests. I feel like there are some other things I should remind you of, but I can't think of them right now. So if you have any questions, please drop them in the chat. If you don't want to post your comments to the entire room, I am Kelly Marie Wooford. You can send them directly to me or any one of the co-hosts that you see in the chat feature. With that, I will turn the afternoon over to Dr. Murray.
Hello, everyone. Welcome back from lunch. Just a great morning. I thought 2 outstanding keynote talks and the breakout session that I was in following each of the keynotes were terrific. We had the extra bonus of Rear Admiral Araojo stayed on. We weren't sure that she was going to be able to, but really a wonderful discussion. It's my pleasure now to introduce Pastor Pointer, who will introduce our keynote speaker, Dr. Raul Vazquez. Just very briefly, Pastor Pointer is pastor of Liberty Missionary Baptist Church, co-convener of the African American Health Equity Task Force. He's chair of the Board of Managers of Millennium Collaborative, chair of the Erie County Poverty Commission, and board chair of Greater Buffalo United Ministries. He is a very influential and enormous contributor to the community. And he spent his last many years working in multiple ways to eradicate social determinants of health in Black and Brown communities in the region. He's also a great partner and friend of the university. He's on the adjunct faculty for the Jacobs School of Medicine and Biomedical Science and co-teaches a very innovative course, Health in the Neighborhood. And I can say personally, he's been a great partner working with me as a mentor to minority medical students as part of a training grant that I run called Training the Next Generation of Physician Scientists. So he has been especially welcoming to the students who we've recruited from outside to spend the summer in Buffalo. And I really appreciate that partnership and enjoy that so much. So it is a pleasure to introduce my colleague and friend, Pastor Keinzer Pointer.
Thank you, Dr. Murphy. I always am challenged in these Zoom, WebEx, Google Meet presentations to master the technology. I want to, again, welcome everyone for joining us in the 3rd annual Igniting Hope Conference. We trust that you found the morning not only exhilarating, but informative. It now falls to me the high privilege to introduce a great friend and colleague in this Western New York community. So let me share just a little bit. I could introduce Raul Vazquez extemporaneously, but I think it's so important for you to know who Raul Vazquez is that I think it's important for me to share with you just a portion of his journey. Raul Vazquez, MD, FAAFP, is the president and CEO of G Health Enterprise. He's a primary care physician who established and opened urban family practice on the Lower West Side of Buffalo in 1996. He was decades ahead of his cohort in medicine and using informatics to diagnose and to maintain the conditions of his patients at the touch of a fingertip. So he uses technology well in his practice. In 2016, the National Committee for Quality Assurance announced that Urban Family Practice of Buffalo has received level 3 NCQA patient-centered medical home qualification. Level 3 is the highest designation of recognition that a clinical practice in the neighborhoods can receive. Recognizing the need for coordinated person-centered care for Medicaid recipients with multiple chronic conditions, Dr. Vazquez formed the Greater Buffalo United Accountable Healthcare Network, and the New York State Department of Health approved the designation as a provider-led Medicaid health home in 2012. The state established 26 health homes across the state. GBON is one of only 2 that are entirely led and owned by minority practitioners. As president of GBON, Dr. Vazquez leads a team of dedicated professionals in the medical and business fields. He set the strategy and direction for the fast-track growth of GBON. Under his guidance, GBON has grown to over 7,500 members and employs a staff of over 200 individuals. GBON is one of the largest minority employers in Western New York. Incorporated in 2008, the Raul and Tony Vazquez Foundation, Raul and Tony's Machinations, has a sole purpose, and that is to protect and enhance the abilities of nonprofit healthcare organizations to serve society and the communities that they serve in. Through research, public education, and advocacy, the foundation seeks to provide a strong, cohesive, and persistent voice for this nonprofit healthcare organization's common goals and challenges with providers and others. In addition, through education and other types of programs, the foundation seeks to establish and enhance the performance of nonprofit healthcare organizations in carrying out their unique roles and responsibilities in the minority community. In June of 2009, Dr. Vazquez was nominated by then Governor David Paterson and approved by the New York State Senate to serve as a member of the New York State Medicaid Advisory Committee. In June of 2012, current Governor Andrew Cuomo and the New York State Senate approved Dr. Vazquez to serve on the Minority Health Council. He's won more than 20 awards for his accomplishments in business, the medical field, and advocacy groups. Dr. Vazquez has served on numerous boards and organizations, some of which are Upstate New York Transplant Services, Healthy Link, and WNED-TV. Dr. Vazquez is an undergraduate of Fordham University and holds a medical degree from the medical school at the State University of New York at Buffalo. What I like about Raul Vazquez is he is unafraid to tell the truth around racial health disparities, and he is unafraid to take on anyone when it comes to the challenge of dismantling those. It is my distinct pleasure and privilege to introduce to some, to present to others, my great friend of over 25 years and my colleague in this work of eliminating health disparities in Buffalo. Please welcome Dr. Raul Vazquez.
Hey, thank you. Thank you for having me, Reverend. I guess you have my slides. You know, one of the things that we wanted to kind of, as we put this whole thing together in terms of the presentation, is I think for the things that I wanted to do within my practice, and the reason that I started this back in 1996 was that I felt that communities, for some reason, were served in clinics and really not in a private practice model. And I felt that, you know, people had to have a choice for both. We ourselves established a model where we are for profit. And I think in our communities, a lot of times they look at being for profit as a really bad thing. And I think it helped us in light of what happened. Do you have my slides at all or no? Kelly, do you have my slides?
I don't. I'm asking
I have
Joe.
them. I can share my screen. Do you have them, Joe?
I had sent them in.
Yep, we got them.
Okay. Yeah, if you can.
I'll share.
Yep. Thank you. Okay. So I think what we wanted to do initially was, remember, as we put this committee together, one of the things that was real important to us was we brought together, the Buffalo Center for Health Equity, Jericho, the IPA, Urban, Jabaco, GBON, which are all part of G Health Systems, the Hispanic United of Buffalo, the Bell Center, Endeavor, and when we call these individuals to come to the table, they just showed up, which was pretty amazing to me in terms of what we were trying to do at the time. And because we weren't waiting around for things to actually happen, we just kind of, let's look at the data and let's start doing things. I think for us in G Health world, we manage 15,000 lives. So we felt that if we infected those 15,000 lives times 3 with information, we could really start touching a lot of the players. And then the churches, because of the trust that's there on both the African-American and Latino communities, we can really expand and really touch a lot of people's lives and save people. And I can tell you on the 15,000 lives that we played with, we lost one. One's too many, but we did lose one person. And a lot of what we did to save people is because we were there in the point of when there was chaos. I mean, there was chaos in the hospital, chaos in the Department of Health. And since we have a close tie and more of a grassroots approach to that population and communication, it became a lot easier. Next slide. Yeah, so this is what we started out with. We wanted to focus on treatments, testing, teletriage, population health resource, and informatics. And it was easy for us because we just repurpose our people. We were looking at ways to, if we're going to do the testing, how do we do that? If we're going to do the telemonitoring, how do we do that? If we're going to isolate, who we're going to do this with. And I think the churches, really kind of stepped up in terms of moving with us. And in the beginning, we both shared platforms. We got them to get on our platforms to show the value of what churches can bring to a community. Because a lot of times you have entities that are out there that really don't show value because they don't have the data to show their value. So we wanted to do opposite to that. And so we targeted high risk, low income individuals and with moderate to mild disease. We, at least on our side for Urban and for GBON, we developed our databases and files and basically did robocalls with the right information in terms of letting them know what the symptoms were, what they needed to do, and a lot of information at home where, people were just telling you stay home, but how do you feed yourself? Stay home, but how do you not express this? So we were just constantly giving members information and also tied them into our nurse call system. So since in the beginning we were trying to get as many tests, but they were very difficult to get, we were just lining people up. And in addition to the teams, we had teams that are around each one. And on the treatment side, we were exploring a lot of the different things back in March, at the end of March and April. We were really, some of the therapies they're talking about now, we were looking at. And I think for me, it touched home when my daughter got it. So I was really trying to learn as much as I knew about. I became a virologist in infectious disease overnight because I was scared for her. The outcomes that we wanted was improved treatment, reduce mortality, and also reduce the burden on hospitals. We literally told patients not to go to the hospital, and they were calling us with a lot of the symptoms. Next slide. So this is the platform in terms of a COVID-19 response. Again, the practices that were heavily involved were Urban Family Practice. Jericho stepped up. I mean, Dr. Glick was, my brother in this fight. I mean, there was no differences. I asked him for this, he asked me for that, and we were sharing data. So we were exploring the symptoms. He was the first one to kind of see the decrease in taste and smell that was being detected on some of these individuals. And we all started kind of learning through that process. But if you saw that by going through this whole thing and then bringing in the churches and having them get into the database was really cool because they could call individuals. We had our people calling, but they were calling individuals that weren't part of our network, that didn't have primary care doctors. And in addition to that, screening them using tools that we had for COVID testing, for social determinants of health, and contact tracing. All that stuff was almost like prepackaged. We use our training platform and got a lot of, Dr. Pointer's people fully trained and working on the same page and having weekly meetings to make sure that we were having an impact on the community. Tied up with Endeavor, so that if there were mental illnesses and things like that, that was the key that was really important. On this next slide, what you saw was the telehealth visits that we employed. I mean, urban, especially our practice, we've been doing telehealth since 2017, but it hadn't been picking up. Came March, that weekend, we sent everyone home because I didn't want to serve as a point of infection and bring more people in and really infect the staff, infect the patient, infected the community. So that was important. On the care coordination piece, it was also something we did. Now, when you look at what we wanted to do was, can you go back to the other slide? I'm sorry. On the other slide, when you're seeing this, we were looking at points where if people have mild to moderate symptoms, we were employing telehealth models, and we were using something called Tidal Care, which were these virtual visits where we can actually get lung sounds when we had PPE available, get oxygen levels, and really assess people. Because we saw not only the cytokine storm, but the inflammation. We were doing inflammatory markers and seeing all that inflammation and seeing, wait a minute, people are being discharged in 3 days and they're dying at home. Something's wrong here. Some people are being on the ventilator and they're dying on the ventilator. Something's wrong here. And so we were constantly kind of changing our model and really working with the community. I think the biggest issue we had was the hospitals were in chaos when all this stuff was going, and they were trying to do their own thing and really not tying into our sector. The Department of Health was also in chaos, here in the county, and they weren't trying to communicate with the doctors. They were telling people, well, you got to talk to your primary care in order to get tested. Well, if you don't have a primary care, there was a lot of issues. So we were just kind of doing things on our own. The one area that we didn't do that I feel for the third wave, I know everybody talks about the second wave, but in the Spanish flu, there were 3 waves. In November to January, it mixed in there with the flu. We got to see the second wave in March, but the third wave, which you talk about sometimes in mid-September, if it gets really bad, that's not going to be a U-curve type of involvement. By U-curve, I mean the young and the old were hit hard. In September, in the Spanish flu, it was a W. So people between the ages of 20 and 40 got hammered hard. And a lot of that has to do is, just like the virus looks pretty good, and we'll show you some slides at the end in terms of our percentages, I find that when it starts to pick up, it's an area that we're going to need to start looking at. We still are not talking about carriers, and I still think we have a good portion of carriers within this market. Next slide. I think telehealth was important, and as you saw, as we trended, it's crazy, but in the primary care world, we ended up doing better financially under the telehealth model, so we did not lose any resources during this time. We have big groups in the community medical practices that weren't equipped to do this. They had to shut down, and that was not a good thing. So that was one thing that I think helped us really get through this whole pandemic. Next slide. Teletriage was something that we developed, and we were supported by Millennium in terms of one of its grants. So we got those dollars and set up the system. When the grant dried out, we continued it. So it allowed us to really have sort of nurses on board that were handling calls coming in, that were setting up televisits with our EMR system, and that were giving out a lot of advice. There were also, once we were testing, they were the ones connecting them to either our system, other systems, to follow up with telehealth visits. And a lot of information was going through there. We, at our G-Health system, we managed about 2,000 calls a day, which other systems cannot handle. And we repurpose our people so we could push to 4,000 calls a day. Every call comes in, we track, we record, and we measure, and we almost do an AI evaluation of the call to make sure that we're doing a good job by the members that are calling in. Next slide. I think this is the telehealth. Remember, this isn't before COVID, so they would be recorded, but it allowed us to really go out there and really do a whole virtual exam. It was important for people that may have had symptoms of bronchial findings, where this would not only check temps, but you get lung sounds, heart sounds, bowel sounds, video of the throat and ear. We could see all that stuff. And I think that's a level that we don't have even today in telehealth, but it allowed us to really get into people's homes. We were also able to get people that were really admitted to the hospital, COPDers on oxygen, instead of having them come in and go through transportation and really get infected by the time they got to the office. We were using this equipment to keep them at home. And I think that really helped, and they were happy with that. Actually, most of them like that more now, so they don't really want to come into the office. Next slide. This was an interesting thing. We had apps for many years that we put together. So I was able to kind of repurpose them in terms of pushing them out so that we could do a COVID-19 survey, and it's tied into our database, and the churches also used it. So if you had the symptoms, it was going to be, if it was positive, it was going to trigger to the nurses who would reach out and set them up for testing. The community support survey, or the social determinants of health, GBON as a health home, you know, we have about 95 navigators, and we manage about 8,000 lives there. So our people know these individuals on a, you know, they talk to them every month. They take them to the doctors. They get them food. They get them transportation. So that connection was real important. And I know as we talk about the trust is, you know, when they get calls, they think it's a bill collector, but with us, they know it's us. And I think what that allowed us to do is, even at the point of when a test came back positive, they could actually, we were trained in our order, you know, our electronic systems were contact tracing focused. So we were actually teaching them, talking to individuals, figuring out the transportation patterns, making sure they're doing everything possible so that those 14 days, there was not a lot of infection. And when they got out of them, they would give us temperatures that were also recorded on the apps, and we were keeping the data, which helped in this whole process. Next slide. The Holland it's a referral management system. We had it for, you know, so Jericho and Urban Family Practice and the IPA, like Dr. Glick, Dr. Gills, Dr. Forte, Dr. Dwight, these are inner city practices that are all together. We communicate through our electronic records and also our SharePoint and our cloud. We have a cloud in terms of data, but for the downstream providers and some of the CBOs, they don't have that kind of system. So we activated Halon, and what this allows us to do is really transfer information back and forth and allow the entities that did not have electronic records to get referrals from us and also close those referrals. Next slide. This is an example of what it does. So you're transferring all secure, HIPAA compliant information, and it's going back. So you can have a CCD or continuous care document going back and forth with an entity, because the problem we have is in primary care, 50% of referrals we sent out never get through, and they cost the system a lot of money because we're referring people for the right reasons, but they never make it. This allows us to kind of close things. So if there's food problems occurring, we would refer to areas that focus on CBOs with food, things related to other things. We were just using this vehicle to do that. Next slide. And remember, the nice thing is we have dashboards. So this is an example of our GBON performance dashboard. We tied in the ministers to our Jabaco performance dashboard, but this basically takes data from all our SharePoints and all our servers and all our electronic records and everywhere. And we created almost an AI reading this stuff, and we can pretty much look at everything from calls, how long the calls, who, you know, the data, who's seeing what documents are being done, which patients are having issues. It gives you a concept of risk scores for the individuals, how much of a cost have they been to the system because of emergency room. We have one individual that went to the emergency room 115 times. So, you know, how do we avoid that? And we've been able to kind of decrease inpatient. So we dropped ER rates anywhere from 64% since 2013, and they've stayed there with GBON. We've dropped inpatient by 84%, and they stayed there. So, you know, when people in the community, there's a trust, there's a medical neighborhood model, it works. And I think COVID-19 let us know that it worked. In addition to, the next slide. You know, this is what I was talking about. You could see the gaps in cares for these individuals. That means what they need. Someone asked a question, well, were the asthmatic people treated if they were African American and Latino and white the same. Sometimes it's not the case. And it's not the case because the systems are set up that when you come in for sick care, we take care of that. And these gaps often don't get done. Now, because of value-based medicine, they become an integral part of payments and rewards. So there's more of an inclination to really look at these things and really make sure that everyone is a dot in that system and everyone gets the same kind of care. Next slide. This is an example of what the contact tracing looked like. What we were able to do was not only put all this information that you didn't have to be a contact tracing expert. You know, we were able to do our own. And I think towards the end, I'll tell you what with our models going forward, it's going to help us kind of do this like within a half an hour of the testing. And I'll describe that towards the end. Next slide. Flow sheets. These flow sheets are built into our system so we can track and we know exactly what medications, who's living there, what kind of chronic problems. So as you're doing the COVID-19 kind of testing, you're looking at things. So one of the things that we found early in the course were that this virus was really, it really took advantage of the RAS system, the renin-angiotensin system, which in our communities is often what causes our hypertension. And it's funny that in the 1940s, African Americans in the medical and cardiology literature did not have hypertension. That the books say if they were Black, you don't treat them for hypertension because their physiology was different. That was in the 1940s. We're in 2020. Wasn't a long time where there was just misconceptions of how you treat people. But we found that because of the RAS system in the Black and Latino, those RAS systems created more airway with the receptors in the lungs. So there were these ACE type 2 receptors in the pneumocells that allowed the virus to get into the system. But if you were taking ACE inhibitors and ARBs, we saw less. It was almost protective. And now some of the cardiology and some of the other literature is looking at that as a possibility as to why some individuals were not infected. Insulin had the same effect. Inhaled steroids, which everyone was talking about, was stop them because, you know, they're causing, no, we kept them. They reduced the number of receptors, less penetration of the virus. So we were learning the science at the same time and really helping people get through this crazy time. Next slide. This is the data. So as we started pulling data, as we did the testing, because we have EMR systems and dashboards, we were able to look at different things. So the antibody test, you know, our last numbers, we're like 3%. So this slide is a little bit old, but we're about 3.7%. Gave us an idea of where to penetrate, where to focus on. The 14215, again, was the issue. We were the ones talking about essential workers. We were the ones talking about first responders. We were the ones talking about the generational differences that were going to have the biggest impact. And that's why we were scared. I mean, you know, I see the Black and Latino communities, they're my brothers, they're my sisters, they're my, you know, they're family. They're not patients. And so for me, when that happened, it was like, come on, guys, we got to really do something. We're a for-profit entity. We had resources. We're not going to wait around. We're just going to do it. And if we get some rewards from this, yeah, if not, and then District came along finally and really provided some testing, which we were able to kind of enhance this to really get the type of information that's real important. Next slide. And this was again, the nasal swabs. The problem that we had in the beginning of the process, we're down to about 3.2, was that they were taking these swabs and they were shipping them somewhere in a medium. And by the time you got the results back, which was now about a month ago, it was 14 days, you lose the test function. Not only don't you know, but then the virus may not survive enough. So when you test it, it's not there. So one of the things that we'll be going live with in the next 2 weeks is actually rapid testing. So how do we get back to normal in light of our community? So for one is we use temperature gauges getting into the office. We put UV lights in the venting systems to reduce that. We use sprayers to do everything in terms of cleaning it, but we are getting rapid testers that give us the results for COVID-19 at the point of care in about 5 to 10 minutes. It also lets me know if someone has the flu in 5 to 10 minutes. It also lets me know if I have a strep infection in 5 to 10 minutes with a sensitivity specificity of 95%. and 99%. So what it allows us to do now is if September hits, we have a mobile unit with examining rooms out in the field. We can test people. If you're positive for COVID, we can easily connect you to a telehealth visit to a provider. And second, contact trace you. Lock it all down in 30 minutes. That's how we can handle this kind of war in our community. Two, if it's viral, treat. If it's influenza, treat with an with your viral medications, get them back to work in 2 days. If it's strep, treat, antibiotic, get them back today in 2 days. But it allows us to really battle this a lot easier now because of some of the tools that are coming that are so important. I just want to make sure that our communities get involved because, everyone was concerned. And I know first responders and health, all that's important, but the community also, if you have areas, I think Dr. Nielsen said it right. If you have people at risk, that's where you got to test. Those are the ones you treat first because they're the ones that we're going to lose if we don't intervene early. So this is just how we were able to kind of keep the data, look at the data, and really make decisions. I think the biggest thing right now in our communities is really to provide the dollars to improve primary care, provide the dollars to improve public health. And it's got to be now, not so everybody walks around, yeah, we're aware of that. You need to put dollars into these things in order to really create an economic engine that becomes a multiplier. So not only will it help the hospitals and the county and the university, but it's a multiplier. The more businesses that you put out there, the more people that we diversify, because social determinants of health is dollars that come in to create jobs and a different type of training. In the healthcare industry, we treat chronic diseases. We get all the vaccinations. We do all that stuff. There's been no real, everyone talks about primary care, but it never goes anywhere. I think it's a time to really grow primary care. In light of the medical school, this is the year of the most minority students in the history of that medical school to come in. So I went to UB Medical School. Back in the day, it was not always the place to go because you didn't feel as welcome. I think with the churches and some of the stuff we were able to do, we have a sort of a vehicle by which students are going to come here and stay and grow. And I got to tell you, God's been good to me. I am a Roman 4:17. I speak things into existence, and that's always been my thing. Now, my two daughters that I said, you're going to go to medical school at UB and follow my steps so I can retire and do something else. And God is good because I have a first year and a second year at UB Medical School. It's my proudest moment in my whole life. So what I do for the community, I do because I wouldn't be here without both the Black and Latino community. Thank you.
Thank you, Dr. Vazquez. We just really appreciate you. You're just really a beacon in our city. We thank you for being uniquely you, for being not only smart, but also being innovative. We have questions in the chat, so if you just give me one moment, I'll be happy to help in that space. Oh, Kelly's back. All right, excellent. So now I'll turn it over to Kelly. Thank you.
So our first question is, can you do COVID testing during fall outdoor fairs or can you do COVID testing during outdoor health fairs?
Yeah, absolutely. Now we have machines. We're using the Abbott rapid testers. We actually have 15 machines coming. They'll be here within 7 to 10 days. And then it's nice because they come in with the reagents. We ordered 3,000 tests to start out with. So, you just swab and you test, and within 5 to 10 minutes, you know who's actually having issues. I think for schools, if we're looking at doing that, besides the temperature and the good cleaning and the UV lights, is at one point you might want to do just like the football players in the sports, is test people coming into the school and following models that not just the fevers, but the loss of taste and smell, that if you pick people up early, if they're sick, don't let them come into the system and learn to manage. Like in the old days, the family docs took care of you were sick. We took care of you at home. We didn't bring you into the office to infect other people.
Thank you for that answer. I just want to remind everyone to please place your questions in the chat box. The next question is, what implications does crisis-driven work have on the future of our interaction during the pandemic and on the future of primary care?
Well, I think, you know, like anything, COVID-19, you know, it shed a light in the community. You know, I've been practicing for 30 years, you know, and the sad thing is, while I've had an impact in the people I touch, the numbers in the community haven't really changed much. I mean, if we start looking at data from now to data 30 years ago, you're still having asthma in areas that are really rough. Diabetes, amputations still become a big issue. I mean, you know, hospitals really need to focus their attention. We saw with COVID-19 that hospitals put their money into elective procedures. And while that's a good thing, there's no investment in primary care and the community structures that are so important. So we need a sort of a rapid response units within our communities, that when these things happen, we don't wait around for agencies to do that. We can just jump in there and really have the IT informatics, because we built them. One of the areas that I'm hoping in the next 2 years that I will personally fund, if I don't get someone to support it, is the digital divide that occurs within our community. The internet connections. Our kids, for education, while we think they're doing fine, they're not doing fine. Healthcare, as 3G and digital health kicked in, you're going to need ways to kind of remote get data from people. And that's the stuff that doesn't exist. I mean, we send our navigators out in some areas. I mean, we live in a third world country. When you look at how some individuals are living, but there's no access to those individuals. And I think that digital connections and things like that, creating a network so that people have a trusted system. You know, they trust GBOM, they trust G-Health, they trust me, because I would never sell them out in any way. In terms of, we talked about research. So we take our data, we wash it out, and then we run with circuit, and we look at areas that, if I find out the Randall sarcoma, a certain cancer research is doing really great work, they don't have Black and brown populations. So I can say, okay, I want you to look at this population. I can sit down and talk to the members and say, listen, this is what we're going to do this. We're not going to, and if something comes out valuable out of any DNA or anything they do it, you're going to benefit from this. We're not just going to say, okay, these companies are going to do it. No, you owe this entity, you owe that DNA, you know, it's how do we really justify people, you know, being involved with these research trials, because it's not often what happens, but the studies have to have more Black and brown populations. You know, the state of New York, 40% of it is Black and brown. So that should tell you that where things need to be kind of moved, and leadership. I mean, I know I'm a troublemaker, but you know, we need leadership, like the UB Medical School, more people that look like us. At the medical, at the hospital level, the boards, they got to look like us. There has to be a direct touch with the community. These are all non-for-profit entities owned by the community, and they have to connect and have some accountability, because the eyes can only see what the mind knows. And when you're out here and you're seeing things, you get frustrated. And I think if we're one buffalo, right? But that includes the Black and brown population to be one buffalo.
That's right. So then the next question actually plays into your response for the previous. Will your practice, and in what ways will your practice play a role in recruiting patients for vaccine trials?
Yeah, so I'm going to be the first one, because I'm not going to tell somebody to do something if I'm not going to do it. So I think I'll go through the process, and then you know, then I'll put my family through the process, and then I could literally tell people, you know, what the benefit is. One of my daughters, because she had it, she developed high titers, and everyone's saying, well, that's only good for 3 months and see what's out. But because the vaccines, and I believe December, January, we will have a vaccine. Russia, you know, has this, you know, we don't know where that's at, but China definitely has something that they started back in November. So I think we will have something by December, January, to create some hope. But yeah, I'll be one of the first ones to get it. So
I believe that. You mentioned the influenza season is coming. Will you talk more about how that will affect your approach to evaluating and treating patients with respiratory systems?
Yeah, that's going to be real important. I've always pushed our people to vaccinate. I have an influenza vaccination rate of about 90%. I drive people crazy because I don't take that because it makes me sick. I'm not taking, I won't mention the words, but I'm saying in my mind is, no, you got to take it. You got to take it. And because we vaccinated people all along, that in itself triggered the system to kind of recognize these things. So even people that got it, I didn't feel that they got as bad as other entities that were never vaccinated for flu shots. So I think it's important. So as you got people coming in, so we usually vaccinate mid-October because the influenza hit for us, it's like at the end of November and January and December. And then January, you start to see like almost a plateau as it starts to come down in February. So when you're coming in, if you have these symptoms this year, more important is you got to test people. So you got to know that it's flu. If it's flu, then you know, you treat with your Tamiflu, you manage them, you're good. But if it's COVID, you got to make sure it's COVID. So it's going to be a real important fact that we test for not only, and strep at the same time is let's test for all these things just because we want to keep our radar off on, because it's going to get worse because it will in September start picking up. And the better we are at this, the better we quarantine people and contact tracing, the less of an impact this virus will have this time.
Awesome. Our next question comes from Canada. In Toronto, we've just started to do COVID testing, mobile COVID testing, yet we're realizing that there are so many myths that keep people away. Can you speak more on the community structures that support trust and dispel myths?
I think we had the same things within when we first started doing that. I mean, people often think, I'm not going to let everybody biopsy my brain. That's not going to work for me. I mean, that's the extent of health literacy that's real important. So we do the PAMs, patient activated measures, and kind of give a response to whatever level of health literacy they have. And I think that helps to do that. But yeah, I mean, people think that you're giving it to them, that, you're tapping into brains, that this stuff doesn't really work, that it's a host. And I think it's just through education that people begin to understand. And I think the family dynamics are real important too, because when one person doesn't want to do it, I play one against the other. So, grandmothers will come in, I don't take my flu shot. And then, they come in with their grandkids and I said, well, it's not you that I'm worried about, it's this young person that's going to die as a result, you're not taking that. And, the little granddaughter said, Grandma, you're going to let me die for this? You know what? Give me the damn vaccine. So there's ways to kind of really educate people at their level, because sometimes, we forget that we're doctors and you got to just be common folk. You can't be different. And I think people really appreciate that. For me, it's different. I'm a Medicaid kid that grew up in the projects. I could be there, I could be everywhere, and I just learn how to talk to people and educate them because, yeah, there's mistrust and a lot of reasons they do have the right. I mean, they're right. There is things that we did, even when I came through medical school where, black and whites were treated differently. And I always had a problem, got myself into trouble, and I still get myself into trouble because it's so important to really just treat people the same, and it shouldn't be different.
And with that in mind, can you expand on the need to invest resources into the social determinants of health, government foundations, from the perspective of government foundations, insurers, et cetera?
Yeah, I think, it's a good time for reparations. I think, maybe, and I know it's crazy, African Americans don't pay taxes for 50 years, which is radical, but I just think that it's a way to kind of equate. This country built its back off of Black individuals, Mexicans. And what I'm saying is this is a way to kind of balance and bring resources into these communities. We can't really do anything without resources. I think GE Health, because we're strong, we were able to seed and work with the ministries and guide them. And we put hundreds of thousands of dollars a year into the community. They come out of my pocket because it's so important to grow as a multiplier. So now the ministries, they're doing great work. You've got, other not-for-profits that we help, they're doing great work. But without money, healthcare is what we call enabler. It can create jobs. It can do a lot of good things. If you don't invest in these communities and people don't feel that they own it, you're not going to get a lot of change. I mean, if I can give you as many cars as you want, when you buy your car, that's a difference. And the same thing we have to kind of, everyone in these communities want the same things. They don't want handouts, but they want an opportunity. You know, we at G Health and G-Bond, we take people that have been on Medicaid and now we employ. They're great workers, benefits, but they have a career. Unless you invest those kind of dollars in primary care, in public health, and really make, you know, but invest in those entities. And don't shy away from for-profits. Everybody thinks it's a bad thing. I'm a for-profit all along. It allows me to do the things I want to do, which are important to me and what I want to do. Because I always ask people what they want to be when they grow up. I'm growing. That's what I want to do. And if you don't pour those dollars into a lot of these communities instead of jails and instead of everything else, you're not going to see the impact that we need to have in healthcare. And you got to have more, you know, doctors in primary care that want to go into private practices in these communities and create models so that they, once they come in, they feel like they can, you know, all of them want to do it, but then they see that they don't see anybody like them doing these things and they just don't do it. So you have to really pour dollars into the system, not organizations, not all this stuff, but really as a multiplier, because those dollars are, all you're doing is creating seeds. And when you seed an area, it's going to grow.
True. You spoke, well, a lot about technology, but specifically digital equity. How can we improve digital equity for communities with barriers to technology?
Well, I think creating a digital mesh system where you create free Wi-Fi in an area, and you know, all you have to do is, if you want to use it, you click on, there's a web page, people can mark it there. That'll sustain that model. But you know, one of the things that the Black and Brown community don't do is their data is valuable, it's rich. Data is the new oil. And so what I'm saying is, and if you're not on the web, you're not going to benefit from these things. So we built our own cloud. We have our own data. But how do we get all these communities and the things that they do to be recorded in databases? Just like the churches, right? They're doing great work. It shows in the data. Then there's no question. Otherwise, why fund them, right? Why fund them? They didn't do anything. This is the work they did. These are the things they accomplished. But data and really having people have access to the data, especially the resources that the Black and Brown community have, are our kids. And if they're not getting the best with access, this is like almost like a I don't know. It's something that we shouldn't even be talking about, because there's no cost attached. It's very minimal cost to do that. Instead of all these Wi-Fi's and all these systems, these kids have to be connected, because the new world that we live, this is just the beginning of what the new world order looks like. And if these kids are not connected in any way, we're just going to go even further back than we were.
Our next question is, how will we ensure that the economically disadvantaged will get the COVID-19 vaccine when it becomes available? The concern is that it will go to the more affluent because it will be in such high demand.
Yeah, I know that's always been a question. I know Dr. Nielsen said the same. I think you have to really focus on people that are at risk. So if you were saying the Black and Brown and Native Americans were at risk, then we should push, because remember, what's funding this is federal government, right? I pay a lot of taxes. So what I'm saying is my money. So I want to make sure that my money is going to my communities too, because it's got to be a fair entity in terms of how we get, but we should be vaccinating the people that are most at risk right now, the ones that we lost. And that would be also, you know, the homes, the nursing homes and things like that, because those are the people that are having the high risk. When we vaccinate for the flu shot, there's an indication who gets it. And I think we have to stick to that in order to make sure that everybody gets access. And I'm personally going to buy a lot of them. So they'll be my money.
Right. The pandemic is teaching us how to use telehealth effectively, right? What are some of the downsides of increased telehealth, like testing, physical exams?
No, so telehealth, I think telehealth has a place. And we were the first to actually do telehealth as a value base. We pushed the insurances to cover it back in 2017. But telehealth, in terms of the video, is good for an encounter. If you have someone with chronic diseases that needs other preventive services, then the Tidal Care that I showed is the next level of telehealth, which is a virtual visit, which means that you send a navigator or a nurse out with PPE equipment, and they have all the equipment, the doctor's here, and you're examining that patient like if they were in the examining room. You can listen to lung sounds, heart sounds, actually better than if they're in the office, because you can just spend your time with that individual. Video of the throat, the ears, the temperature, the rashes, the blood pressures, the weights, and it's got built-in AI. So it guides the doctor. So when you're looking at the ear, it can start telling you whether, beep, beep, this is probably ear infection. Beep, beep, you gotta, so it's giving you a guide through this whole process. That's the level that we need to get to, because then if you have those remote, and we can give them to patients that are like high costly because they go into the emergency room a lot. So they can call you, they can use this equipment really simple, and you can start to gather all this data. And the more data we have, eventually we can come up with a lot of different ways to manage people. But the whole idea is, yeah, you got to get to the virtual care type of model, not just telehealth. Telehealth is going to be temporarily. If I'm calling you for your blood pressure, you're giving me that. If I want to make sure you look okay, if you've got, other things that are simple, but you really have to use the physical diagnostic skills. And that's where like a Tidal Care with remote monitoring gives you better capabilities with those individuals.
Our next question is switching gears just a little bit. Can you speak about the importance of good health and nutrition? We know that that is a cornerstone of some of the work that you do with your patients, and you provide opportunities for your patients in that regard. So can you speak to that a bit about purchasing veggies, produce throughout the year, not just summertime?
Mm-hmm. So I mean, during the pandemic with the social determinants of health, what we did was with that app, we were able to kind of repurpose. We had our wellness people down, the chef and the nutrition. They've been down. They've been doing tele-nutrition, but they haven't been bringing individuals in. When this first started, without the COVID-19, we have, we put a nice gym. I mean, it's phenomenal gym, kitchen, everything's beautiful. I didn't expect it to be utilized by the members as much. But then after a while, we had 200 people, a week coming in. I saw people when I was working on the gym that I didn't recognize them because they had lost like 50, 60 pounds. And so it was like, oh, I was thinking, man, are they sick? But they, it's just the fact that if you know what you eat, those are so important. I think partnering with the churches was phenomenal. Goya did a horrible thing, okay, and now it's to support this political structure. But what we were going there is we bought at bulk, and we were able to kind of supply a lot of food to the community. And we're constantly, we got about $50,000 in food that's being prepared for September. So if things go bad, we're just going to be pushing things out. We partnered with the schools. So we were giving out about 300 meals that are 7-day packs to a lot of the members and a lot of the community network. So we developed a nice network, and like with the churches and stuff, to be able to distribute. But food is a necessity, and it's something that people don't know. I always tell people, unless you were poor, you don't know what it is to be poor. I know what it is to go to have gone to bed without eating. And so that's happening here. And so under my watch, if I can do something, I'm going to do something.
And a point of clarification regarding your previous question in your presentation, you seem to be talking about a highly decentralized system of medicine combined with telemedicine. Is this perception correct?
Yeah, I think we're a virtual system. I think that's what the future is going to hold. You're noticing that as the elective procedures take place, these hospitals' balance sheets, they're not going to be able to support these types of structures. In the value-based world, as we start to get into total cost of care and figuring out how you're going to distribute dollars, you are going to be the player that'll decide how to save money to be able to do some of the things that will have an impact in people's entities. So yeah, I think virtualization is going to take out mobile systems. We have our mobile unit that goes live in the next week. It's 2 examining rooms. It's got everything that an ER has in terms of chemistries. We tied in with both ultrasound. We do imaging. We do ultrasounds. We can pretty much, I ran an ER for about 5 years, pretty much do everything. In addition to retinal scanners for diabetes, everything you can possibly think about. If we do get COVID positive patients, we have pulse oxes. We can run chest x-rays and really manage these individuals and not require them to go into the emergency room or inpatient. So yeah, it's the world we live in, it's going to be digital and it's going to be more mobile. Amazon, If you don't become close to Amazon, you don't exist.
So to that end, this next question actually fits in with the mobile situation and setup that you're discussing. So how are you looking or addressing with the community, those that have suffered outside of COVID specific issues? So physicals for work, routine, things like that, pap smears and mammograms, follow-ups on abnormal test results. And then how do you advise small clinics who really help Black and Brown community members, but are still closed due to COVID?
No, we want to partner. I think, this year, Jabanco, which is our ACO, we have 6 contracts. So we have 31,000 lives. Then what's nice about it is we have 31,000 data points, everything about those individuals with regards to mammograms, and they meet all our quality metrics. So we're chasing that group, and that's all within our zip code. So a lot of them have Gales, Douglas, Dwight, Jericho, these groups that are already serving the community. So we're targeting them first because having that data makes it so much easier to knock this thing out. But at the same time, we want to partner because, we have general practice PC, we got ECMC's groups that are also part. We have about 250 providers within the Jabanco network. So not the GBON, the Jabanco network. And we've got them working with transformational pods. We want to use this mobile unit to really target those value-based entities and also continue to work with the churches and now really come to the churches with something ideal where it's a 10-minute COVID test, not like we do this and it's going to take another, 10 days to get back. And then the screenings. I mean, for diabetes, we can do hemoglobin A1C, renal functions. We could do eye exams. I mean, you name it. We can do GYNs could be done inside these units, and it's just the way we have to deliver care. This is how care is delivered in other parts of the country, especially in areas in the Caribbean and Africa. And I think they're going to come back to this country. People want that. And I think it's going to be a good way to kind of deliver care.
And our final question, how do we get a more, I'm going to make this I'm adding to this person's question. So how do we get more proportional population representation of minority groups into leadership roles in clinical care, but also into the medical school?
So yeah, I think, Reverend Pointer came to me with a young lady that, oh my goodness, Carol came to me. Yeah, and Carol came to me and she had so much fire. I mean, I had lost some of my fire, but she had the fire. And then Reverend Pointer, he still had fire. I was just trying to do the things we did. And they said, listen, we have these students, and I think it was about 3 years ago, that are neat. She wanted to bring them back. She wanted to kind of like wine and dine them and talk to them. That there are people that look like them, because when you came to the schools, you don't have anybody that looks like you. You're not going to do anything. So we brought them in, and I said, fine, let's do this. We wine and dine them. We had a great time. And that year, I think it was 35 people and 34 came. And then Carol just every year and with Dr. Pointer, it got bigger and bigger. Then we had the Dr. Daniels that, I mean, the medical school has true people that truly care. And, Dr. Millings, it's just, all these individuals really were great. And then this year is the largest class in the history. I'm surprised we're not talking more about it. And I'm just hoping that we touch them and keep that chain going so that some of them stay in the area. And we're getting, actually, the one thing that I find that's interesting, we're admitting more kids that are from the area. And I think that's going to be real important to create a chain, because if you're from here, the likelihood is you're going to stay here. And so those are the things that are going to happen. But we have to kind of sometimes push, but if we're pushing from the bottom up, but it's a lot easier to push from the top down. And I think we need to be involved on boards for the medical school. I think, more admissions committee. This year, I'm vice president of the alumni, the Buffalo alumni. So I'm hoping that we're going to raise money. We're going to raise money, but I want to make sure that we have the representation, that the curriculum really touches into communities, that we don't become sort of, like the zoo. I don't want people to come into our community with a zoo. They take care of us and then they go home. We're all people, and you got to be able to see and feel what people do. The hospitals are going to need more players in the community that are going to be more radical. I think it's real important. We have like FQACs that are going to have to begin to work together, but I mean truly work together, not just say they work together. And I think that that's all going to be real important. What we do now with the Black Lives Movement, I mean, I'm seeing, you know, I'm seeing it like I've never seen it before. I'm always the guy up front driving the car. Now I'm in the back, and I like where it's going. I think we should, that momentum needs to really change the way all of this works. But there also has to be economics. You got to distribute dollars within these communities for some of the programs. And we have, you know, we have money. I know the district has some money. Those dollars need to be applied to some of these programs. You know, the churches, the district came out, we pushed it. ECMC did a great job with Millennium, but Millennium doesn't exist anymore on paper. It's our time to make sure that, you know, Reverend Pointer's program gets refunded, because it's really important. And what it does is, how do we push the entities to kind of spend some more dollars, because it's having an impact. And if they want data, I'll give them all the data they want.
Huge, important. Thank you so much, Dr. V. I appreciate all you do. We go back a ways, way.
You didn't come work for me. I tried.
I was there a week, but things happened. You know, I was crying in training because, you know, the lot, man, I would have had people living in my living room. So it's not a fit for everybody, right? You have to have a certain kind of personality and ability and gift to be able to do the work that you do. So I appreciate you. Thank you for everything. Thank you for everything that you do. With that, folks, I want to mention to you that in the group chat, we have someone, Oswaldo, he posted his experience with Dr. V and his experience with COVID and the healing process and the work that's being done. And that's in the chat. So I encourage you guys to check that out as well. We are moving into our third session, our third breakout session. So just like the other two times, if you are staying in Dr. V's breakout session, you're going to stay in this room. You're not going to go anywhere. I mean, you can, but you want to come back at 2 o'clock when the breakout session starts, which is in 4 minutes. Joe has placed the link in the chat. You can click on that link. It will take you to your page of breakout sessions. In this session, this is our last 30 minutes, guys. We're talking solutions. We're talking next steps. We are talking about how we are moving this agenda forward. So put that mindset, that perspective on, head over to your chat, your breakout rooms, and your third breakout session starts in 3 minutes. Dr. V's group, please stay in this room. Tim, I turn it over to you.
Thank you, Kelly. Kelly, you've done great work again. Dr. V, you're going to hang out with us, and we're going to give folks a couple minutes to get where they're going. And then we're going to just pick up where we left off.
Yeah.
You can take a bathroom break, though, Doc, if you need.
No, I'm good, man.
Okay.
I'm good. I give myself a little more insulin.
Okay. I've been drinking water all day, so, but I took a bathroom break before I introduced you, so I'm good. And I know I didn't, but I hope I didn't embarrass you too much by talking about the things that you've done deliberately in your work and the necessity for continuing to work in these veins, because somebody has to speak for folks who are not at the table.
That's what we do.
And so there's a question asking, can you see the questions in the chat?
See, I'm trying to.
You should be able to, but you're also a co-host.
Yeah.
You see it to the right underneath the participants?
Yeah.
Okay.
Let's see. Let's see.
Sorry, I answered for you. My apologies.
No, that's good. That's helpful.
Yep.
Thank you, Louis. I've been admiring your background all morning.
I think that's a testament to my wife and how good she is at knitting.
Nice stuff.
Yeah. If only I were that talented.
Yes. All right. So Dr. V answers that he can see. So I'd wait for Dr. Murphy, but I'm sure he went for his bathroom break.
He said he'll be back in a couple of minutes, and then
Yeah, we can get started.
Sure. So welcome everyone again back to the main room breakout session. Of course, we're here to provide a deeper dive into keynote topics. So for those of you who just came back, we're back here with Dr. Raul Vazquez, primary care physician and president and CEO of G Health Enterprises, here for a closer, more in-depth look at his talk on working with the community to shape better healthcare in light of a pandemic, and also to field any additional questions you might have. Again, you know, if you are accessing us through Zoom, feel free to contribute a question by either clicking on the raise your hand icon or send me a question in the chat function, and we'll try to get to as many as possible. Dr. Vazquez, would you like to add a few more words about your topic first?
No, I'm pretty good. No, someone mentioned here, feel Dr. V should write a children's book on their success. You know, it's funny. We are putting a book together. We've been writing a book for the last 4 months, so it'll be done in 9 months it takes. So we'll send you guys a copy. It's basically, our stories are pretty interesting because of where we came from, me and my wife. But I think it got us to where we're at right now. But it's been a blessing, and we want to make sure that people understand that, you know, don't be broken by the system. At the same time, hope and a lot of the things you do will get you where you want to be. And so examples of things that sometimes didn't go your way, but they're the right things to happen. And I've always been a boxer in terms of business. You know, there's 12 rounds. So if, you know, you get hit a couple of times, you learn and you just keep going. But if you're persistent, you end up being a good boxer and you do well in what we're trying to accomplish here.
That's really wonderful to hear. It's wonderful to hear that there's someone really out there fighting for the needs of their patients and for this population in general. I think one of the chat box comments is that your initiative, it seems to pull together churches and community organizations and medical partners. I know you said that these things kind of just came together, but what kind of approaches have you used to sort of build this broad coalition? And what are some of the lessons you might have learned through this collaboration?
Well, I think, and Reverend Pointer will tell you, I mean, we started this a while ago. I mean, was it 2013, 2014, Reverend?
2013.
Yeah, and so I you know, because we sat on so many boards together, and I just said, listen, I think you guys really need to kind of really be involved more in the healthcare industry. And I said, let's, you know, I knew that the district was coming up with a needs analysis, and I said, who better than the churches to put it together? And so, you know, we helped set up with the church, and we brought some talent. We had some great meetings, and from there, I think, you know, Reverend Pointer, you guys took off. You guys, all we needed was a couple little seeds, and you guys just took it to different sorts of levels. And I think, you know, it showed the commitment that the church really wanted to do something, and it's in the best position to really have the biggest impact. So these medical neighborhood models were good. That, and then our partnership from there led us to the medical school, meeting medical students, providing some resources to make them do the things they wanted to do. And, you know, it just, one thing happened, and, you know, helping the community. I think, you know, and that's what we do. One thing we do is, you know, I literally put hundreds of thousands of dollars of my money into this. You know, you have people that come and do things, but they're not putting money into it. And I think that's the only way that you're going to have a big impact. That you have to put dollars behind initiatives to make them work. And I think, you know, I mean, we help with Dr. Pointer's projects, and I think now they're on their own. They're growing. So that's what we want to see. A lot of these seeds grow and really have impacts in our community, and they'll change things. A multiplier effect, I always say.
Can I just add on something to what Dr. V is saying from a city perspective? And Reverend Pointer pointed this out. And Pastor Nicholas talked about this earlier, about having meaningful relationships with people in the community and trying to create that infrastructure there Churches are the beginning part of that. They have these relationships with people in the community. Dr. V built upon that. From a city perspective, once that happened, you have elected officials or you have administrators who are looking at that, and you had this convergence of folks doing things. In the beginning, from a citywide perspective, both from the county and the city, we looked at the numbers and we saw, wow, there were some hot spots. And so there was a mindset here, is like, do we expose that? And do we say, you know what? Do we share that information? Ministers, Reverend Pointer said, you know what? You got to share that information. We didn't want to not share it. We didn't want to stigmatize a community, right? And so I thought there was a key point there about saying this is what was going on, because there was a push that was going on in the community. And so sometimes we rely on one entity more than others. We rely on government to say we got to do this, we got to do that. And sometimes things flow in the community that doesn't necessarily have to have a governmental response first, right? And I know that because, Dr. V says where he grew up at. He and I grew up in the same neighborhoods. We had the same type of folks looking at for us when we were going to college, getting on the trains, going up to Buffalo, doing all those things. Little ladies putting $5 in our pocket saying, listen, I need you to do this. I need you to do this good. And so having that relationship with people, you can't underscore that, right? And it keeps you in Buffalo. It keeps you in that, So I just can't underscore the fact that that to develop that infrastructure is not when a crisis happens. You have to develop that beforehand, because when it happens, you're scattering all over the place. So even from a city perspective, that's important too. Someone talked earlier about the call centers, 211 and 311, and how we responded to folks in the community. And so I have the fortune of running one of those call centers. And initially you're talking about, it was so important from us on the city side to make sure that got up and running, because people forgot that we had to vacate City Hall and we had to, the function of government, we had to do that remotely. And we needed to make sure that we connected. Dr. V talked about that, having that call center or having that way of how we talk to people. And that was very important. And then not only did we do that, we went door to door and put door hangers on every door in communities and said, here, we're here. How can we self-activate people in the community and provide for that too? So, this, again, I don't want to take too much time, but I just wanted to underscore that piece, which is so, so important.
That's good stuff, Oswaldo, because what happened in this instance is we actually began to have the conversation with government prior to government coming to us. We didn't wait. We knew what our numbers were. We knew what the comorbidities are in this community. We understood how this disease was understood early. We understood this was a respiratory infection that, and the outcomes, not out of China, but the outcomes we saw out of Italy and Spain alarmed us and said, we can't wait. We have to move. Because in Italy and Spain, people were dying to begin with who had diabetes, heart disease, and the other respiratory conditions, asthma and COPD. And so we knew that if we didn't do anything in Buffalo, we would just simply have a train of funerals. And as physicians and pastors, we're not interested in funerals. I mean, of all the work that we do, the last thing we want to do is to stand up over a funeral buyer or to stand at a bedside and tell a family that there's nothing else we could do for your loved one. So together, we pulled in government and said to government, we don't need you to fund anything. We simply need you to listen and then partner, and let's be intentional about how we do this. And yes, we're going to tell this community the truth because they already know the truth. You can't hide truth. So, and then we said, we'll give you a plan and we're not asking you to do anything but get behind the plan. And then we've done the work, and we've done the work competently because we're trusted voices in this community, and we've used the community to reach out to the community. And the other piece is we've had the collaborations that matter, and they're not new. These are collaborations that have existed over the course of the last 7 years We built them so that when we needed to have a chat with our friends at Endeavor Health Services, I said, Raul, we need to talk to them about some additional things we need to do. They were available. We could have those conversations. That's how you collaborate, and that's how you move the needle. Because if you don't, the worst 3 words in English when you put them together are, I should have.
And trust me, when you have this disease, you do not want to say I should have, because when you're living with it, you want to, saying I should have is too late. I think this is one of the shots where we talked about solutions, and Pastor Pointer talked a little bit about modifying, at least from my office and some of the things we do these outreaches called clean sweeps. We usually have, and we're out there being proactive and bringing City Hall out in the community and affecting the community. If you need to fix a street sign, a pothole, or talk with a building inspector, or do that. We look at information and data just the same way that Dr. V does in terms of a planning perspective. And I'm thinking that when you talked about the rapid testing, what we wanted to do, we didn't start clean sweeps this year because of the pandemic. And we wanted to do a modified version of that. And we're getting ready to bring that back up. We're bringing county and city and different agencies, dental and health, and just going door to door. And we can look on a map, just like you, I can look and see there's certain areas that we need to be focusing on. And so we wanted to focus on areas that the propensity of COVID was high, and also unemployment. We wanted to look at all of those areas. And so we have that mapped out. So I wanted to touch base with you about maybe working together.
Absolutely.
And then going
so one of the things we're doing a lot, and G-Bond, we've always been out with you guys in the clean sweep.
I know. Yes, you have been.
Yeah. So what we've done is so the social determinants of health. So I'm in the value-based world too. We're managing about $250 million within the 6 contracts and 31,000 lives. But what we wanted to do is premiums are always not right because of the communities. And what I mean by that is the Z codes, which have social determinants of health, they never capture. We have databases called vulnerability indexes that the state put together in national crisis to know where to deploy the different types of resources, and a sort of an index for that. So what we're doing is we're merging that with costs, with the Z codes, to really come up with so if we say, listen, we're going to need dollars for this area, this is why. And it's not like we're making things up. This is where the data is. And I think for the city, it will help. Some of the stuff we put out is there's cities that get compared across the country in terms of what their issues are, but take that information and really go after some combined multiplier effects for the city, for the churches, for the clinics, where we can really have a bigger impact because you're showing a need. And then not only that, but when you delta change that need and begin to drop, people are going to watch and say, how did that happen? Because of all these things. You have city, county, everybody's working together. So that's going to be crucial. And we have the data. So it's not something we got to find.
I agree. The data is there. I mean, I just want to say this. Tell them what part of the city you grew up in.
South Bronx, baby, 1343 Washington Avenue.
I got you, man. I grew up on Jackson Avenue, so
Morris Project, baby.
Just had to do that little commercial. I'm sorry.
No, and I think that's because if you have people, the eyes can only see what the mind knows, and I always say that is because I know the community. I know. Listen, it could be Buffalo. It's the same market, same issues, and I think you're coming at it with a different view.
That's true.
I think that's what your view is different. My view is different, but those views really are what the community is looking for to make some changes.
Thank you both. So another question from the chat is, I think everyone appreciates how you were so proactive about everything. You looked at the data from Europe, you built these early relationships and partnerships, you took these different preventive measures. Now, was there any pushback? Were there anyone that said, you were alarmists, don't fix it, if it ain't broke, don't fix it? And how did you sort of deal with that early pushback? And what are sort of measures you did to counteract that as well?
Well, I back in March, I started getting a little crazy. So I think the news and some of the things we were going, they were understanding. And it's funny that I talked to Todd Anderson from WBLK, and he said everything I've told them has been something that if you're on the ground, you're seeing what's happening. The hospitals had their control center. They were totally disconnected. And that's not a good thing to do during this process. You really want to touch base with the community, the county. They were at one point we were doing testing and it was very difficult because we were clashing heads. So we just said, let's keep doing it. We just didn't want, what we were saying is, can we get waivers? So if we do things that are not the standards, that we're not going to get into trouble because all we're trying to do is the right thing. So, and with time, it's sort of like the proposal, the church came to me, we put the proposal together that ECMC deployed and modified, but it was our proposal. It wasn't like they came up with it, but we not shamed them into doing it, but we pushed them into doing it. And that's what happened. So it's sort of like, well, and Reverend Point will tell you, well, don't work with Dr. Vazquez. He doesn't like to work with anybody. No, Reverend Point will know that I'm just pushing people to do the right thing. And if you have resources, I know everybody's in a state of chaos, but if you have zip codes and you have hotspots, you got to focus on those areas. You can't just say, I want to do everything for the whole county. Sometimes the best way to tackle, how do you eat an elephant? A piece at a time. The 14215 was the area that you really wanted to put your hands in there and fix, because once you did that, then you have a better idea of what the spread and all the other issues across the county would be.
Yeah, the question about is there pushback? Man, listen, that's pretty laughable. Lewis, there was more than pushback. As a matter of fact, one elected official simply said, I don't want to do that. I don't want to do that at all. And we said to that elected official, we understand your reticence. We understand why you don't want to do it, but we're telling you that we're going to do this. So you need to either be in and we'll tell everybody you're in, or you're out and we'll tell them you weren't the one who wanted to help. And look, you got to get it reelected. So I shouldn't have to have this conversation with you, but you will never get my support in any election again. So, then you talk to them in the language they understand. And we said, look, just hush. So let us show you what we're talking about. And then we showed them the data. And the data, the interesting thing about data is data doesn't have any bias. It just shows you what is. And so once we laid out the data, they were, kind of relaxing, and we said, look, we're not asking you to pay for anything. We're simply asking you to come along. And then when we went to the entity that could do something, to Erie County Medical Center Corporation and Millennium Collaborative Care, we didn't have to convince them about the data because they knew the data also. And I'm not patting Millennium and ECMC on the back. They knew the data because they served the community. ECMC is the community's hospital. Millennium Collaborative Care is the response from Disrupt to how do we fix some of these things. So it just made sense. Now they took the project that we created and they modified it and they spread it to the 8 counties, and we're okay with that because what we were saying is, look, there's no testing on the east side of Buffalo, and that can't stay. There's no testing on the west side except in 2 medical practices, and that can't stay. We've got to test all over this city, and people have to be able to walk to a testing site because 42% of the people who live in Buffalo don't own cars. And getting on a bus, that's not an option in COVID-19. So people have to just be able to go around the corner. We were able to get that done, and then to use our churches to actually call people at home and say, look, we're calling from COVID-19 Communities Response Project. I'm calling you from so-and-so church. We want to know how are you doing? And then just have a conversation. And in the course of those conversations, ask 4 very deliberately created questionnaires that seek to discover what people's well-being is, and even to include a clinical questionnaire that every patient is asked when they go for their annual physical, the PHQ-9. And in the PHQ-9, tie it into the performance system in such a way that it triggers an automatic referral for mental health care in a community that won't even talk to you about needing mental health care. We were able to trigger referrals, and that's how you build the platform that matters for the people that you need to serve.
You know, I would add to that, Pastor Pointer, or sort of elaborate on it. So somewhere along the line, Pastor Nicholas mentioned the large grant that we've worked on together, the university and the community, and it's in there being reviewed at the NIH right now as response to the COVID-19 pandemic. And so as part of that preparation, Pastor Pointer set up I don't call it a focus group, or really a debriefing session. And it was Pastor Pointer and me and 6 of the people who made those calls 8 hours a day. And I'm telling you, I learned more about what's happening about coronavirus in the community in that 1 hour than everything I've read and everything I've heard and everything else. And in fact, to your point, Pastor Pointer, the number one thing that I heard was the mental health impact of this pandemic, the loneliness, the fear, the unknown of the people were hearing about, the callers were hearing about in their conversations with the community. I mean, that was so revealing for me, quite frankly.
I would be willing to share that data from our call center, because the same thing. People were calling the city and calling the 311 and 211, and we thought, and as we were working with people with food insecurities and making sure we had that, got people masks, make sure we had that, but overwhelmingly, whether it was seniors or just folks at home, and then people who had tested positive and negative, and then the after effects of that, and how either they felt stigmatized or if they weren't healthy or not in that respect too. So I'd be willing to share that information with you, because, you know, and I said it, having boots on the ground, and I think it was a good point, even from a city hall or a county hall perspective, sometimes we make these decisions, but if you're not on the ground, you know, and Dr. V talked about why we do these clean sweeps, because it's a difference when you're knocking or talking on somebody's door and communicating about, you know what, that's the house that everybody's talking about, as opposed to looking at it from a planning perspective. You just can't, you got to have that, I call it that community intelligence. You have to have that. They have that. And so when you're making those decisions, and I'd be willing to share that from the city side with you, Dr. G.
Yeah, no, I would love, you know, to look at your data. And, you know, what we don't have is almost a community website. And that's where I thought if we have a mesh network that you can really get everybody free access, everybody goes there. So, you know, if you want to market, you go there, but you can hit screeners. This thing's going on. It's a trusted site. But yeah, and then having that information, because then what you do is you pull all this data and you learn once you stitch it up. Wow, we don't have this, we don't have that. Because with the 211, you know, we took the database, we bought their database, and it's built into our models. So as we're calling people, we're just crazily referring people. But then on the backbone, we know exactly what needs came up at 211. What is big? What is everybody calling about? And then what you do is you develop resources around it. So as you know, food was big. So, you know, let's pack it up. Let's get this stuff out, and let's just start like delivering stuff. On the testing side, we saw transportation issues with the call center as the calls were coming in. So we mobilized the van. We made them all COVID-19. We put plastic on it. We just got them to get tested. Or we took the units out. Working with Reverend Pointer, we went out to Mount Olive and Lackawanna. We put our systems there, and I think that's what was beautiful, because, we have so many people in Buffalo that care, and that was nice. It created hope, and people just trying to do the right thing. It might not have been perfect, but it was just nice. It was nice to see that.
One question that I had when I looked at the data, the 14209 still has the highest rate. Where do they get the predominance of their medical care? Are they markedly underserved? they're still really high.
Yeah. So that's Jericho. So we're 14208, but so Jericho has a large Burmese population. Their percentage even now was higher. So I mean, at one point there were 15 to 18 to 20% positive rates on the testing. So that's why you have the Burmese population was huge in that area. You know, in our areas, the areas we tapped into, we were like right now we're about 3%, and we've done thousands of tests. But that's, I think you need that sampling kind of model, and then what I felt comfortable is like a lot of the stuff we were shooting up to the governor in terms of do this, do that, and we were seeing the changes that they were listening to us. Like, listen, if you're under 5%, that's when we're good. Anything above this, we got to continue to do the things that. Sorry, give me 2 seconds. I apologize. Okay, so yeah, and that's, I think that's it. We were just going back and forth and discussing, but yeah, those markets had higher incidence, and then we were trying to be more aggressive with them.
Great.
So one of the questions on the chat is sort of piggybacking off of both yours and Pastor Pointer's earlier statements on access to healthcare and sort of accessibility in general. You know, I think we also how telehealth is sort of through the roof in your practice. Can you speak to any challenges you had related to access to technology or high-speed connections that have impacted your ability to use telehealth? And I know this is also really relevant also in the educational arena as well.
Yeah, so you know, that's the one thing is, so in March, what we did was the first week of March on that 16th, I took our 240 people. I said, okay, this is what we're going to do. That Friday morning, I said, okay, everybody get ready. You're all going to leave at lunchtime. You've got all your systems going and you're going to go home. After lunch, for the next 3 to 4 months, you're not coming back. Everybody's gone. So they were like, whoa. So that Friday afternoon, we had hiccups. By Monday or Tuesday, we were pretty much good. And then what we started doing was with the phones, not everybody had a smartphone, but sending a link became the easiest part of it. Or if not, what we did was we were taking Wi-Fi's, little Wi-Fi spots, and just dropping them within areas that we felt we needed to kind of expand and let everybody piggyback off. We have one of our mobile unit has a 1 mile radius of Wi-Fi. So, you know, we would throw it in certain areas to do that so that everybody could do the work. But everybody, you know, it worked out pretty good, but there's still a digital divide. There were some areas where the penetration of the towers, there's not enough of that. And I'm the second largest account for AT&T, okay? That's how many, we have about 240 to 300 devices. So I was telling them that if they wanted to continue my business, we need more these access points to be able to attenuate or make the signal better to be able to provide the service. But you have like people in their homes that they have Wi-Fi, but now they got the kids playing, they got all this stuff, and that bandwidth dropped pretty quickly. So how do we you shouldn't be selling bandwidth that is not practical. There should be a threshold. You know, I live, you know, other countries have it. We should have a threshold where we shouldn't be doing something that really doesn't really help, because some of these individuals in times of needs, they need to have access. And that was, but the telehealth picked up quite a bit. Our patients enjoyed it. There was a calming, you know, like we at one point in GBON, we made 8,000 telehealth calls a month. Okay, so you can tell, and we were talking to them, who's sick, who's not sick, the contact tracing, if that became, what food do you need? How do we get you set up for telehealth? It became that kind of people were calm, and we were using data to really do robocalls and let them know, okay, this is going on, that's going on. So, you know, and then the apps pushing out information, because, you know, all this fake information out there, people just don't know. We were just trying to be the sort of the benchmark. If I'm telling you I'm liable, I can lose my license. So that's why what I'm telling you is honest. And I think those are the things that really help. But the digital divide, I've been talking about it for many years. It's just, that's in health equity situation, because if you don't have connections, the kids aren't going to get educated. Every aspect of what you touch, you're pretty much not in the game.
That's very, very true. So right now we are sort of close to 2:30 where there's going to be a conference evaluation. Dr. V, do you have any sort of parting words of wisdom you'd like to give us?
Well, I think, you know, like anything, I think it's a perfect time to redesign. I think we have to kind of redeploy dollars to some of these things. And I think, you know, while we all need hospitals, we need to kind of consolidate those systems. There has to be more focus on community-based models, medical neighborhoods, more public health, because this is the new order. And if you don't develop infrastructures now, we're going to be in serious trouble. And the health department needs to really develop models that are more connected. The city's working on that piece of it, but it's real important for us to develop a community response, or at least a system that, God forbid something happens, we can reach people fast and not be dependent on things, and reach people from anywhere, not a building structure.
So I would like to thank you on behalf of all of us, Dr. Vazquez, for a wonderful talk, and more importantly, what you're doing for the community. Thanks so much for being a part of this conference. And I want to congratulate Louis. I've been with Louis in this group all day. Really nice job, Louis. You did a nice job in facilitating these great discussions that we've had.
Thank you, Dr. Murphy.
So I think our job is easy. All we need to do is stay right where we are, and we're on to the next part of the conference. Great.
Welcome back, everyone. Folks are still popping into the room. I hope your last session was truly beneficial and you were able to get some solutions down. We are going to, Heather, oh, you're here, wonderful. Dr. Heather Oram is going to hop on and give us a rundown of the evaluation process. I turn it over to you.
Thanks, Kelly. Yeah, so as people trickle back, you will see that our conference evaluation link is in the chat. So you can go to the chat and find that and just click on it and get into the evaluation. And so this is a great time for multitasking. I'm going to talk a little bit, and hopefully all of you can get into the survey and give us your thoughts. They're extremely valuable. So for some of you may not know me. I'm Heather Oram. I'm a member of the Health Equity Task Force, and I'm on faculty at UB's School of Public Health and Health Professions. So again, I just want to thank you all for the time you've spent today, because in addition to our inspiring speakers, you're what makes this conference a catalyst in our community. If you've been to one of our conferences before, you know that every year we evaluate the Igniting Hope Conference, and we pay close attention, share comments, and try to expand and improve things for the next year. So again, for those of you who are just joining you, I'd like to invite you to take a minute or two to complete our online survey. The link is in the chat. And eventually you should all get a link in your email if you miss your opportunity now. So as I mentioned, your answers are really valuable because we do this as an annual conference. Each year the organizers pay close attention to your feedback. But this year, the conference, as Dr. Murphy mentioned, is funded by the National Center for Advancing Translational Science, which is part of the National Institutes of Health. And it's also really important to them that we evaluate the conference. They are particularly interested in the impact of the conference on promoting research on health equity that is conducted in collaboration with community members and stakeholders. So you'll find that this year we ask some questions about your involvement in research, and we'll also be hoping to stay in touch with you and connect with you again in roughly 9 months. So with that, thank you very much for taking a few minutes to answer our questions, share your opinions and your contact information. And I think we have time for just like a couple minutes break before the next presenters come on while you complete the survey. So again, thank you.
Thank you, Heather. I have posted the link in the chat for those of you that have just made it back into the room. If you can fill out the survey, it will only take a few moments. I want to make sure that we have our 5 reporters that are going to speak in the report out? Is Rita in the room? Okay, so each group is going to report out on their breakout sessions, and everyone has about 3 minutes. So DeChantel is in the room from mental health. So I am going to ask that you, my lady, go ahead and start with your 3 minute report out from the mental health group.
Yes. Okay. Thank you. So we had 3 sessions for mental health. Kelly was our wonderful speaker, and we thank you for being open and honest during that talk. And that is what really laid the foundation for the mental health discussion. Kelly was very open and honest, and it opened up everyone to have a community conversation. And that's how we started that out. We also discussed how mental health has been impacted during this pandemic and how everyone is going to walk out of this with some kind of stressor, feeling some type of way. So the question was, how do we deal with these mental health challenges living in the pandemic? How do we cope with the barriers, and where do we get care from, and care that we believe in? So we don't want everyone to walk out of this, everybody going to see a psychiatrist. So Dr. Pissar, who was actually in this conversation, talked about self-care, starting with self-care and working your way up to getting additional help. In our next session, we talked about patient-doctor contact and how that can be awkward during telehealth interactions, but how it also has made positive impacts, being less people having to commute and more people having access. One of the biggest impacts during the conversation was children getting care during telehealth. We had Dr. Benedict also in on that conversation, and she spoke about how OSHI, they had a 100% contact with the children who were currently getting care, and those who were high risk, where they may not have access to internet or resources. They have a mobile team. So there's 100% contact with everyone. All kids are being taken care of, and how they will remain more than likely with a telehealth kind of process going forward, just because they have less cancellations and more of a positive response from this type of care. The next thing that we thought was really, really beneficial is just talking about research and getting more, and that this forum would be a great contact to deal with research and how the integration of the physical and mental health components and getting the community involved, and how we integrate that into the community. So that was, and my 3 minutes is up. Sorry, my timer just my timer went off, so I got sidetracked. But the research was a big component, getting into the community. And as Dr. Benedict said, the OSHI has a lot of information with that. So maybe we can start there and see how the pandemic and telehealth and how the impact has helped and hindered the community.
Awesome, thank you, DeChantel.
No problem.
Community response, this was your room, so you guys should still be in here. Louis, are you doing a report out or someone else?
I'm gonna do it.
Asha, hi.
As described, hi.
You have 3 minutes total, all 3 together.
Okay, sounds good. So the first breakout session was after Dr. Lesse's talk about the COVID-19 pandemic, the magnifying lens for health disparities. So we talked about how we need to remember the big picture, or the big dream, as Dr. Lesse called it. So solutions to the issues brought up in this conference will require a big design, urban planning, and overtaking of current structures that are in place, and a comprehensive approach is needed. So what are the specific actions taken by the Health Equity Task Force, and can these be extended to diseases such as heart disease and diabetes? We talked about how health is a neighborhood concept, and this is not a new idea. Constructs of the neighborhood lead to greater overall health, and so the primary issues underlying health disparities are housing, lack of access to primary care, poverty, unemployment, education opportunities, and food deserts. So this pandemic and subsequent boots on the ground efforts should be the beginning of a more sustainable and broad-based effort to address these issues. And these in turn will lead to solutions in diabetes, heart disease, and for COVID disparities. We want to ensure that affected communities are engaged as part of the community and not just subjects of the conversation or subjects of research. And currently we talked about call centers that are employed to address the needs of individuals and have been doing a great job with that in terms of food and other necessities. And also the REACH grant, which focuses on food and nutrition and is informed by the community by focus groups. So what are the best practices to encourage testing, vaccination, and prevention, especially when there's a lack of health or a lack of trust in health systems? Firstly, you want to be humble, listen, and learn from those that are affected. And the best way to increase trust in the community is to engage with community-based organizations, churches, and other programs that are already rooted in the community. And we talked about how people must show up authentically. So provide your services directly to the community and work with people. And obviously testing is going to be huge in really identifying the problem. So the second breakout session was by Dr. Rear Admiral Araojo. She talks about the FDA perspective and enhancing racial and ethnic minority representation in clinical trials. So when a trial is being designed, we talked about how diverse patients need to be at the table from the beginning during the design. So we need to establish partnerships and collaborations with the community so that we're able to bring people to the table. We need to design the trial with the community in mind. And so this requires researchers to step into communities and to not quickly step out. So we need to be engaging communities on a regular basis outside of the research project, which includes health fairs, community access sites, board of block clubs, and et cetera. We need to build long-term relationships. Good doctor-patient relationships are key. And we talked about how minorities right now are segregated and disconnected on so many levels. So housing, where children go to school, and there's this huge distance between institutions and minority communities. So we need to work on relationship building. And we need interdisciplinary relationships, such as GSD, SSW, and CAS. And one of the most important things is the language we use. So we don't share common languages across cultural distinctions. So we need to create a common language between the research trials and community. And scientists and researchers are often using a highly technical language. So being able to relay scientific concepts to the community is actually a skill that requires training. So right now, RCTSI is developing training sessions for trainees on how to talk about clinical trials, and training will be an important investment in the future. And then the last talk was by Dr. Vazquez on working with the community to shape better healthcare in light of the pandemic. And his main focus is that we need to put dollars behind our initiatives. And people on the ground are the ones that can show the needs so that we can get funding. And we need different views and different perspectives to accurately represent what the needs are. This will require redesign and reemployment of funding. So we need models that are more connected in the community, and we need to be able to reach diverse communities. And like we talked about before, we have call centers that are already in place that are responding to the needs. And we have a large grant coming up that was based off of focus groups and debriefing sessions, which is a great way to understand what's happening in our communities. And just lastly, the mental health impact of the pandemic. So there's a loneliness and fear of the unknown. There's a lack of mental health providers for disadvantaged populations. We talked about how a community website might be helpful, and we would be able to show what the needs really are and develop the necessary resources with the tools such as that.
Thank you. Employment. Who's the reporter for employment?
So that's actually going to be me. Again, I'd like to thank all our speakers for employment. It was a really great discussion. At first, we started off with everyone's introduction. Mr. Stephen Tucker, as part of advanced manufacturing training session, what he made us be aware of is how there are not a lot of people who are aware of job opportunities that have market job expected growth in the next 5 to 10 years. And so it's very important that his sector prepares folks in those careers in advanced manufacturing and engineering. And he predicts that there will be a lot of infrastructure investment, and coupled with the fact that some employees will be accelerating their retirement date, there's going to be a lot of job opportunity. Miss Julie Barrett O'Neill was talking to us more about small businesses, and she also spoke about the fact that baby boomers are expected to retire early in the next few years. And if interested, she would be able to help connect people to those resources and opportunities. We're going to source a lot of the information that was going on in our group chat, and hopefully we'll be able to distribute that to everyone in this forum so that it can connect to other people and those who would need it. There are also challenges to starting small businesses in Western New York, such as racism and sexism. And through our discussion, we learned that there is foundational support available to help break these barriers. Again, we will do our best to source the resources to everyone in this forum. And last but not least, Ms. Doris Carbonell Medina, she also gave us very good insight about low-wage workers. How are they going to be able to sustain their lives in the course of this pandemic? And it's important for us to understand that it's difficult for this demographic to gain access to knowledge, education, and networking opportunities. And so they may need to rely on philanthropy and foundational support. So that was part of our first session. Our second session, we actually had a lot of great questions, and we were ahead of the curve in terms of the digital inequality. And so we've decided that, or we discussed that it's important to deploy tools to teach individuals how to work with the technology at home, educate populations about how to use these tools. And there's a notion amongst certain minority demographics of the need to show up to work physically. And so we need to change that mindset. That's my timer. So I'm just going to end with the strategies, the equitable strategies that we discussed. We need to continue to convene and put forth best practices that work, closely examine all barriers to employment, and understand the reasons why people take on the jobs they do, create a better pipeline for people who are looking for work and connect them to those employees who are looking for those individuals, need to better implement a better transportation system for those living on Buffalo's east side to other parts of the community. Consider creating a CEO roundtable where those leaders meet to discuss and drive change.
Wonderful, thank you so much. Education?
Hi, that's me. I'm education. So my name is Autumn. I was in the education group. We had a really good talk. I actually didn't really speak that much. I got to sit back and kind of just absorb everything that was being said. And we had a really great discussion. And our lead presenter was Dr. Kelly Lucci. We had other wonderful co-presenters. But one of the main things we talked about what reopening schools look like, right? And how that can be very scary and it's gonna look different. And one of the main things that we talked about in a lot of the conversations, I feel like from my perspective, we're coming back to this relationship, right? This relationship. How do we effectively switch this, system to take these kids back to school without allowing these kids to fall through the cracks? Because attendance still matters whether you're, in school or not in school. And what that looks like not in school is participation. That's what attendance looks like virtually. So how do we make sure we maintain that, participation? And that's building and maintaining these healthy relationships. And we talked about that from so many angles and perspectives. We talked about, empowering our stakeholders, whether that be parents and teachers, allowing them to know that you can speak up, you have a voice, and we want it to be heard. Going to, being a part of the Parent Teacher Association and going to community meetings and being involved in your school or district's reopening plans. And not only that, but allowing your students to know that they also have a voice in this. And a lot of, I think it was mentioned that a lot of the teachers, when this started to happen and everything had to go virtual, not only, were the teachers affected, but the students were as well. And I think the kids, sometimes we, forget to ask them how they're doing. And that was mentioned as well. Like, let's talk to the kids. Let's see how they're doing, how they feel, what they need to say, because their voice is important as well. Like I said, just back to empowering everybody, making these safe spaces for just, speaking and listening and knowing that your voice is going to go somewhere. Something else that was also mentioned was, implementing skills, courses and things, activities like wellness activities and mindfulness activities, because everybody's going through this together. And how do we come out through this is just with this team approach. I know that there was some great stuff said. I know that John Lewis was quoted a few times, and I know it was mentioned that we want to be proactive, not reactive. So we want to, make a move that's going to cost something, but not, respond only in how things were. And it was talked about how our system was kind of already always broken, and we can't go back to that same way, right? So we have this that hit the system that's already a little messed up. It's our job, it's our responsibility to not go back to how it was, but to so we had a really great conversation. I think my time is almost up, so I'll just leave it at that.
Thank you, Autumn. And last, housing.
Hi, everyone. My name is Tamara. I will be talking about our discussion on housing. So essentially what we wanted to do was just understand systematic racism, the housing in Buffalo, like the eviction process, how does that work and how is it looking now? We also wanted to look at the Live Well network, the Live Well Erie network. We then looked at resources for housing assistance, and then we, of course, wanted to develop the strategies and further strategies to combat disparities. So in the first session, firstly, I just wanted to thank Marie Cannon and Dr. Taylor as well for their contributions in the presenting. So what we did in the first session opened up with a question, and it was, what is one hope you have for our communities regarding housing? And, me personally, like while I was typing frantically, I forgot to start the timer. But while I was typing frantically, so many things were going through my head, but we talked about African-American and housing in regards to segregation, redlining in housing, discrimination, and gentrification. And regarding segregation and neighborhood quality, we know that there's decreased quality of municipal services, transportation, fire, garbage, housing, purchasing power of income, access to medical care, that includes primary care, hospitals, personal property and crime, increased environmental toxins. We also touched on the lead crisis and the lead problems in Buffalo. And we also talked about commercial and industrial facilities. With redlining, we know that started around the 1930s, and essentially it's an intentional act of government to make sure people of color did not have the opportunity to build that generational wealth and things of that nature. And also with that, the quality of schools, which kind of correlates with the education piece, the quality of schools is decreased because there aren't as many taxes paid, and the taxes correlate with the quality of schools. So during that question and answer, we were talking about the idea of land trusts for the community, and Dr. Taylor spoke on that one, and he said there are differences in the land value that lies at the bottom of the number of challenges that we face, so we must participate in efforts to disrupt the land trusts in the way they operate. And they shift ownership from the government. They shift ownership from the government to the community, and it essentially creates opportunities for the community to engage in forms of development. So giving communities power to, control the land that they live in, essentially. And the different hopes in those included increased quality of housing, opportunities for individuals to at least be exposed to various places, and making where people live healthy and safe and affordable. So those were the hopes that we thought about in the first session. The second session, we talked about housing in Buffalo in particular, Erie County. It's one of the nation's oldest housing stocks. It was constructed with lead paint. So as we know, with lead, it's associated with learning disabilities and other health outcomes, bad health outcomes. The energy costs are 30% higher. 90% of people are without air conditioning, and that's essential, especially with the asthma and things of that nature. And we know that Buffalo has one of the highest eviction rates in the country. We also touched on COVID and homelessness, and the few key highlight points in that area was that almost 350 people per night were seen at the pop-up shelter. I'm running out of time. And they saw more single males. They saw 70% African-American men, increase in domestic violence, and a large number of evictions in municipal housing. And I thought that was very interesting because you wouldn't think that there were a large number of evictions in municipal housing. Those should be the ones that are the least impacted, especially during the COVID time. So, excuse me, with that question and answer, we talked about mixed income being a potential solution, and Dr. Taylor disagreed, and he said we have to stay with the land value and how it operates. And two issues with that, with the mixed income solution was that with gentrification, Blacks are moved into an area, and white people, or those who aren't from the area, they have more calls to police, so they're having a relationship built with the police, so they're calling the police on the loud music, and they're basically trying to disrupt the existing culture that's already in that area. So that's one of the reasons why he disagreed with that. And in the last section, we talked about our moving forward and our action plans, and essentially we wanted to say, we were thinking about housing stock, and basically we were saying that investors are not the answer. Investors are not the answer because they don't live there. They don't know what the community needs. So we need to challenge, Dr. Taylor suggested that we challenge the Buffalo Center of Health Equity to develop neighborhood plans and include in those neighborhood plans housing plans, and then pull other organizations to partner with that. And yeah, we talked about how Live Well, the housing task force has been very implementational and very influential during the COVID. I'm sorry, I'm way over time, but yeah, so we talked about all of that, and I have all these notes, and Matthew has all the notes as well, and yeah.
Thank you so much. Now I'd like to turn it over to Pastor Kinder Pointer, and following Pastor Pointer, Pastor George Nicholas.
Okay, thank you so much. First thing I want to do today, as we look towards wrapping up, is remind these incredible young people who happen to be women that that Pastor George, myself, Rita, and Kelly are looking for you all to come along to take the reins. We don't intend to do this work for the balance of our lives. We are encouraged by what we've seen today. So I want to make sure that we lift up Asha, Autumn, DeChantel, Nonye, and Tamara, because you all have done excellent work today. And you've made us sound like we're geniuses. Thank you so much. Also want to thank our friends at the National Institutes of Health, the National Institute for Clinical and Translational Sciences, for giving us financial support for this conference, or for conferences for the next 2 years. A special thank you to the workhorses who have made it possible for us to do the conference. That would be Rita Hubbard and Rita Hubbard and Rita Hubbard and Kelly and Kelly and Kelly. And you don't see her today on the screen, but Ebony Atwood, Ebony Atwood, Ebony Atwood. Also want to make sure that we lift up our friends and sponsors, Power 96.5 WFO, REACH CAI, the Clinical and Translational Science Institute at the University of Buffalo, as well as the University of Buffalo Community Health Equity Research Institute. And then partners who helped us get here include Millennium Collaborative Care, Erie County Medical Center Corporation, and our friends at United Healthcare. Today has been a seminal day in the work that we have set our hands to. Let me encourage you to understand that we need you to hold us accountable. So the first way for you to do that today is to be sure to fill out the survey. So they're going to put the link back up in case you missed it. please go fill out the survey. But the other way that we need you to make sure that we're accountable is to stay engaged so that you can remind us of the work that we have committed to doing and making sure that we do that work. I've got to give incredible thank yous to our 3 excellent presenters. This is our first, they tried to convince me this is our first regional conference, but this is actually our first national conference. So we want to thank Rear Admiral Richardae Araojo from the Food and Drug Administration Office of Minority Health and Minority Health Initiatives. We want to thank our own Dr. Alan Lesse from the Jacobs School of Medicine and Biomedical Sciences, and of course, the indomitable personality, the one and only Raul Vazquez, the president and CEO of G Health Enterprise. There are several additional events that we have already planned. So stay tuned so we can make sure you know about them, and we desperately need your participation. It is my privilege and honor at this point to introduce my fellow barn burner, my friend, my colleague in ministry, my brother from another mother, and my co-convener of the African American Health Equity Task Force, Pastor George F. Nicholas. Pastor Nicholas, take it away.
Thank you so much. Thank you, all of you who have spent this afternoon with us. Echo all the accolades that were given to the leadership team and the organizers that have worked so hard upon putting this event together. Angela Davis said, "I no longer accepting the things I cannot change. I'm changing the things I cannot accept." And we cannot accept these inequities that exist within our community. And we are organizing and working and developing a movement that will bring the change that we all deserve and that we all need. It's about leadership, it's about collaboration, it's about resources, and it's about results. So thank you again for spending your afternoon, your morning and afternoon with us. Please log on to buffalohealthequity.org. We will prepare a report of this conference. And so if there are things that which you have missed, we will provide very good notes and resources. And then there will be follow-ups within these work groups that we have. So you've been with us long enough. Thanks again. This has been a great collaboration with the community and with the university and with the Buffalo Center for Health Equity. God bless you all, and we will, you'll be hearing from us very soon.
Hi, this is Rita. I know I'm not on the program to say any final words, but I just must really want to thank these super students. I'm telling you what, I feel like I can retire right now, but I won't, I promise. Happy to mentor and encourage you all for your great work in this space. We really couldn't have done it without you, how professional you were in the chat rooms, even in your presentations. I mean, just a body of work you will be providing us with the notes that you've taken in your workshops. I just really want to just lift you up because this would not be a movement without you. It can't be a movement without you. So we encourage you to stay connected to the work of the Center for Health Equity and also with the professors that are leading in your departments and schools. Thank you so much.
Goodbye, everyone.
Bye, Kelly. See you later.
Thank you all for joining us.
God bless.
Bye, everyone. Thank you.
Goodbye.
Bye, everyone. Great day.
Here. Good job. Good job, everyone.
Thank you, everybody. Excellent.
Thank you. This was awesome.
Happy birthday again.
Happy birthday, Alan.
Thank you. Thank you.
And many more.
I should have had my champagne ready right now. That was a misstep. Enjoy your day.
Thank you. Take care. Enjoy it
too.
very much. Great way to spend a birthday.
All right, John boy, bye.
Bye, Elizabeth.
You guys are the best. Thank you all.
Thank you, Kelly. Great job.
Joe, are you able to grab the chat? Otherwise, I can.
I have the whole chat saved now, so I can email it over to you.
You're the best. Okay, I'm leaving then. Thank you all. Goodbye.
Thanks, Joe. Good work.
Thanks, guys. This is awesome.